Sir, we are live in 3, 2, 1. We are live now, sir.
Good morning all. Dear faculty and delegates, welcome you all for this CME on MSCA 2070, a new era of mental health care. Straightway, without losing any time, we will start with the inauguration function. I request Dr. Kumar sir to welcome all delegates and faculties and tell about the CME theme. Over to you, sir, for your kind words.
Good morning, everyone. I feel honored to welcome our Honorable Director, Madam Dr. Sadhna Taide, Dr. Gautam Saab, President SAC, Psychiatry Nations, Dr. Raju NN, President IPS, Dr. Nitin Dalaya, President IPS Maharashtra Branch, Dr. Arun Maravle, our beloved President of Western Zone of Maharashtra, Western Zone of IPS, under whose able leadership today's webinar is conducted. Dr. Bharat Sarode, President of Smart Group of Mental Health Awareness and Training Center of Pune, and all the people who are attending this session from mental health profession, my senior colleagues, and all attendees. To tell you honestly, every time I have gone through the script of Mental Health Care Act, it has given me new insights and understanding into it. We all know that the act is in place and it is here to stay. And hence, rather than beating around or beating down the act, let's look for options and evolve strategies, how we can face it and how we can cope up with it. Yes, part of it is difficult in view of the human context, particularly the infrastructure and the HR paucity, but we'll have to accept it within ourselves. Some budding issues will be there. How we solve those budding issues, how we handle and communicate with the administrators, how we communicate with our caregivers, our patients, and how we manage a mental health establishment so that we have put our patient at the center where we are giving full respect to his rights, which have been given to him by the Act. So, without much ado, I welcome once again everyone and hand over to Dr. Bhalchandra Kalmek for further proceedings.
Thank you, sir. Now I request Dr. Nitin Dalai, sir, President Indian Psychiatric Society Maharashtra State Branch, to say a few words about this CME.
Morning all. It's been a pleasure to be on this meeting. The Mental Health Act has been awaited since a very long time, and my experience is also the same. Now, how infrastructurally we are going to manage and how things are going to fall in place, but it's a reality that we need to be well educated, well aware, and as Dr. Bhalchandra has done a great job, and there are 700 delegates who have registered. So I think the gravity of the situation and the way changes which one needs to make is very, very clear and evident from the number of people who have attended it. I also have a similar experience when I read the Mental Health Act. And initially there was a lot of hue and cry, and the conference which we did in West Zone conference, which we did in Ambi Valley, we had called Dr. Pathare, and he explained it and made it simplified, and there were a lot of issues which he addressed very well. And we have Dr. Pathare today, so he will throw light on whatever queries and whatever questions people have. All the best, and let's welcome everybody for this meeting. Thank you. Conference. Thanks.
Yeah. Thank you, sir. Now I request Dr. Arun Maravle, sir, President Indian Psychiatric Society Western Zonal Branch, to say a few words about this CME.
Thank you, Bhalchandra. I welcome you all. Respected Honorable Minister of Health, Maharashtra State, Topeji, who is expected to join later. The Director of Health of Maharashtra State, Sadhnaji Tade Madam. Our beloved President, Dr. N.N. Raju Sir, National President. My good friend and presently President of SARC, Dr. Gautam Sahaji. My colleague, Dr. Dhananjay Ashturkar, and the rest team, Pawan Adatia and D'Souza, all EC members. Dr. Sanjay Ji Kumawat, who is key factor for this CME, all EC members. Our state president, Dr. Nitin Dalaya, Secretary Dr. Kalmeg and his team, the Smart Group, President Dr. Bharat Sarode, one who has attained the heights, gaining the Magsaysay Puraskar, Dr. Bharatji Watwani, many senior members who have joined, and dear delegates. As many people will be talking on Mental Health Care Act 17, I won't talk on that. Through Dr. Sanjay Ji Kumawat, who happened to be Director of Mental Health, State Government of Maharashtra, and Sadhna Ji Tade. And if Rajesh Ji join, I put some issues related to our mental health, particularly which are very essential for patient care and patient benefit. The first issue I want to put before all of you, particularly the administration, is medical insurance. So both life insurance, particularly say a person who attempts suicide, completes it, won't get insurance. So just like other medical illnesses, say for example, cardiac failure is there, or stroke is there, leading to some complications and death. So suicide is one of the complications of many psychiatric illnesses, particularly depression. So why they don't consider suicide even for insurance? So life insurance should be given to all our mentally ill people. That is my demand on this platform. Secondly, Mediclaim. Most of the companies deny Mediclaim to our mentally ill people, which is that way injustice. And I hope our administration and our national body will take care of this issue and make justice to our poor mentally ill patients. Second thing which I would like to put forward is disability certification. So there are many benefits which are offered by the government. They are in books only, or they are only rules. Practical implications are that way very rare. The difficulties start right from beginning, that is certification itself, because most of the medical colleges, most of the civil hospitals don't have clinical psychologists. So at least whoever is available, they can appoint at least on contract basis, so that they can certify, they can evaluate disability, so that our psychiatrist fellows can certify it at the district level itself, civil hospital level itself, so that our patients will be benefited, certainly, I'm sure. And I hope Sadhna Ji Tade ma'am, Sanjay Ji Kumawat, with the help of our Honorable Minister, will take care of this, will circulate circulars to all civil hospitals and medical colleges, so that this process of disability certification will be hastened, including the travel concession. Because one of my senior colleagues, Dr. Vinay Barale, he requested the Commissioner of ST, state transport that time, and he availed the travel concessions to most of the mentally ill people. So being psychiatric illnesses, being disabling illnesses, and many times they need an escort to come with them. So travel concession should be granted. It is there, but not executed. So I request the administration to look in this matter and get this thing done. The fourth thing which I would like to comment is stigma reduction. For stigma reduction, we can take help of the social media. That we are doing. There are some committees with us. They are doing well. But here, my request would be something different. One of my honorable teachers, Dr. Mohan Agashe, spent his whatever pension he got on production of movies, which spread awareness of mental illness in society. The films like Caso and two more films are there, which talk about problems of dementia, problems of depression, and how people react to that, how the patient has so many troubles. So I mean to say, if the state government exempts the tax, I think they are tax exempted, but screens it quite often on TV, at least the state TV, all three states, I request the health minister of all three states. So if they can do this screening, that definitely would help our population. Similarly, just like what Vani sir, let our fellow colleagues come forward and take care of the mentally ill people. I would like to say there are some rehabs like Nitin is doing good work, our Amar Shinde is doing good work. So hope the rest will also come forward and help these mentally ill people. So Sadhna ji madam, so with help of yourself, I expect all these problems solved. So thank you once again. Thank you for the opportunity given by my friend Dr. Kalmeg, and wish this CME to be very successful. The number of the delegates joined is more than 700. That it itself talks about the enthusiasm we people have in this act and clarification of the facts. So without taking much time, I would like to stop here. Jai Hind, Jai Maharashtra, Jai IPS. Thank you.
Yeah, thank you, sir. Now I request Dr. Jan'22 sir, President Indian Psychiatric Society, to give his blessing for the CME.
Thank you, Dr. Balchandra Kalmeg and President of West Zone, Dr. Arun Marwale, the chief guests of today, Madam, and I think the Health Minister Mahoday will join Dr. Director Dr. Tayade Madam and the rest of my good friends, Dr. Gautam Shah, Dr. Kumawat, many more. I think I can't name. I think so. Basically, I think it's a great curtain raiser for my tenure. Talking about the Mental Health Act, new era, because we all know, as Dr. Sanjay Kumawat said, the Mental Health Act is here to stay with us, and it's a law. We need to follow that, and unfortunately, most of the states, from the government point of view, have not fulfilled the obligations, the constitutional obligations the Mental Health Care Act has given. So I think that is where perhaps the societies, both at the central level, national level, Indian Psychiatric Society, and the zonal levels, and the state and local state levels should work to see to it that everything is in place. So far, not many places, not many states have even the review boards, mental health authorities. So all these things ought to be considered now. And also there is, if somebody is, there is a case filed in the High Court, and also High Court has given a direction. The Chief Executive Officer, I think so far most of the states have appointed one of the deputy secretaries or directors of mental health, or sorry, directors of medical education, or somebody as the in charge chief executive officer of this state mental health authorities. Perhaps they, I think the High Court gives a direction that where they need to have the qualification in psychiatry. Perhaps we need to look into that judgment also. I haven't seen the judgment fully, but that is the report which I had seen in media. So perhaps we have to go through that judgment and see, because once a High Court gives an order, I think that is the order for the entire country to follow. So most probably, once we go through that order, perhaps that can be communicated to each state branch, who themselves can coordinate with the directors of either mental health services or directors of health services or directors of health education, whoever is in charge of this state mental health authority. Perhaps they can coordinate with them and see to it that the Mental Health Care Act is properly, in the first place, the government itself forms all the required obligations required by as under Mental Health Care Act, and see to it that they are implemented to the best maximum possible. We all know that, as Dr. Sanjay has repeatedly said, there are certain areas which are very difficult to follow, because the problem is that health is also a state subject, and there are certain obligations created by the Mental Health Care Act. The needs, the financial needs, the budgets, everything have to be kept in mind. But whatever that should be followed, I think the Indian Psychiatric Society have the responsibility to coordinate with the central government and also with the state governments to see to it that what best we can do it. And I hope the zones, the zonal presidents and secretaries, and the state presidents and secretaries do come, all of us come together and divide the work and see what best we can do about it. And at the end of the day, what best we can do for the upliftment of the mental health in the society. True, at one hand, we have the interest of the patients, interest of the mental health in general, but also we have to keep in mind the professional interests, because what best they implement that without any hassles. I think the law should not be in such a way that we try to circumvent it just because we cannot implement it. I think if we have problems, we need to bring them to the notice of the governments to see to it that if required, maybe a few amendments also can be recommended. It is a long process, it is a long journey, but we need to consider all that in mind and do it. I hope we will try to do whatever best we have and whatever time we have within time frame, and hopefully we will try to implement, bring it to the notice of the concerned authorities. Also, I'm happy that Dr. Arun Marwale, the president of West Zone, has brought out a lot of issues which are really important, and perhaps we will take the help of the people who have some expertise, some influence in converting them into realities. I once again thank the organizers for giving me this opportunity and wish this program a success. Thank you so much.
Thank you, sir. Now I request Dr. Gautam Shah, sir, immediate past president of Indian Psychiatric Society and the present president of SARC Psychiatric Federation, for his blessing for the CME.
Thank you. Thank you so much. At the outset, I must congratulate the organizing committee led by Dr. Sanjay Kamath, Dr. Balchandra Kalmeg, one of the most active members of the Indian Psychiatric Society, Dr. Bhushan Matre, and Dr. Devarat Harshe. And also, I want to show my regards to this chief guest, Sri Dr. Rajesh Top Saheb, the Honorary Health Minister of Government of Maharashtra, Dr. Sadhna Kaide, Director of Health Service, Government of Maharashtra, and also our President of Indian Psychiatric Society, Dr. N.N. Raju, and Dr. Nitin Dala, the IPS Maharashtra State Branch President, Dr. Arun Marel, the President of Western Indian Psychiatric Society, and all the members present here, they're my senior colleagues and also my friends, those who are present here. I have seen that Dr. Dhananjay also there, the secretary of the IPS Ocean State Branch, and the senior members like Dr. Bharat Sarode, Dr. Deepak Kalkar, and also Dr. Henal Shah, and all, Dr. Bharat Vadwani, and all the senior people, those who are, because it is one of the most important. You know that Indian Psychiatric Society is always working on this. And in fact, a future, before implementing this Mental Health Care Act 2017, we also have, under the presidency of Dr. G. Prasad Rao, then I was the General Secretary. We have a meeting of all senior colleagues at New Delhi regarding this. Dr. Nimesh Desai was there also. I think we planned, Dr. M.S. V.K. Raju was there. And according to that, we met to the Health Secretary, Dr. I think I just forgot the name, and also the Health Minister, Dr. Nadda. All the three past president and me met there. And our talk, we talked regarding, there is a positive point definitely regarding, as Dr. Marwale also mentioned, that in this insurance sector, at least they included that. And also the decriminalization of the suicide is one of the most important positive point of the Mental Health Act. But there are lots of issues regarding GSPU, regarding the ECT, regarding the advance directive, regarding nominative representative. There are lots of issues we have pointed out. But I think today we have a great speakers, great faculty list. We want to listen to them. Actually, we are running short of time. We see that this inauguration supposed to so I'm not taking very much sure that there are lots of insight. It is not implemented in the different states, but they implemented. What is the shortfall, financial or any other reason? We have to take care. And if there is any changes, we definitely should go for that. Thank you so much. Thank you everybody again. My regards to senior and love to all my junior friends and my all friends. Thank you so much.
Yeah, thank you so much, sir. Now I request Dr. Sadhna Tade, madam, our guest of honor, Director Health Services, to put her thoughts and to inaugurate the CME. Sadhna, madam, over to you.
Yeah, good morning, everyone. Thank you, Dr. Karmek, all the dignitaries who are present here. I think the Health Minister of Government of Maharashtra, Rajesh Tope sir, he is yet to join, and I think he will be joining shortly for this program. Dr. Sanjay Kumawat, Maharashtra State President, Maharashtra State Branch. Dr. Nitin Dalaya, President, Indian Psychiatric Society, Maharashtra State Branch. Dr. Arun Maravale, who is the President of Indian Psychiatric Society, Western Zonal Branch. Dr. N. Raju, President, Indian Psychiatric Society. Dr. Gautam Saha, President, SAC Secretary. All the dignitaries and the participants who joined this conference, I welcome you all for this grand conference. At the outset, let me thank Dr. Kumawat and all the organizers of this conference for arranging this conference on such a sensitive topic of Maharashtra Mental Health Act 2017. I agree to all the speakers who have said, just who have talked before me. And definitely there is lot many things we have to do in Mental Health Care Act. It is just not possible to implement each and every word in the act. It's really very difficult. There are so many constraints we are facing. Therefore, as a psychiatry union or as a psychiatrist, all of you, we need your help and we need your suggestions. Your suggestions will be always welcome to improve this implementation of this act in Maharashtra. And I hope that today's conference will give us a good suggestions. Thank you very much once again. Mental Health Care Act 2017, as you all know that, it emphasizes the rights of mentally ill patients. It preamble states that it is an act to provide for mental health care and services for persons with mental illness and to protect, promote, and fulfill the rights of such person during delivery of mental health care and services, and for that matter, connected therewith or incidentally thereto. Mental Health Care Act, it discriminalizes the attempts to commit suicide and prohibits inhuman forms of treatment. It also empowers persons with mental illness. As you all know that, apart from many provisions of Mental Health Care Act, the few which are very important uh, notifications that we have started implementing in Maharashtra. For example, the state mental health authority is already formed in Maharashtra, and now the first turn of state mental health authority is already over, and we are now advertising the second turn or the second round of mental health state mental health act authority. All the members, we are going to, whosoever the non-governmental NGOs, we are going to give the advertisement for them very soon. Then what we have done is that the rehabilitation of the mentally ill patient through halfway home. Almost, let me tell you that more than 200 patients from our mental health institutions, they are rehabilitated with the help of NGOs, and they are uh, uh, with the help of these NGOs, they are taking care of them. The second thing is that Maharashtra has four good mental health institutions, and moreover, we are developed two more institutions. One is in rural part of Maharashtra, that is in Ambezukai, and one we are going to develop in Jalna. So these, with the help of these mental health institutions, we are catering to more than 5,600 patients yearly in government of Maharashtra hospitals. The concerns of our this government is that we are not getting psychiatrists. The district mental health program is already implemented in 34 districts of Maharashtra. It's going on. Few districts like Hingoli or Bhandara, these are the districts where we are not getting Satara to that matter, such a good city, but still we are not getting psychiatrists there. So these are the constraints which we are facing by government. The second thing, what uh, uh, s- Dr. Danaya said here is that the life insurance for these mentally ill patient. I think all these queries will take up later on. But right now, I wanted to address few of them, which many speakers they have asked here. The first is that the life insurance for the mentally ill patients. So let me tell you that the whatever the this Prime Minister uh, uh, Mahatma Phule Jyotiba Mahatma Jyotiba Phule Yojana is going on in Maharashtra. Through that Yojana, we are already included mental illnesses in that procedures. So whatever the 1200 procedures we are giving insurance, one of them is mental illness. So it has already come, and slowly I think more and more procedures will come into it. Then the clinical psychologist or to issue certificates to the mentally ill patients. So definitely there is shortage of clinical psychologists. I do agree with that. Moreover, there are some government rules, regulations are there, and therefore we are not able to fill up these posts. But still, let me tell you that out of 34 district mental health authorities, or district mental health program, we have almost 24 clinical psychologists in all of our districts. Though they are not attached to medical colleges, but they are working with us in district mental health program. So definitely the certificates we are issuing to them. And I think this travel concession and the other concessions which we are supposed to give to the mentally ill patients, I think you will see some progress in that. The IC and the stigma part, that is all that is very strong for the mentally ill patients. And for that, let me tell you that constantly in our meetings, all our reviews, everywhere we are stressing this point. And this year, what is our mandate is that to reduce this stigma, we are taking these OPDs, mentally ill OPD for the mentally ill patients to all our PSCs. And we told them that each and every primary health center of Maharashtra should give services to this mentally ill patient. In Maharashtra, right now, 1,864 primary health centers are uh, there. They are scattered in all over in the rural part of Maharashtra. And let me tell you that out of them, almost 300 primary health center has already started giving services. From since last 2 years, the health and wellness clinics are started in Maharashtra. And all the sub-centers, almost 10,600 sub-centers are there. And these sub-centers and all the PSCs, they are converted into health and wellness clinic. And there, one BMS doctor or one nurse practitioner is appointed as a medical officer, and they are given a training of mental, they are given a training of these mental illness. They are supposed to provide the services of 13 services through these sub-centers. And one of these 13 services is mental health care. So in rural Maharashtra, the mental health has reached up to sub-center level, up to village level. Maharashtra is one of the state, and I think Dr. Kumawat was with us during that time. We have implemented a Prerna Prakalpa program for preventing the suicide of farmers. So that is also going on in Maharashtra in 14 districts. So all these things we are already implemented in Maharashtra. Recently, the 8 review boards are also started in Maharashtra, and they are at 8 circles. That is, they are situated, these mental health review board. They are at Thane, Pune, then Nasik. These are the big cities or the revenue divisions of Maharashtra. And then Nagpur, there is one. Aurangabad, there is one. Latur, we have one. So all these 8 mental health review boards are already established in Maharashtra, and very shortly we will be able to give services to this mental health review board. There is one again constraint here, that somebody said that funds, really it's a problem for Maharashtra government. And though it is a state program, health is a state program, but there are some front crunch for this, and we are trying very hard for this. So I think through these review boards, we will be able to give services more fast to this, and we can uh, save the rights of mental ill patients. So that is one thing. The second thing, with the help of Dr. Pathare, we have already completed our online training. Because of Corona, we have to give online training, and we have completed the training of this mental health act to all our psychiatrists who are working with us, then clinical psychologists, the psychiatrist, social worker. So the government people, the police people, the judiciary people, we have already completed the training of these. And this year also, we will be continuing the partnership with Dr. Pathare, and I hope that this year we can start training of some private practitioners. And for that, definitely we need the help of Psychiatrist Society. So once again, I thank you all for arranging such a wonderful conference, such a sensitive topic. And I congratulate all the organizers of this conference. I hope that from this conference, some good suggestions will come, and they will help government to implement the program or this mental health act smoothly in Maharashtra. Thank you all.
Thank you, madam. Uh, Thank you for your kind words. I assure that Indian Psychiatric Society, Maharashtra branch and national branch will be there and will work hand in hand with the all state governments. And thank you once again for taking cognizance for all our concerns. Now, as we know that Rajesh Tope Sahib is unable to join because of his commitment and busy schedule. So I request Sadhna Tade madam to announce that this CME is open for inauguration.
Thank you, Balchar.
Please
And
announce, madam,
I
that
announced
CME
that this CME, I announced that this CME is open for it.
yeah.
In person.
Thank you, madam. Thank you all delegates,
Thank you.
faculties and dignitaries on the dais for joining on this virtual platform. So without losing any time, we will straightforward, we'll start with the academic session. Before that, there are some instructions for all the delegates. Logging to all session is compulsory for MMC purpose. Feedback form is also compulsory for MMC purpose. And we have kept prizes for best questions that you need to ask on the chat box. There will be 2 best questions and which will be judged by Dr. Kumaut sir and the chairperson. So stay tuned with us for the whole day. This is Marathon CME. So we will go ahead with the first session of the CME. Chairperson for this first session is Dr. Bharat Watwani sir, senior psychiatrist from Mumbai. I think Dr. Watwani sir don't need any introduction. Bhushan, please run his slide. First slide. Yeah. So I will not waste any time in his introduction. He is the Bharat Watwani sir, great psychiatrist from Mumbai, Raman Magsaysay Award winner in 2018. So I will hand over the session to Bharat Watwani sir for the further proceedings. Watwani sir, over to you.
Yeah, thank you very much. Can I have the CV of Dr. Pathare?
Yeah. Yes.
Yeah, I'll quickly introduce. This is Dr. Soumitra Pathare. Everybody knows him very well. He's a consultant psychiatrist and director of Center for Mental Health Law and Policy at the Indian Law School, Pune. His primary interests are in the areas of mental health policy, scaling up mental health services, right-based care and legislation. He's the chief in drafting India's new Mental Health Care Act. I'll go quickly over this. He has served as a WHO consultant in many low and middle income countries. This is excellent. Botswana, Seychelles, Lesotho, Samoa, Vanuatu, and Eritrea, assisting them in drafting and implementing mental health legislation. He was the principal investigator of Quality Rights Gujarat project, which implemented the WHO Quality Rights program in 6 public mental health facilities in Gujarat. He is project director of Spirit Hub, and he's currently involved in scaling up Atmiyata across Mehsana district, Gujarat, with a population of 1 million. Atmiyata is a project to improve access to mental health services in rural areas. This is a simply outstanding CV, and I don't think we should waste any time and let him take the floor. Please, Soumitra, go right ahead.
Thank you, sir. Thank you, sir, for your kind words. And I would just like to start by thanking all the organizers for inviting me to this session. Sir, I know we are running a bit late, and I just presume that maybe for this session we still do have the 1 hour between Kaustubh and us. So I had a chat with Kaustubh earlier. What we will try and do is probably do 20-25-minute presentations and then leave the remaining 15 minutes to answer some of the questions which have already been asked by the delegates and sent to us. I hope that is okay with you as a way of dividing up the time for the session.
Absolutely okay. Absolutely okay.
Okay, sir. Thank you. Before, what I thought was I was told to talk about the philosophy of this act and philosophy behind what went into it. So I decided to do something which probably will help people's understanding a little bit more about what came about in the act. So I have chosen to speak about the Convention on the Rights of Persons with Disabilities. The reason to speak about the CRPD is 2 reasons. One is the whole process of drafting and creating this new act really started because India ratified the Convention on the Rights of Persons with Disabilities. You see, all of this would have not even happened if India had not ratified this convention. So I think it's important for us to know that the fountainhead from where this whole process started, in a sense. And secondly, people also have very little understanding of the CRPD. It's not something that keeps on being brought up at CMEs or at medical meetings. So I thought I'll kind of give you a very broad helicopter view of the CRPD and what it is about. It's also something different to what you would normally hear from in many of these meetings. So the CRPD is basically a United Nations convention which India ratified the minute that it was open for ratification. In 2007, India was among the first few countries to ratify it. And you have to understand that the convention really supersedes all other human rights instruments which are related to mental health. So, for example, the previous one, which was called the MI Principles, the United Nations Principles for Protection of Persons with Mental Illness, the CRPD overrides all of that. So first of all, why do we have a separate convention for people with disabilities? And you'll see the CRPD makes that very clear right at the beginning. That although we've had various UN human rights conventions, very often people with disabilities have got forgotten out of it. So this has been a tradition now in the international, internationally since about the 80s. If you remember, the first of such conventions, which was focused on a specific vulnerable group, was CEDAW, which was Convention on Elimination of Discrimination Against Women, because they said although we had all of these protections, women were being left out. After CEDAW, we also had the Convention on the Rights of Children, the CRC, because there was a feeling that children were being forgotten. And then this is followed by the Convention on Elimination of Racial Discrimination, because of the feeling that people with race do not enjoy all their rights. And then we have had the one on disabilities. And there's already a talk about a convention on protecting the rights of older people. And there's some work which is already happening on it. The most important thing to understand is that the CRPD does not create any new rights. So the disabled people are not getting more rights than what you and I have. But what the CRPD is really focused on is ensuring that they get all the rights that you and I have. And that they are not denied the rights merely because they have any kind of disability. 10% of the world's population lives with some kind of disability. In fact, it's called the world's largest minority. And about 80% of these people with disabilities live in developing countries. So as of today, I mean, this is something I just checked out yesterday. How many countries have ratified the CRPD? And nearly everyone has ratified. The ratifications are standing at 184. There are 196 UN member states. So there's about 12 countries left which haven't ratified the CRPD. And what are the key things that the CRPD? These are things that you probably need to slightly understand. These are the three key factors that the CRPD is trying to bring in terms of a paradigm shift. Everyone says paradigm shift. So what are these paradigm shifts? What the CRPD wants us to do, and wants everyone across the world to do, is to stop seeing people with disability as objects of charity, people for whom you do charity, but to see as subjects with rights. To shift from a paternalism that exists around disability towards a respect for human rights, and to stop seeing people with disability as a burden on society, but to start seeing them as active members who can actually contribute to society. And these are the three key things that, if you want to understand what the CRPD is trying to do and understand the process in which it is trying to do, then this is really the shift that the CRPD is trying to bring about. I always get asked who's covered under the CRPD, and it's important to just remember what the CRPD says. The word in this definition, which is very important, is it says persons with disabilities include those who have long-term physical, mental, intellectual, or sensory impairments. The word include, and this has been clarified by the CRPD committee, include does not mean anyone's been excluded. The word include is used to emphasize some people who within that group might otherwise get forgotten. So when it says persons with disabilities include, it does not exclude people with short-term physical and mental or intellectual or sensory impairments. And that is very important to understand. Again, as you will see, this is not a definition. This is actually a non-definition. It doesn't say who is a person with disabilities. It says it includes that. And it goes on further to say which in interaction with various barriers may hinder their full and effective participation on an equal basis with others. And I think you need to understand all of these words which I've highlighted in different colors, because that is where the real emphasis is. It's about interaction with barriers, it's about full and effective participation, and it's on an equal basis with others. Now, these are all the things that the CRPD attempts to do through its process and what the CRPD expects countries to do through the process. The first problem that many clinicians actually face is that the model of disability that is being used by the CRPD. We've all, as medical professionals, been brought in with what is called as a medical model of disability. So what is the medical model of disability? The medical model of disability, to put it very shortly, identifies that the shortcoming or the problem lies within the individual. So that, you have some, if you're blind, it's because you got a problem with your eyes. If you cannot walk, then you got some problems with your feet or with your locomotor system. So it identifies the person or the individual as the focus of where the disability exists. And that has always been the medical model. So there's always the talk of the individual is impaired, and that is what is causing the disability. Now, this is something that we've all grown up with as medical doctors, as clinicians. This is the model that we've all used. This has been the dominant model of understanding disability. The CRPD uses a very different model of disability, and I think it's very important to understand this model, to understand what everything then flows from it. The social model of disability actually says the problem is not in the individual. The problem lies outside of the individual. Disability is not because of deficits in the individual. Disability is because of the person having some impairments, but there are there are barriers, and these barriers are of two types. There are either environmental barriers or there are attitudinal barriers which cause disability. So what does this mean in practice? What it means in practice is what a person using a social model of disability will say is that a person on a wheelchair is not disabled because they cannot walk. A person on the wheelchair is disabled and cannot participate in society because you haven't created an environment where his wheelchair can go everywhere. So the disability is not caused. So the person has an impairment, but the disability has been caused by society. And the way to get rid of the disability is by ensuring that his or her wheelchair has access everywhere. A person who's blind is not blind because they cannot see. A person who's blind is disabled because you haven't created enabling environment, which means you do not have a braille everywhere. You haven't created accessible ways of getting information. And the disability would be removed if you made everything accessible to people who have a visual impairment. And in the case of mental illness, it is not environment which is an issue, because environment is not really a barrier for people with mental health problems, but it is attitudinal barriers. The attitudes of society towards people with mental health problems is what acts as a barrier and disables them. So the social model of disability is much more broader than the medical model. And so the CRPD goes on to say that disability is a social construct. So they say that disability is not in the individual, it's something that has been caused by, and as I explained why it says social model is, it results from an interaction between the person with impairment and attitudinal and environmental barriers that hinder their full and effective participation in society on an equal basis with others. So you see, they see disability as an evolving concept and as a social construct and not as a medical construct. And I think it's very important to actually understand the point from where CRPD is coming from. So the CRPD comes from a social model of disability perspective, and that is what you need to keep in mind when you're trying to read and understand what the CRPD says. And again, the purpose of the CRPD is very clear: to promote, protect, and ensure full enjoyment of all human rights by all persons with disabilities, and to promote respect for their inherent dignity. The other important point to remember is that the CRPD is also a tool for development. It emphasizes that majority of people with disabilities live in conditions of poverty, and hence the critical need to address the negative impact on poverty on persons with disabilities. So, there is a lot of focus on education, work, employment, to try and remove the barriers that prevent people from getting out of poverty. And then there are some obligations on governments, and this is what every government which has ratified the CRPD, and India has ratified the CRPD, has these levels of obligations. Obviously, the first obligation is to respect. So governments, which is states, must refrain from interfering with the rights of persons with disabilities. The second, which is the important one, is to protect. So states have to take action to prevent what are called non-state actors. That's the technical term that is used. What it means is private parties, really, or people who are not government agents, from interfering with the rights of persons with disabilities. And finally, to fulfill, which means that the state should adopt legislative, administrative, budgetary, judicial, and other measures towards full realization of rights of persons with disabilities. So, there are three roles that governments have. One is to respect, protect, and fulfill. And you need to understand how the government's actions in terms of the law actually fit into these three, which is to respect, protect, and to fulfill these rights. I'm not going to go into the structure of the CRPD and all of that. I think some of the key principles also I'm not going to go into. I wanted to talk about some of these specific articles of the CRPD, which have always been very controversial. Article 12, which talks about equal recognition before the law. So what is Article 12? Article 12 really talks is about personhood. It says that people with disabilities should be recognized as persons before the law. Now, that's a simple sentence, but what it means in real life is that it really means that guardianship provisions need to be abolished. So it has important implications, not only for mental health, but also for other guardianship laws in countries. And the purpose of Article 12 is to shift away from a model of substitute decision-making to a model of supported decision-making. And I'll tell you what I mean by substitute and supported. Substitute decision-making means that someone else decides on your behalf. Commonly happens in the case of children. Okay, when children below the age of 18, there is substitute decision-making, which means parents decide for them. Supported decision-making is something where you're saying, we understand you have difficulty in understanding things, but let us provide you with advice. However, whatever you decide will still be your decision finally. And whether it is for right or for wrong, it's still your decision. We will provide you with support, advice, guidance, but ultimately you make the decision. The example that I always use to try and explain this is let's take the matter of financial investments. I don't know about many of you, but I do know that I'm not particularly good with financial investments. I don't understand how they work. So I might go to a financial advisor. I'll go to a financial advisor and say, look, I want to invest my money. Tell me where to put it. And the investment advisor will give you lots of advice. But at the end of the day, where to put your money and what you should do with your money is decision that you make yourself. You might choose the wrong things. The advisor might feel this is a terrible decision to put your money into this company. You will go bankrupt. But still, you have the right to make that mistake, and you have the right to put your money where you want it because it is your money. So that's an example of what is called as supported decision making, which is that you have the right to ultimately make a decision. Somebody provides you with support to make that decision, and you might make a wrong decision, but that is still your decision. And the CRPD would like us to move to the supported decision making model for people with disabilities, so that people with disabilities are given information in a simple way, are given options, are offered choices, But at the end of the day, they make their decisions, and they basically have the right to make those decisions, and somebody should not be deciding what's best for them. Article 14 of the CRPD again talks about they should not be deprived of their liberty unlawfully or arbitrarily, and that the existence of a disability shall in no way justify the deprivation of disability. Now, this clearly impacts upon involuntary admission and treatment in mental health facilities. So if you do a letter reading of the act, letter reading of the CRP against their wishes. If they do not wish to be there, then they can only be kept in a hospital with their consent. Now, clearly, this has important implications for mental health law. What does it mean? How does it work? Does that mean anyone with mental health problems can never be kept in a hospital, even if they are not able to consent? Or does it mean that when they are not able to consent, you can do it? So these are things around where a lot of discussion and debate happens around the CRPD and its implementation across the world. These are articles which I think every one of us would be very happy to promote, and I don't think there'll usually be any kind of argument. One is in Article 15, it says freedom from torture, cruel, inhuman, degrading treatment. The question is, what is the definition of torture or cruel or inhuman or degrading treatment? And it says no one must be subjected to medical or scientific experimentation without his or her free consent. Now, again, you can see there is a problem with this because it has no exception. It doesn't say except when they are not able to consent. It says no one must be subjected to medical or scientific experimentation without his or her free consent. And that has been interpreted by many disability activists to mean that without consent, nobody can ever be included in any kind of medical experimentation. You can see there are problems with taking a literal approach to it. The reason I'm telling you some of these is many of these issues have been dealt with in the Mental Health Care Act. And you will see that there is an attempt to stay true to these articles while also recognizing the reality that there will be times when some people may not be able to consent. And if you're not able to do any kind of research, then you will not make any progress. Let's take dementia, for example. If you said people with dementia cannot be included in any experimentation without their consent. Now, people with dementia, especially advanced dementia, may never be able to consent. And there's no likelihood they'll be able to consent, in which case no research will happen, in which case you're not going to help people with dementia. So clearly there is a need to kind of interpret that to be able to do that. Article 19 of the convention talks about right to live independently and be included in the community. And again, this really promotes the closing down of psychiatric institutions and the development of community-based services. Again, the Mental Health Care Act has provisions, and in the Mental Health Care Act, Article 19 is effectively Section 19 of the Mental Health Care Act. And then this is the most positive rights that are included in the CRPD, the right to enjoyment of highest attainable standard of physical and mental health care, which really is like a right to mental health care. And you see this article has translated itself into the Mental Health Care Act in terms of the right to access mental health care services. And that is already in the act. And if you read this versus if you read what is in the Mental Health Care Act, then you'll see that what the Mental Health Care Act does is try to convert some of these principles of Article 25 into practical activities that the government needs to do in our country. So what happens, how is the CRPD monitored? There's an international body called the Committee on the Rights of Persons with Disabilities, which monitors the implementation of CRPD. How do they do that? Every country regularly submits a report to the committee on how the rights are being implemented. And then the committee examines the reports and makes recommendations. And the committee also provides guidance on the interpretation of the CRPD. As you'll probably be aware, India was examined. It's called, that's the word they use. India was examined by the CRPD committee, and in October 2019, they produced some concluding observations on the initial report that India had produced to the CRPD. You can go and read it. It's a long report. It identifies areas within law and policy which need to be affected. In many ways, it still wants more changes to be done to the mental health in terms of what the Mental Health Care Act has done, and wants the Mental Health Care Act to go even further than when it has gone. I don't have time and I won't get into details of it. But basically, there is a process that our country follows by ratifying the convention. And this is the kind of end point, in a sense, where at the end you go and report, and then every 5 years you will be reporting. So now what will happen is, after 2019, India's turn to report might come after another 5-6 years, when we will again report. And at that time, India will have to say, okay, all of the things that the committee suggested last time, what have we done about it? And that is how it will go. I'm going to quickly end here by just showing you one slide. What the committee is, what the CRPD is trying to do is to shift us from what has always been seen as a equality argument to a more equity argument. A lot of our previous international conventions have got interpreted in this equality argument. And what the CRPD wants you to do is to move to this kind of a position, where if this is the person with disability, then you need to provide certain kind of supports and accommodation for everyone to be able to participate fully in life, which is going out here on this pitch. And that is really the broad philosophical thrust of what the CRPD is trying to do. I think I've used up all of my time. I'm going to stop here. I know there are some comments on the chat box, and I think what we'll do is, after Dr. Kaustubh Zog has finished his presentation, we will take up some of the questions. Thank you so much once again for the opportunity, and I'm happy to answer questions at the end of it. Thank you, sir.
Yeah, that was a great session. There was a lot of queries in my mind also, but time is short, so we'll take it up later on. Let's move on first to Kaustubh Zog. Let me introduce him. He is a part of the Center for Mental Health, Law and Policy. He works as a senior research fellow. He's also completed his training from INHS Ashwini, and he's a project co-lead for large-scale community-led intervention called Atmiyata, which already Dr. Pathare is involved with. And additionally, Kaustubh coordinates the Center's International Diploma in Mental Health, Law and Human Rights. So basically, they are like a conjoint team. So let's get on with what Kaustubh has to say. Let's hear him out, and then we'll take the questions.
Thank you, sir. Thank you very much. Good morning to all. Thank you for introducing. Thank you initially for organizers who invited me. Thank you, Bhalchandra. I think what I'll do is, after Dr. Pathare's talk, my job, or what I've been told, is basically largely to talk about MHCA, Mental Health Care Act 2017, and give an overview. Obviously, it's very difficult to give an overview in short time. What I'm going to stick to is, as Dr. Pathare has explained about CRPD and the different articles and different ethos and philosophy behind CRPD. I think MHCA lays down on the same foundation. MHCA lays down the instruments or the procedures which are there so that the rights of people with mental illnesses are protected and promoted. So these are some of the guiding principles of the MHCA. All persons are invested with basic human rights. I think that's clear, as we heard with Dr. Pathare about CRPD. Then autonomy as well as the right to full participation and inclusion in society has been already been talked about. So autonomy and free will is the cornerstone or a principle of MHCA. and then the capacity of persons with mental illness. There is a paradigm shift about the understanding of capacity, as again Article 12 of UNCRPD talks about. I will talk about capacity a bit more. Supported decision making, again, as CRPD mentioned, is an integral part of the right to exercise one's capacity. And as I said, the principle is also to ensure that the will and preferences of persons with mental illness, kind of respected in all situations. So ultimately, what I feel is MHCA places the person with mental illness at the center of the mental health care system, and that's, I think, the kind of a foundation of this act or of this legislation. Now, what I'm going to do is just to highlight few of the components of MHCA, or what we can say few of the instruments of MHCA. Through these instruments, through the procedures and next rules and regulations, how do we exactly, kind of promote and protect, as I said, the rights of people with mental illnesses. Talking about capacity, we all know, I'm not going to, kind of waste more time, but basically capacity refers to one's ability to make decisions regarding, in MHCA, this capacity mentions or capacity is related only to mental health care and treatment. The other fundamental principle is all persons are presumed to have capacity. So all persons with mental illnesses are presumed to have capacity unless and until, it is lost in certain point of time. Capacity with regarding to making decisions in other matters, and this is the difference from the old Mental Health Act 1987, is all other matters of property, marriage, contracts, that capacity is completely different and it is not covered under the MHCA. The another important thing, I think, from a clinician's point of view, as well as from mental health professionals, mental illness is not the same as capacity. So there is two different entities or two different things, and there are different assessments for both of these things. Then capacity of person to make decisions regarding, again, their mental health care and treatment means, so these are the guidelines given in the law, how the capacity needs to be assessed. And as we know, I'll just explain that the assessment, how to make assessment for professional, there are now guidelines which are open by the expert committee. These are the three factors in this assessment: that the person understands the information regarding the decision on treatment, care, admission, and so on. Then appreciate that any foreseeable consequences of decision or lack of decision regarding that, and communicate the decision by means of speech, expression, and gesture. So that communication is an important part of assessing the capacity. And as we know already, have been spoken about supported decision making. So again, earlier MHA was talking about substituted decision making, which is now, or a guardianship, which is now converted into a supported decision making, is a right or progressive instrument to respect one's capacity or execute if people do not have a capacity. These are some of the responsibilities of MHPs or mental health professionals. Again, these are same, basically documenting and recording. There has to be a continuous assessment of capacity. Again, there are procedures which are laid down into the law, that how frequently as a clinician you should be assessing the capacity. Informed consent, the procedure to inform consent, documenting informed consent are important part. And lastly, as I said, there are guidelines for assessing capacity, which has been now published by expert committee appointed by the Central Mental Health Authority. So moving ahead, the next two instruments I just try to highlight are the Advance Directive and Nominated Representative. Basically, nominated representative is largely or directly related to, kind of exercise the supported decision making. But first, we will touch upon the Advance Directive. Again, most of you now, after almost 4 years of law, know about Advance Directive or have heard this term. Largely, the Advance Directive is a written declaration of how a person would like to be treated in the event that they cannot take decisions for their own mental health care and treatment. So again, it's, kind of a clear what is Advance Directive is. Now, these are the conditions or what person can do or write in their own Advance Directive is the form of treatment or care they want, and also what they don't want. So that can be also specified. Any other aspects of their care, rehabilitation, then their nominated representative in order of precedence. So who can be the first nominated representative, who can be second, and so on. Now, who can make an advance directive? Every person has a right to make an advance directive. So again, so it doesn't mean that only persons with mental illness can make advance directive. Even anyone who does not have a mental illness can make an advance directive. In case of minors, it's the legal guardians who makes the advance directive. Then the CMHA has prescribed already the regulations for the manner of making advance directives. And again, these are the few of the procedural issues. I will not go deeply into it. There is prescribed format. From the procedure point of view, these all advance directive has to be registered with MHRB. And once MHRB will have an online platform, these all advance directives can be displayed there. Next is basically the advance directives will be invoked, or they will be basically used, or they come into force when the person with mental illness is basically lose their capacity until they regain their capacity. Once person has the capacity, the decision of the person will override the advance directive. And again, only latest advance directive will be applicable. Advance directives are not applicable during the emergency treatments. So these are some of the another procedural issues around AD. This is about who has the authority or power to review, alter, or cancel the advance directives. Again, there is a function of the board, as you can see in the middle box, the MHRB, which has the power to assess whether advance directive was made out of free will, applied to the present circumstances, and so on. And again, has the power to review or alter or cancel the advance directive. I think liability from the MHP point of view is largely around, all of us like mental health professionals will not be held liable for any unforeseen consequences on following a valid advance directive. So if the advance directive, which is valid, registered, if somebody follows that, they are not be held liable. At the same time, the MHPs will not be held liable for not following valid advance directive if they have not been given a copy of the valid advance directive. So these 2 points, I think, are important to kind of a note down. Moving ahead with the nominated representative, or NR, as it is called. So basically, nominated representative is a person who a person with mental illness may appoint. And this person is largely going to basically be used, or you can say is useful in supported decision making. So in the process, whenever there is a capacity of persons with mental illnesses is not there, the nominated representative can make decisions on the behalf, but that the process is again through the support, or basically the nominated representative will provide the support to person with mental illness to make that decision. And these are some of the, these are some of the work or the conditions of what NR has to do. So again, the procedure is any person can nominate a person in writing. This person can be anything, relatives or a friend or anyone, and then they can write on the piece of paper with signature who will be their NR. If NR has not been appointed, again, this is more of a practical question, then MHP will have to consider the following. So there is in order of precedence, these are the individuals or persons which are given who can be then nominated representative in case the NR has not been appointed by the person with mental illness. These are some of the duties again which are kind of listed. I'm not going to go through everything. Largely, I think the work of or the responsibility of NR is to provide support in making treatment decisions for supported admission, seek information on diagnosis and treatment to provide support to the person with mental illness. In other sense, what I always feel from a professional perspective, there is now the more responsibility on the nominated representative soldiers from the law perspective. So that means that responsibility of taking decisions, taking care, if something goes wrong in the treatment and care, I think the responsibility now shifts from professionals to nominated representative. And in a sense, it's a support in that sense to the professionals also. So I think from a positive perspective, we need to see this. Just now moving on out of the NR and AD, these are the few, just I think I want to highlight the main things which have been shifted from the, or which are different or which are new in the MHCA. This is about emergency treatment. ECT cannot be given as an emergency treatment, so that's important part. Emergency treatment is only provided till 72 hours, and in case of disasters or emergencies is up to 7 days. So these are the few important points. The prohibited procedures, we all, I think, all know till now that ECT, which we called as a direct ECT, is now prohibited. In case of ECT for minors, it is important that we have psychiatrists must apply to consent board, obtain informed consent from the guardian, and get the permission from the board. Then sterilization for the treatment for mental health illness is prohibited, and chaining in whatever form is prohibited. So these are some of the procedures which get prohibited, largely to reduce the what we can say the abuse or to protect the dignity and respect of person with mental illness. I will not go into deep into this rights of persons with mental illness. This is chapter 3. There is an extensive chapter. I think all of us can read through that. This is based on, as Dr. Pathare explained, about CRPD and different articles of CRPD. The highlight is, I think, right to access mental health care. I think that is the highlight for this MHC, and that is going to be the main, I will say, the giving the whole power to person with mental illness. So again, there are different rights which are explained in different sections of this chapter. Medical insurance, we have already spoken about. People have already kind of have knowledge that now persons with mental illnesses, the companies need to provide insurance to people with mental illnesses. And again, the principle is there should not be any discrimination, and there is a principle of equity which is followed. If insurance companies do not make provisions, then again, this is stated that it is an offense under sections, as you can see, 108 and 109. And any person, including the mental health establishment, may file complaints against any insurance companies that deny medical insurance to persons with mental illness. So these are the provisions which are made in the law. The last point I'm going to just cover about the MHRB and what MHRB is for, and what is the what is the role of MHRB. From my point of view, I think as I read the law and as I understand it, I think the MHRB is going to be a very good, I can say, a quasi-judicial body, which is going to monitor the implementation of this law. And really, MHRB is going to play a huge role in protecting the rights of persons with mental illness. Largely, I think if we have to implement the law, the MHRB has a major role into it. As we know that in Maharashtra, the MHRBs are already getting formed or already formed in many places. So I think the role of MHRB is going to be very crucial in the implementation. These are some of the functions of MHRBs. As I already said, the advanced directives, they have to review advanced directives, they, registration, reviewing, altering, modifying, all those things are with MHRB. Then also about similarly with nominated representatives, there is a function of MHRB. Reviewing the decision to admit patients. So again, they have to monitor admissions as well as the related to treatment and discharges. So then these are the few other duties, reviewing of decision for non-disclosure of information. So basically, if some nominated representative wants medical records to be accessed, then around that, there is a role of MHRB. Deficiency of services, receiving and they can decide complaints from a person with mental illness or their NR against the deficiency in provision of care and treatment. Inspection of prisons is another role of MHRB. And these are some of other duties about inspection and inquiries for violation of rights. So the protection and promoting rights, I think again is another role of MHRB, as well as they can issue penalty for non-compliance with orders of authority or board. And then they can also involve in additional measure so that they can protect rights of persons with mental illness. So these are some of the, I think, highlights or the key, I can say, ingredients of this MHCA 2017. And with this, I think I'll stop sharing my screen. Thank you very much again. Yeah, we can now, I think.
Yeah, thank you, Kaustubh, very much. We are just in time for a few questions. I think one of the key things which I would like to ask both of you, Soumitra as well as Kaustubh, is that finally when we are following the convention for people with disabilities, essentially what we are doing is following a Western pattern, which, I mean, a couple of the questions are also related to that. And purely now, because of the fact that we have become signatories to the Disabilities Convention, we are doing, aping literally what the West has been doing, and which may not be that great a thing, because in private you come across so many Indian patients who are there, who have stopped their medication, but perhaps because they aren't causing immediate harm to themselves or immediate harm to society, everyone assumes that they have the right to take their own decision, and finally nobody is able to intervene until the case goes way beyond a certain point of psychosis, and the person either ends up committing suicide or perhaps takes a gun and ends up shooting a lot of people. Your comments, Kaustubh.
Maybe I'll ask Soumitra to go and
Soumitra, yeah.
Yeah, I mean, look, I've heard this thing that it's a Western concept and all. I mean, the fact of the matter remains that the CRPD has not created any new set of rights.
Yeah.
There is nothing new in the CRPD which did not exist before, first. And the second thing is that nobody put a gun to our heads, to India, to ratify the convention. We chose to do it. Nobody came and said, "Banduk rakha hai abhi, aake karo ratify." कोई बोला नहीं था, नहीं करना था ratify, अगर हमको नहीं पसंद था तो हमने अगर ratify की, we can't say we have ratified but we will not follow. You know, you make up your mind. You either ratify it and follow it, or you don't ratify it and say we are not ratifying it, we are not following it. So that's an easy answer to that thing, you know.
Yeah.
The issue about, you know, you said that people don't take treatment and then ultimately die by suicide. It happens in the West because they don't have the kind of treatment we have. Let me just remind you that India has 17% of the world's population and we have 30% of the world's suicides, 33% of world suicides. So, you know, 1 out of 3 people who die by suicide are in this country. So whatever it is that our value system is, we seem to have double the rate of suicides as the value systems of other countries. If you are going to equate the suicides to value systems, first, I don't think so. But I think that the fact that if you're going to say, oh, this is what is leading to suicides, then really the fact is that India has a higher rate of suicides than almost all other countries. And if our way of doing things has resulted in suicides, then well, maybe they are doing something right and we are not, is what I would argue. So you know, suicides is a major problem in our country, which we've not paid any attention to, including our own society as well as professionals. We've always ignored it or not paid attention to it. So yes, suicide is a major issue which maybe requires its own discussion. And the third and final thing is that there is nothing. What about people like, I always say, what about people like diabetes? You know, the rate of non-compliance with treatment in schizophrenia is about 50 to 60%. The rate of non-compliance with diabetes medication is about 50 to 60%. Now, you tell me who has a mental health problem? People with diabetes or people with schizophrenia? You know, if they are so, if they have no other issues, why is the rate? So the rate of non-compliance with any chronic illness, whether it is a physical illness or mental illness, is the same. It is not anything particular for people with mental health problems. That is the first thing. So if you're going to use non-compliance as the only grounds on which something should be done, then well, we should use the same logic for diabetes, because even with diabetes, people don't take their treatment. They end up in hyperglycemia, ketoacidosis. They end up in ICUs. They die. They use a lot of resources. They fall dead on the streets. Same logic could then be applied for diabetes, but we don't apply it for that. Why don't we apply it for diabetes is what my argument. It should be the same logic. No, they are putting themselves at risk. They're putting their families at risk. They're using up scarce medical resources. And they're as non-compliant as people with schizophrenia are. Where is the difference? So if there is no difference for diabetes, then why is there a difference for schizophrenia? That would be my question, you know.
Okay, granted. Coming to another point which somebody has mentioned, that while providing guardianship of person with mental illness who has fluctuating course of his illness, what does the law have to say about this issue?
See, the Mental Health Care Act does not have anything on guardianship. In fact, one of the things that you need to understand is the scheme of arrangement that happened in the government when both Mental Health Care Act was being drafted and the Rights of Persons with Disabilities Act was being drafted. Government in government, every law has a guardian ministry, and guardian ministries guard their own turf very well. So the Mental Health Care Act is the guardian of the Mental Health Care Act is the Ministry of Health. The guardian for the Rights of Persons with Disabilities Act is the Ministry of Social Justice. So they were both trying to guard their turf very well, and there was always a discussion. Ultimately, there was a discussion between the two ministries and said, "आप ये करोगे, आप हम ये करेंगे, एक दूसरे पे कुछ we will not touch on each other." And one of the things that happened in that process was basically what the health ministry said was, right, we will only look after health related issues. The Mental Health Care Act will focus only on health related issues. Everything else, everything else to do with property, marriage, with employment, disability certification, guardianship, all of that, you are social justice guys, you take over that and do what you like. So if you want to look at the guardianship provision for people with disabilities and people with mental health, mental illnesses, then you will have to look in the Rights of Persons with Disabilities Act, which actually provides for a plenary guardianship as well as limited guardianship. Both is available in the RPD Act. Sorry, sir, you were trying to say something.
Yeah, I was just saying that how much of this has been actually covered by the Department for Social Welfare.
So the Department of Social Welfare has got some provisions for guardianship that they have put in place. They're supposed to have local committees. Now, in different states, the level of implementation of that has been at different levels, But there is a set of rules and regulations, including for guardianship, which have been produced under the Rights of Persons with Disabilities Act. So, everything related to guardianship and obtaining guardianship is now all under the RPD Act. There is nothing about it under the Mental Health Care Act. What the Mental Health Care Act has done, though, because we know that is going to be a problem, is that, let's say somebody has a first episode, they're not on guardianship because you wouldn't have them on guardianship. You still want to be able to treat them. And that's where it has created the provision of a nominated representative. You see, so the nominated representative, when it comes to mental health care, and especially mental health care, the nominated representative is the way forward. For all other matters, things like managing somebody's bank account, managing somebody's finances, all of that will have to go under the Rights of Persons with Disabilities Act. The NR has no power over somebody's property, over somebody's finances, none of that. So their responsibility and their role is purely limited to mental health care provision, and where they come into it. So that is why the NR is there and how the NR is different from the guardian in that sense.
Okay. Coming to one question, which is favorite, closest to my heart. The person on the road who's wandering mentally ill is supposed to be picked up by the police and taken to the nearest health establishment and all that. Now, that often doesn't happen. So where exactly does this particular thing fall under? Does it fall under, it is mentioned in the state mental health, it is mentioned in the Mental Health Act. So I'm asking this question.
Well, I would, I've been consulting with Banyan and Tamil Nadu now, because Banyan has taken a lead. As you know, Banyan's been working in this area for a long time. Banyan has taken a lead, and the Tamil Nadu government actually appointed a committee to come up with a policy for management of people who are homeless and found to be mentally having mental health problems. And they've made it very clear now what is the role of the government, what is the role of the police. In fact, they've now put up in their policy, they've said they're establishing crisis mental health centers in every district in Tamil Nadu.
Yes.
The police are supposed to take them to that crisis mental health centers. Those crisis mental health centers are in many districts run by Banyan itself. and where those provisions of the act will then continue to be followed. So Tamil Nadu is taking quite a lead in converting a lot of these principles of the act into practical things on the ground using the spirit of the act, rather than to try and not use the spirit. So, I think the policy should be out. I remember I've just seen a final draft of it. It should be out in the next couple of months, I would imagine. And it should be something that other states could then use as a list. And in fact, their policy is very interesting because at the end of the policy document, there is a list of some 500 odd mental health facilities which have already been registered by the state mental health authority in Tamil Nadu. So there's a list of registration, whom to contact, address, phone numbers, and everything. So that is happening,
Yeah, I know that because a lot of the district people are in touch with Shraddha for the rehabilitation.
Correct.
Yeah, now coming to this one question which somebody has asked, suicides or not, how does one now help people who are in psychosis, but in bracket, not in touch with reality, but not aggressive yet, and not taking medicines?
I don't see where the act comes into that. You help them like you helped them before. I mean, I don't see, specifically, I don't see what is the problem. There is nothing that the act says you can't help them, or you do not wish to help them, or that you can't help them. There's nothing in the act which would stop you from doing anything. So I don't know how the act would be either a barrier or a facilitator to that. If they were more specific, then maybe I can answer. I don't know broadly what they are.
I think from some of the questions which I'm getting, there needs to be a very specific interaction with you wherein the person can actually voice out his question and you can give a definitive answer.
Sure.
Yeah. So perhaps Kumar will take up on this and this thing. Right now 50 minutes are over, so we are still 10 minutes, but I think we'll cut off the 10 minutes because all the questions which I come across are very specific and they need a particular example to go through. So I would rather not speak that particular question, and I would much rather let this session end here and we'll take it up with the next session. Perhaps Kumar can later on organize a one-on-one, since you seem to be the most well-versed person with the law, and since you are the drafter of the law.
Sir, can I quickly, since you have 10 minutes...
Balchandra, even Kaustubh will be available for interaction on chat for people who are interested. And whatever chat box we have, we cannot entertain now, we can still forward it to our esteemed panelists or of this session and otherwise, and we can answer. So that can be solved.
Sir, can I, Sanjay, can I just quickly take 2 minutes to answer 2 or 3 very specific questions?
Please go ahead. Balchandra?
One was this.
I'm taking the note.
Sorry.
Yes, please forward. Yeah, go ahead.
Yeah. So first question was this. Somebody said, what about this thing about registration? I think they've asked, Bombay Nursing Homes Act does not apply to the mental health establishments. So I just wanted to clarify it. If you look up the Mental Health Care Act, it says very clearly that if you're already registered under some other act, such as the Clinical Establishments Act or the Bombay Nursing Homes Act, then you don't need to register under the MHE. You just provide the copy of that registration to the state mental health authority, and that's done. So really what the Mental Health Care Act is doing is offering you 2 options. You can either register under the General Health Act, or you can register under the Mental Health Care Act. If you're a mental health facility, if you're a purely mental health facility, you can just register under the Mental Health Care Act, and that's the end of it. If you're a general health facility and you registered under the BNHA, you just forward a copy to the SMHA and say, look, we are registered and we have fulfilled all the specific obligations that are required. So in a sense, you are getting options to decide which is an easier process. And I think if you look at the MHCA, the registration process in the MHCA is actually the easier process than registering under the Bombay Nursing Homes Act. If many hospitals would rather register under the MHCA than under the Bombay Nursing Homes Act. The second question from Dr. Shashwat Sare was, what about the marriage of a person with mental illness? Which department looks after it? Sir, the marriage of person with mental illness really is driven by our marriage acts. So the Hindu Marriage Act, the Special Marriage Act, the other religion marriage acts. I don't think any department has a role in it, but basically any of those are the marriage acts which regulate the marriages in this country, because marriages in this country get regarded as a social contract. And I do have some problems with the marriage act and the way they provide for divorce and all using mental illness. You see, it's very interesting. Until 1976, venereal diseases, epilepsy, leprosy, and mental illness were grounds for divorce, okay, or grounds for even nullifying a marriage. In 76, they removed venereal diseases, they removed epilepsy, okay. Last year, they removed leprosy also, but they have left mental illness, okay. AIDS is not HIV is not a grounds for a divorce, but mental illness is still a grounds for divorce. So, there's a real problem there. I find that very discriminatory.
What I want to ask is there a way to assess the capacity for marriage?
Sir, I don't think that we should get into assessing capacity for marriage. I think that the real role, the role of a psychiatrist in the marriage issue only comes in at the point if there is a question about divorce, or whether there is a question of fraud, or, whether this marriage is null or not. I don't think we should get into assessing capacity for marriage, because if we decide to do that, then we should do it in a non-discriminatory fashion, which means then we should assess everybody's capacity for getting married. We should say that anyone who wants to get married has to first get a certificate from a psychiatrist saying that they have the capacity to be married. As you know very well, parenting, even by people who do not have a mental illness, leaves much to be desired. So I think if we are going to do it, then we should say it is non-discriminatory. Then maybe we should have a law saying every individual, if they wish to get married, should produce a certificate from a psychiatrist saying that they have capacity to be married and to be parents. But otherwise, doing it only for mental illness is a highly discriminatory process,
And just one more thing about capacity to make a will, whether the law states anything, this MHCA states anything about that?
So again, as I said, the MHCA does not get into the business of will making, because again, it's talking about property. And if you see, that is covered in the Rights of Persons with Disabilities Act. So the MHCA really focuses its whole attention purely on capacity. And in fact, if you read the capacity provision, it also says that even if you are judged to not have capacity under the Mental Health Care Act for the purposes of mental health care decision making, that does not mean you do not have capacity for other things. Okay, so in fact, it has a very clear statement there that because you do not have capacity to decide for your treatment, that does not mean you don't have capacity to write a will, or you don't have capacity to look after children, because capacity is one task specific and capacity fluctuates with time. So the idea is that those decisions should be made very independently of the Mental Health Care Act.
Thank you.
Sumitra, can I add a little here?
Yeah, please, sir.
You see, in our earlier drafts, we had added a clause that mental illness cannot be a ground for divorce. But as you remember, Parliament committee said that this is a very controversial thing, so let it be handled separately. So that time this clause was removed from there. And what happens is that people are generally hiding the mental illness, and therefore it ends up in divorce. So it is under that cheating, that facts were not shared at the time of marriage.
Can I, if you're interested in the whole marriage issue, sir, we did a review of all the marriage or divorce petitions that came to Pune Family Court over a period of 15 years. One of the highlights that we found, or two highlights that I would like to point out. One is that, see, although it's a gender neutral law, meaning any spouse can file against other spouse saying, I want divorce because he or she has a mental illness. Almost 80% or 85% of the cases were being filed by men against women and not by women against men. When in fact, if you consider the rate of schizophrenia is 2:1 among to women. But more men were filing cases for divorce on grounds of mental illness. And secondly, the kind of reasons that were given very often and the evidence for mental illness that was produced and accepted by courts is actually very flimsy. There were things like a prescription for a chemist bill from a chemist for purchase of medicines as evidence. Okay. Now, what the Mental Health Care Act has done is that in any civil proceedings, any court proceedings, if one party says the other party has a mental illness, what the law now says is that that case has to be referred by the judge to a specialist expert committee made up of psychiatrists to decide whether there is mental illness or no mental illness, and then the court will decide. So now, in fact, any such things should be coming to a psychiatrist for that opinion, so that the judges don't make some opinion based on a chemist ka bill, chemist ka bill for purchase of medicines. Both, Dr. Kumawat can tell you more, but recently he and I were appointed by the family court in a divorce matter as an expert committee to opine on a case on which we went and visited this person and gave an opinion. So gradually the courts are also taking notice of that. So any accusations of mental illness in a spouse should come to a committee of psychiatrists to decide whether there is any mental illness or no mental illness.
You see, if conjugal rights are not, they are not able to exercise, then that becomes a ground for divorce.
Yeah.
I think we'll leave it at this.
Thank you, sir.
First of all, Soumitra, believe me, it's a privilege to be a chairperson of a session in which you are there. I was all the time thinking that I would be sitting in the audience and listening to you. And I think the amount of knowledge that you have on this entire issue, since you have built it up right from scratch, I mean, believe me, you can make the most unconvincing thing sound convincing. So perhaps you have got that much grasp of the nitty-gritty of what is going on. And perhaps at some point of time, we need to share this grasp of the nitty-gritty which you have got with a lot of other people. So I would not want that this should end at one particular session. And Kumar, of course, is the go-to man for all emergencies. So I take it for granted that he'll be able to arrange a session separately with you so that, I mean, at every point of time, you meet different psychiatrists, either in a conference, somebody always or the other is invariably bad-mouthing you, if you ask me. But the truth is that you are in the right. And I would like I would like to thank the organizers for giving me this opportunity. And I would like to thank both of you for being there. It was a wonderful session. I only hope that Kumar does it once again and specific, very specific to the psychiatrists, because this is needed, unless we are all on the same platform and on the same wavelength, which today to some extent my doubts have been cleared. But unless we are on the same ground and the same platform, things will keep on moving, rotating here and there, which is not fair to either the patient or to our psychiatric brethren fraternity. Thank you very much.
Yeah. Thank you, sir. I thank both the speakers, that is Dr. Soumitra Pathare and Dr. Kaustubh Jose for being with us, and Dr. Bharat Watani for chairing the session. So we will move to the next session. Next session is a case-based discussion on MSCA 2017. And the speaker for this session is Dr. Manik Vise. He is the professor and head Department of Psychiatry, MGM Medical College, Aurangabad. To chair these sessions, we have with us Dr. Suresh Badamat, professor and head of Forensic Psychiatry, Nimans, Bangalore. So we don't need any introduction for Suresh Badamat. He is the man who is teaching us Mental Health Care Act since at least 4 years. So over to you, Dr. Suresh Badamat, for further proceedings.
Thank you, Balchandra, and also I welcome all the delegates for this wonderful session on Mental Health Care Act. The whole day we are discussing. Before I start my discuss about this, I would like to pay an important point that is basically this. Again, one more person we are not discussed or told about is late Kesav Desiraju, the person who has been another architect who stood behind for the implementation of Mental Health Care Act, who was the Union Health Secretary of our country, and he passed away on 5th of September 2021. Unfortunately, if he was there, I think we would have had much more push for the Mental Health Care Act at the center and the state levels. He was the grandson of our former Indian President Radhakrishnan sir. But yes, it's a big loss for our mental health fraternity. Along with this, now I would like to move to discuss about Mental Health Care Act. But before I start, I would like to say that to the organizers, it is already 11:55. That means we are already running behind by 1 hour. In this format, what we are discussing, we will be discussing with regard to the cases. And also, if we have around 5 to 10 minutes, we have been doing audit about the implementation of Mental Health Care Act in NIMANS, regarding what are the difficulties the doctors and also the nurses, various other people are facing, and the patient and the patient party when they come, what are the problems we are facing, especially with regard to the implementation of that. That is basically the practical aspects. The spirit, if you look at the Mental Health Care Act, it's one of the best in the world, but the issue is implementation. If you take POXO Act, best in the world in India, but unfortunately the implementation. Name the legislation in India, they are the best because the best minds come together and they write it. But the issue is the will at the state level, at the center. It may be the funding. Unfortunately, it falls down very badly. Even the HIV Act, which was passed just 1 week after Mental Health Care Act, again, the implementation is the issue. Now, with this background, I would like to request the fellow colleague to present regarding the case vignettes, which we'll be discussing. And I request all the participants to please put the questions with regard to the case vignettes and related to that. Over to my colleague.
Thank you, Dr. Suresh, sir. What will be, as you have rightly said, since there is very little time and we are running a bit late, what we'll do is we'll discuss the cases first, and then if whatever time will be left, we'll be addressing the questions, and sir will be sharing his experience at the NIMANS on implementation part. Yeah. So here is the first case. Miss ABC, 26-year female, an IT employee, living alone in the city with alone in the city. Now she presents alone with severe major depressive episode, with suicide ideas and recent suicide attempt by cutting her wrist.
Make full screen, please.
Yeah, I had made it, sir.
In the bottom.
Is it visible, Dr. Bhalchand?
Yeah, it is visible, but make the full screen.
Manik, run the slideshow.
Run the
yeah, I had.
Because the next slide is not seen.
Okay. Is this okay now?
No.
Click on the
No,
slide.
no.
The first slide is showing. Your case is not.
Bring it to the next slide.
Make it slideshow.
Either go to the next slide or make it slideshow.
Slideshow. Better to slideshow.
Yeah, I had turned into slideshow mode only.
But it is not working.
Then go by manual. Click on the next slide.
Yeah. Now, is it okay or still?
No, it's not working.
Can you hear Dr. Bhalchand, same PPT is with you?
Sir, can you just close the PPT again, reshare the again?
Okay, just 1 minute.
Stop sharing and then again reshare. Yes.
Now I will be sharing the screen and we'll open the video.
Manik, if you are unable to do it, I'll be sharing from my side. Is it okay?
Yeah, if
coming.
this doesn't work, then that will do.
It's coming.
Make slideshow.
Yeah, just 1 minute, let it load.
मानिक स्क्रीन वरचे ऑप्शन्स आहेत ना, त्याच्यामध्ये स्लाइड शो कर.
Great.
Go ahead.
This is okay?
Now,
Okay, but next slide. Huh?
Next slide.
Okay.
I think Suresh should do it.
Yes,
Right,
yes,
right.
yes.
Now it's working. Huh?
Yeah, it's okay now.
It's okay now. Then okay. So here is a young girl presenting alone to a psychiatrist, and she had suicide attempt, a recent suicide attempt, and there is no one with her to take care of or be with her, as per her information that she gave. Now, as a psychiatrist, you are thinking of admitting her in view of suicide risk, medications, and ECT treatment. So we will be discussing what, as a psychiatrist, we have options from the perspective of this new act. So as it starts, first and foremost is we have to assess the capacity for making treatment decisions. And then if she has capacity, we will go ahead with independent admission under section 86. And if she doesn't have capacity to take treatment decisions, then we have to go for the 89. But then if she refuses to inform the parents, and she then the real question or the complication will arise. Here, if she has capacity, she is willing for independent admission. For ECT, we will be requiring consent, not only of the patient, but for the anesthesia purpose, as the other laws related to health are there. They will mandate the either signature of the relatives or the here NR. Now, what can be the possibility here? Because she is alone, she is not ready to inform to the parents, and NR she has not formulated. So only way is, I think, we will have to request her to either communicate with a friend and bring the friend and make the friend as NR for taking treatment related decisions. That will only apply if she has capacity. That will only apply to the immediate post anesthesia period, when for a brief time she may be she may lose the capacity. Now, other aspect in this case is insurance, that has been already discussed in the previous session. And insurance, definitely she can avail the insurance facility available, but then there will be the sharing of information with the employer also as for processing of insurance. Why I'm saying this is because she had the insurance through the her company, and many IT companies, they provide the insurance cover as their policy to their employees. But they also ask for the sharing of information, and the many times insurance is processed via the company through the insurer. So here we will have to be explicitly in discussion with our patient or the client here, that these are the things, and how we'll be going ahead with your treatment.
Okay, Professor Manik, I have a question to you, because this is the maximum questions asked. If the patient comes with the suicidal ideas or suicidal attempt, should we make MLC in the district hospital or medical college? This is the commonest question everybody is asking. What is your opinion, Professor Manik?
Yes, sir. Since this act has decriminalized the suicide attempt per se, there is no need to file an MLC. If you are in suspicion that there's something malicious is going on, maybe she is actually being, it is not suicide and it is more of being harmed by others, or there is something malicious you are suspecting, then it is better to go for MLC, because this act protects you from decriminalizing, it protects the person from decriminalizing suicide. But if there's something wrong goes, then the police inquiry needs to be done.
Okay. So what you're mentioning is basically, I'll put it in a different words to Professor Manik. It's basically, there is no need for MLC if the patient has capacity, the patient is doing well, is able to answer your questions, no need of making an MLC. If the patient is unconscious and you're suspecting foul play and there is an abatement of suicide, that is, we are talking about 306 IPC, yes, of course, there is a room for MLC. And if you are, especially a rule of thumb, what we say, whenever you're in doubt, please make MLC. But need not, for all cases, is not required when the patient has capacity. That's the one. So second question, which is usually asked in any of the workshop is, can we give ECT on OPD basis or the patient should be admitted is the question. Over to you, Professor Manik.
From the perspective of this act, it doesn't talk per se whether in what setting either patient needs to be admitted or it can be given on the OPD basis. I think it does talks about ECT without anesthesia only, but it doesn't, it is silent on this aspect. But in general, in practice, what we see is it can be given on both. In either case, the liability of the patient, whether you give on OPD basis or IPD basis, the consent has to be well framed and it has to be taken in liaison with the patient and the NR or the relative, and whatever the consequences, it is the liability of a shared liability will be there of the treating psychiatrist as well as the family as per the consent that has been obtained. So I don't think there is any restriction on OPD basis ECTs.
Okay. One more question, Professor Manik, we commonly asked by our psychiatrist and also the mental health professional. The ECT is prohibited in giving an emergency treatment. Okay. Yeah. So when to give ECT then? If you are admitting the patient, okay, and the patient, if you are admitting under 89, since there is no NR, you have informed the mental health review board. The review board has appointed one of the either NGO as an emergency basis as an NR, or maybe a social welfare department director will be the NR. So they have given the consent. So how to go about, because the patient is in emergency situation, when to give ECT? Over to your Professor Manik.
Yes, sir. This is a very good question, sir. If we look at the act that has and the section that has been framed about this emergency treatment, once the patient reaches the MHE, if he is admitted to the MHE, the emergency treatment provision ends.
Excellent.
So once he is in your MHE, you are free to treat him the way you want, either under section 86 or 89 if he doesn't have the capacity.
Okay. One more question which is commonly asked is, there were earlier some of the psychiatrists used to go home and give ECT. What is your opinion with regard to this? Because bringing to the patient to the hospital and then can we give ECT at home? Because there is nowadays a simple machine is available with regard to ECT. Can it be given at home? Professor Manik.
Yeah, very interesting question. It cannot be given in the home because it is not an MHE. That is the first thing as per this law. Second and important thing is it involves anesthesia. So again, anesthesia is a general anesthesia. Short, though it is short, but it is a general anesthesia, and anything may go wrong. And in that scenario, both psychiatrist and the anesthetist are contradicting the law of land.
Okay.
Because in this procedure, other laws are also applicable, not only MHE.
Okay, excellent, Dr. Professor Manik. You made it very clear. Giving ECT at home, you have to follow the procedure. It has not prohibited giving ECT anywhere, but only in emergency A. But you have to give modified ECT, that is general anesthesia, and you have to give muscle relaxant. At home, you may not have Boyle's machine. You may not be able to resuscitate. You have to take anesthetist with you. So all these are the problems. Hence, it is best to give in the MHE. Now coming to insurance. See, many of our persons with mental illness and their family members are confusing with life insurance versus health insurance. So you are mentioning again insurance. Which one you are mentioning, Professor Mani?
Sorry for that. It's actually the health insurance cover that is provided by the company to this IT professional.
Yeah, even the Mental Health Care Act also talks about health insurance should be covered. But unfortunately, again, please do remember one of the person who spoke early in the morning, he said that life insurance should be covered. But invariably, Mental Health Care Act talks about health insurance. And invariably, if it is a life insurance, the life insurance people, if the person has committed suicide and the life insurance with regard to suicide is invariably considered null and void because the person has taken life by himself, or there is a period which is to be they call it as a transient period. If it is done, then only some of the insurance are covered. But again, Mental Health Care Act has said that any person who has attempted suicide is because of stress. So it's a blessing in disguise. We can argue in the Supreme Court asking, yes, it has to be given if it is after 2 or 3 years down the line, if he has committed suicide because of mental illness, why not can be given is one question which comes to my mind. I think the right, if the persons with mental illness and their family member are able to argue, yes, we can get this. So this another one important you brought, sharing information to the employer. That is the employer means the person with mental illness who is working with, or is it to the insurance company? This is the question which is commonly asked, Professor Manik, because right to confidentiality under Section 23 is very clear. So how do we deal with this?
Yeah, and that is why I had kept this piece in the slide, sir.
Good.
What is the before availing the insurance per se, we'll have to ask to the person whether your company actually wants the insurance to be filed through them. And this I'm talking from my experience, because there had been 2 patients who had got their insurance via the companies here in Aurangabad, and they said they will have to submit the documents to the company for the processing of their insurance cover, that is health insurance. Please correct that. And then I had clearly told them this is a medical legal document, and whatever is written, it will be shared, and you will have to give consent for that. Because I can share with the insurance company that because you had made a contract with the insurance company that they will have a right to review the documents. But for that sharing with your employer, then you will have to give me that explicit consent, because there I will be violating otherwise one of the important clauses of this act. And in other case, where they had independent insurance, not via the company, there was another client. So there nothing, no question was raised. But in that 2 cases, I had to explicitly discuss with them and get the consent.
Yes, Professor Manik, you have made a point very clear. See, with regard to health insurance, if the patient party, please take the consent from the patient. If the patient doesn't have capacity, please take the consent from the NR to share information either with the insurance company or with the maybe employer without the considering the consent. Because if the insurance company before when they have signed it, it is the contract between the patient who is availing the insurance and the insurance company. So the insurance company invariably will approach the doctors for asking for this. In such a scenario, you have to be very clear. Please talk to the patient and the patient party to reveal the information. Yeah. But however, this issue is not only in India, even in Australia, even the health minister had to give a declaration telling that he will give an orders because they used to share the whole file, which is required for admission. So a lot of things which is written used to be shared. Not only that, if you come to Ayushman Bharat, in certain states, I'm talking to this, where the Ayushman Bharat under the insurance for mental health is available now. And again, they are asking for the whole file. The whole file, does it require as a question? But anyhow, it has to, because the whole file sharing is, if you ask me, you are violating the complete confidentiality. There are certain things only is required for the reimbursement purposes. But again, this is debatable, which requires a higher discussion. I think we can go to the next case, Vignet, Professor Mani.
Can I interject, Dr. Suresh, for a minute?
Yes, Mr. Bakshi, sir. Please go ahead.
You see, Dr. Manik's what he said indicated that NR is compulsory. If the patient wants admission and patient doesn't have the capacity to take mental health related decisions, then she must get some relative to be her NR. Now, law does not make it compulsory for a person to have an NR. So in such circumstances, and if she doesn't want to share her illness with her relatives, so I think admission should not be denied. Admission can be given under Section 89, and then some NR can be appointed from NGO. You see, NGO can be made an NR if a relative is not to be made. So we should not insist on her approaching a relative or a friend to become her NR. This is my submission.
I think you have made a wonderful
stated that who can be appointed as NR if there is no relative, and that has been taken up by the prior session.
Temporary NGO can be made an NR.
NGO, even the there are authorities who can be made.
No, authorities can be, but temporarily this mental health establishment can decide and make an NGO as the NR.
Thank you, Dr. Bakshiji. I think he has made it point very clear. Just because there is no NR or family members are not there, please don't refuse admission. Not only for it's a government hospital or private, there are many NGOs, even like Bharat Watwani sir is running an NGO. There are many patients who are wandering mentally ill at large and they don't have NR. In such a scenario, you need not wait. Right to life takes the predominance. And that is the reason where you have to admit either maybe 86 or 89. And please approach the Mental Health Review Board asking for a NR, or if you have an NGO, for a time being, NGO can be there. And let me make my point very clear. Mental Health Review Boards are not formed in Karnataka, but in NIMANS, we are running our own internal board till the MHRB is formed. And we have people from like lawyer and other people from the community who are looking after this mental health internal board, we are call it as, so just to review all these things. So please do in the good faith. See, the preamble is very clear. You have to protect the rights of the persons with mental illness during the provision of services. So even if he is here and there, please don't worry. Please go and admit under 86 or under 89 and approach the review board for the maybe NR, or for the time being, it may take 1 day, 2 days, or 3 days, or 5 days. Till then, an NGO, as Dr. Bakshi sir said, no mental health review board is going to hound you or hold you for that. Please admit. Don't refuse for 86, 89. And during this, we have seen during this COVID, where family members are refusing to get admitted because the reason is, although there is a COVID, we can't stay there. So, and again, if the family member is there, he is elderly, maybe 70, and the patient is around 45. And that time we have to take a decision admitting the patient alone. The simple reason is admitting again a family member along with the patient. The COVID was one of the biggest challenge for 2 years. I think this is the point where Bakshi sir has made very clear. Don't hesitate to admit the patient under 86 or 89 without NR, and document what is the problem. And those documentation I'll be discussing later. Over to you, Professor Manik. I think we can go to the next case. We have already spent 15 minutes on one case. Go ahead.
So here is the second case. An nominated representative of a 25-year-old male comes alone with information that index patient is experiencing hallucinations, delusions, and is very aggressive, with history of attempted strangulation of his mother by him yesterday itself. Patient is at home, locked by them, and they fear of being harmed if he is set loose to bring him to the hospital. On inquiring, the NR says patient had made an advance directive, which is registered with an MHRB, and that is accessible to you as a mental health professional. Now he asked, what can be done now? So first and foremost is we have to verify that he is an NR actually, and then as this law doesn't hold us from visiting the home. We can provide treatment at home also. May not be the procedures like ECT, but yes, home visit we can do. So we can visit the home and assess the capacity of patient there. And what do you feel is capacity in this patient is obviously impaired based on the history, because if capacity guidance document clearly states in its first statement itself that yes, if the patient is aggressive, harming to the other close people around him, then capacity is can be deemed to be impaired at that moment. So we ask for the advance directive as the NR has stated it, and he has written that he doesn't want to get admission and ECT treatment. So the question here is, can we as a mental health professionals override an AD? The answer is clearly no. We can't override an advance directive. We can't go against it at that moment. But what we can ask to the NR or the relatives is that please approach the mental health review board and get this advance directive modified via the review board. And there is a procedure and even application format given in the rules that has been framed by the center. So they can get it done. What is important here is we can treat the person at the home also. He has not written about anything related to medical line of treatment or the medications. So yes, by following his advance directive, we can give him the treatment with the support of NR, because he has lost the capacity now. The medical treatment can be provided. That may include the chemical restraints as well at home. Till that time, the MHRB modifies the advance directive and allows him to get admitted, because here the life there is a threat to life of other person. So here comes the pivotal role of MHRB, which should take the quick decisions in such situations. And only if AD is modified, you can admit him under 89. What is the fallacy of Act here is that this MSCA 2017 doesn't consider the plight of family members or the relatives, that they will be suffering through such situations. That's it from my side, sir. Anything you want to discuss?
Yeah, Professor Manik had made it point very clear, but however, I would like to make certain things very clear also. See, whenever in such a scenario, when the patient has locked up himself, it is not the first time we are seeing. Even in Bangalore, we have seen many cases where the patient had paranoid schizophrenia, thrown his mother out of his house. Mother was around 70-year-old or 72, and she was staying on street. In that scenario, we had to take the help of the police under section 101, 102, or 103, where 103 is for the person who was involved in crime. So it's basically anywhere we are going to talk about the help of the police. 100, usually we call 100 phone number. So remember that section 100, 101 and 102, talk to the police. And if he has locked him himself, and also the patient, the mother who is a senior citizen, she can also approach either to the police or a senior citizen cells are available in almost all city. From there, she can take legal aid, or from there, she can approach the police. And if you are a psychiatrist, maybe whoever it is, it may be public or private, please do contact the police, ask help. One. Second, important thing is 108 is already working in almost all country, almost all state. 108 is basically the ambulance. In Karnataka is there, in Maharashtra is there. It is most probably a national level. It is going to be there for mental health, which has been planned. Central government is discussing about this, which will be considered as a T-Manas, basically the telephone and helpline, and also providing healthcare through telemedicine, and also if required sending an ambulance, along if required a police will be called. That is a plan which has been there and it has been discussed with Niti Aayog. It will be done, implemented. Coming back to this, take the help of the police, bring the patient to the directly under 100 or 101 to the mental health establishment. But unfortunately, it talks about public mental health establishment. This is one of the problem which is there, because you have to go to a government only. That is the biggest problem. But anyhow, DMHP is there now. Medical colleges are there where you can take them. So that is one. Please take the help of the police. If in such a scenario, and again, if the patient has written, again, the advance directive in the Mental Health Care Act has clearly written anything. If he has written against the prevailing laws, if he says, I don't want admission, again, it's not the norm. How can you say that I don't want admission to mental health establishment completely, which will be against the nature or what we call it as against the law, he may require admission. If I am in the psychiatrist who is going to treat, I will not wait for the MHRB to give the opinion. That is a blanket statement which will not hold good in any court of law. That AD will become nullified, if you ask me. So in such a scenario, the golden hour, what Dr. Balachandra has raised, I would go and admit him, taking the help of the police, admit him, or else even if because nowadays in Delhi, there has been particular magistrate in that area of the MHE has been assigned, and you can contact and you can get a 10 days of reception order, or what we call it as assignment for the permission to admit him and treat him. So don't step back. This is a proactive legislation. Go ahead and imagine if you are in the parent's place where you have been thrown out of the house and the patient has locked himself and he may be beating up, and a couple of cases where the patient's family members were even fractured. So in such a scenario, don't hesitate. There is a clear cut, the violation has occurred with regard to the family members. Please admit, don't wait for the legal procedure. Legal procedure by MHRB, they will definitely give permission looking at the whole context, how it has happened. And although here by going by the law, what we have discussed, don't hesitate to take the help of 100, 101 and 102 under the Mental Health Care Act. Don't hesitate to call ambulance under 108, which is available in most of the states. Call them and they will be able to help you to shift the patient. If there is you're suspecting a violence, take the help of the police. And there are district legal service authority. Many of them in Karnataka and even in state, Maharashtra state, they have been sensitized. These district legal aid member secretaries, they also proactively help. You can document that we have called them, asked for legal aid, and they know before we are taking the patient under our custody. So there is some amendment is required. I don't want everything to come to a public, because some patients' family member says, let us take him to a private establishment. Why not? So that's one which can be discussed, but don't wait for the law to take time, because law in India takes time for the implementation. So please go ahead and admit, this is my humble submission. Don't make our senior citizen to suffer. Oh, I think if there are no questions, we can take, because MHRB will take time to respond. It may take 1 week, 2 weeks, 1 month, 2 months. So till that time you are waiting, telling that he has written something, I don't want admission. That kind of blanket statement will not hold good in any kind of advance directive. Nothing to do with health. Even if he is written somewhere something like such kind of advance directive, even for a capacity, for a testamentary capacity, it will not hold good, considering that he is mentally ill or other ways. So that kind of will not hold good. Over to you, Professor Manik. We can go to the next case.
Yes.
Bakshi sir, would you like to add something? Sir, you have to unmute. Bakshi sir, you have to unmute. Bakshi sir, I think you have not unmuted. Please unmute, sir.
Unmute yourself. We are unable to hear you. Please unmute yourself, Bakshi sir.
I'm unmuted. So,
yeah, please go ahead, sir.
You say Aurangabad MHRBs are not functioning. So it is a hypothetical question. But suppose they function and such a situation arises, then you see, once Section 89 is to be used, then patient's wish for admission or non-admission does not matter. He has to be admitted forcibly, if possible. And secondly, this nominated representatives are not registered with the MHRB, or you are saying that you will verify it from MHRB. So that is not correct. You can question the NR whether NR has to show the letter to you which he has received from the patient, and then you have to satisfy that this is the last nomination which he has done, because he might change his nomination also. So these are some submissions.
Okay. Thank you, Bakshi sir. You have made a very valid point. Here the MHRB, if it is not functional, actually, if you read the Central Mental Authority regulations, we have put in the clause clearly telling that when a MHRB or you are approaching the MHRB and the case is pending for hearing, you go ahead with the treatment. That we have clearly said, because we anticipated this problem. Either MHRB may not be functioning or MHRB is delaying because they've taken the case. Invariably, they have these are the judges who have learned telling that we will postpone the case or we don't have information. So for that, there is a clause in Mental Health Care Act, in the Mental Health Care Regulations, which was passed on 16 December 2020, which we clearly said that during that grace period, you can go ahead and treatment. Don't worry. These are all legal procedures. And these are basically to protect the rights of a person with mental illness. You have to go ahead and treatment. So please don't delay. One. And there is one question by Dr. Arun Marwale, which he says, what about the potential harm to the rescue team member? Here, in Maharashtra, one member died because the patient stabbed the team member. What is your response, Professor Manik?
So that's the risk, and this law is silent about that because
Professor Manik, I would put it like this. These are all occupational hazard. If you look at the persons with mental illness harming the doctors or the family members, harming doctors or the healthcare workers versus normal people harming the doctors and other team member. If you compare, the normal people are harming the doctors or the nurses or the healthcare professionals. So this is one of the rarest of the rarest cases. If you ask me, I'll give my own example. I've been working in Nimans since past maybe 22 years in Nimans. I've been assaulted twice. Similarly, my friend, there is an orthopedician who is working in a general hospital in a corporate sector. He has been assaulted more than 10 times. So it's the normal people assaulting the healthcare workers is more rather than the patient assaulting the doctor. So please don't take this as what we call it as all patients are dangerous. That is completely wrong. And even if you look at the cases which we are seeing, even in the normal public, the normal public committing crime is more than the persons with mental illness committing crime. So don't think that the persons with mental illness are dangerous. That is a danger information given to the society, and it's completely wrong. This is one of the case, Dr. Arun Marwaleji, and it should not become, we should not make rules for exception. If you make rules for exception, it will become very difficult to implement. This is one of the rarest case. So in that way, and there is one more question from Devrat Harshe. What will be the...
I would like to respond to Bakshi sir's comment. Basically, this Aurangabad board has become already functional. Two of our colleagues are appointed on the board, Dr. Vinay Chapalgaonkar and Dr. Agrawal from Jalna. So it's not in Aurangabad, it's in Jalna. It has become functional. The government has sanctioned that order.
Okay, thank you, Dr. Arun, for the clarification. So there is one more question by Devrat. What he says is, if the consent of the relative is given for ECT, but the MHRB refuses permission. So you will listen to the MHRB and you will go ahead without giving ECT. That would be my response, because if MHRB is refusing, then it will either you have to challenge in the High Court, or else you have to listen to the MHRB, because I don't know if the patient or the NR has given the consent, why need you to go to the MHRB? If the patient has challenged, then of course, if the MHRB says no, please follow the quasi-judicial body, what he has given the information. And I think Dr. Sanjay has asked, these are hypothetical cases, stands for and beyond Maharashtra and not only for Aurangabad. Please note, okay, this is not just only for the Maharashtra, I think for the other cases. I think we can go to the next case, Professor Manik.
Yeah, probably Devrat was talking about this case, refusal by MHRB for ECT. And this is the case of a 15-year female brought by parents at 11 p.m. to your MHE. She has schizophrenia with catatonic symptoms leading to poor oral intake since 7 days and no intake since 12 hours, which triggered them to rush her to your MHE. Your plan is admission and ECTs as emergency measure. Now I'm not talking because they are already in your MHE. So emergency is for the urgency of the treatment rather than clause of this law. And so what will be the procedures that we will see? So obviously she is a minor and admission has to be under 87, section 87 of the Act. And it has to be before the admission itself, she has to be assessed and certified by the 2 psychiatrists or the 1 psychiatrist and 1 MHP, 1 psychiatrist and 1 that all thing is given in your Act that you can see. So that certification and requirement of admission and is to be validated by the 2 professionals. then a separate accommodation from the adults need to be provided to the minors as per this act. And this, we have to plan for that. If the minor is getting admitted to my MHE, I will have to make a separate admission provision from the adults. So maybe a separate room, or if it is a general hospital, whether you can collaborate with your pediatrics, because you will be having a license under both Clinical Establishment Act and this MHCA also. So such kind of arrangement you should be prepared with. And here she is a minor, female, so a female attendant has to be there. And if the NR is female, then she can stay 24/7, or she should appoint, if he is a male, then NR should appoint the one female attendant 24/7 with the this minor girl in your MHE. Then information to the MHRB, that is the review board, has to be given within 72 hours. And again, there is a provision for more than 30 days, then a review for 7 days. And so the things are given in the act which we have to follow. Now comes the question of ECT, and this is what the probably Devrat was talking about for this case. So if ECT to minors has to be given with the permission of MHRB only. If MHRB says no, then we can't give ECT because we will be contravening the act per se. Yes, sir. Over to you, sir.
Yeah, it is. This is one of the other problematic issue here is there. ECT is not prohibited in minor, but it is regulated. You need to take the consent of the MHRB before you give ECT to the minor. So that is one issue is there. But however, if the patient has come in catatonia, you will not directly give ECT. Invariably, you will consider at least 2 to 3 days of lorazepam. You have time. And many, again, the research has clearly said that around 60% of them respond to lorazepam. So try lorazepam first. And by the time you have a grace period, you can approach the MHRB for ECT. And of course, there are some here and there minor practical problems. Otherwise, giving a treatment for a catatonia, you should not be a problem. And at the same time, if you ask me, one is, of course, yes, Mental Health Care Act 2017. Catatonia can be for 100 reasons, if you ask me. It's not just because of psychiatric reason. So in such a scenario, you have to do all investigations and you need to be proactive in checking whether there is any organic causes. So in such a scenario, that means, imagine if there is an infection and there is a catatonia. Do you think you will be waiting for AD, NR, all nonsense? Please don't do that. Go ahead and with treatment. Everything revolves around one thing. Doctors practicing defensive practice will be a problem rather than being proactively and doing things and documenting, telling that I had a doubt about ABCD and I'm doing this investigation to rule out, especially with regard to catatonia. Please do investigations, go ahead with the treatment. And of course, if ECT is there, if it is an organic cause, you will not give ECT. In such a scenario, you have to use your clinical judgment. That is very essential. I think I have made my point. You can go to the next case, Dr. Ram.
Okay, can I have one more question?
Yeah, go ahead.
Okay, the clause about female caregivers for female minors. If a girl child is brought by her father, and he is the one who is admitting her, then and if there is, I mean, he cannot spare a female relative to stay with the child, female child. So what is a practical alternative to this? Because it is not always possible. I mean, these cases may not be majority. Some or the other female might be available. But what if there is no female relative or caregiver who is willing to stay with that minor female? So is there any practical work around this?
Devrat, I will shortly answer this question because we are running late. We are coming to the end. So I would rather say that, see, in our hospital, what we have done is, we have our own NGOs. We have our own people who are paid attenders, especially females are there. They will come in. It may not be immediately because if it is a light 11 p.m., it is difficult to arrange. Maybe in the next early day morning, they are being paid attenders are available. There are like for a patient, there are 24 bar/7 available, pediatrics are available, or else the hospital can have their own arrangements to arrange these kinds of, especially for these special conditions, 1A. But invariably, see, the issue here is when you are admitting the patient in a general ward along with adult patient without attendant, those are the issues were considered. If it is a special ward and a single room is there, you need not have, because imagine there are many private establishments, they have a single rooms. Single room you can admit, need not be a child be admitted in a general ward. It's basically a special ward where the patient is kept in a single room along with the family member. Of course, you need to have a female attender. I think that will suffix your answers. I think we can go ahead because we are running late of time, Dr. Manik. Sorry,
Thank you.
Devraj sir.
Thank you.
Sorry, Devraj sir, I'm cutting short.
No, thank you. Thank you, sir. Thank you.
Professor, go ahead.
So here is a fourth case. Your physician friend gives you a call for management of alcohol withdrawal and de-addiction of a 25-year male. He is currently admitted in his hospital, which is not registered as MHV. So what to do in such scenario? Because many of us get calls from other hospitals. This obviously is going to be taken up in a separate consultation section later, but we'll discuss it briefly here. We can attend the call. Law doesn't prohibit us from attending the calls in other hospitals and treating patients there. But yes, whenever you are going, any medical practitioner can admit and give treatment for all psychiatric illnesses. And remember, this act has done a good thing that it has brought the alcohol and the substance uses as a mental health disorder per se, rather than the keeping them apart. So yes, you can, anybody can admit and give treatment, any other professional apart from a psychiatrist. And as a MHP, you can go see the call, write the proper treatment, whatever is required, and suggest the transfer to an MHE, either it may be yours or some general hospital or whatever, but suggest the transfer to an MHE once the patient is stable or after the 72 hours. So because that emergency 3 days period is there for other professionals to take care of mental health illnesses as well. So what I will suggest is you can use this act positively with your other professionals, like other colleagues from your other specialties, saying that it is better that under this act, the patient is shifted to a MHE. But on other side, what I see in practically is there are few psychiatrists who are also admitting the patients to the GHPUs, other general hospitals, which do not have the MHE license. So there, it is better to get the MHE license for that medical hospital as well. And as stated in previous session, it is very easy. Just have to show that they have a license under Bombay Nursing Home Act or Clinical Establishment Act, whichever is applicable in the state. So it is always better to transfer the patients after 72 hours to an MHE.
Yeah, Professor Manik, you made a point very clear. I also would like to request all our colleagues to tell those nursing homes, if you have already registered under the Clinical Establishment Act or the nursing home, send that to the SMHA that they have registered under the other act. So they will be, because even Soumitra Pathare was very clear, if you have already registered under Clinical Establishment Act, send a copy of it. That's it. That means you are automatically registered. So need not worry, and tell all the nursing homes to please register under SMHA. I think you can go next case, Dr. Professor.
Yes. Here is a fifth case. 30-year male, alcohol dependence with delusional jealousy is brought by relatives to your rehabilitation center for admission. And we have to see what might be the considerations here. So obviously, this act states that you will have to have a MHE license even for the de-addiction centers or the rehabilitation centers, though there some separate clauses may be made or separate rules may be made for that latter. Addiction, yes, it is a mental illness under this act, and you have to assess the capacity of that person. If he has capacity, then it is his will to get admitted. And if he doesn't have capacity, which will be only possible under the few hypothetical circumstances, like he's currently intoxicated and he is not able to verbalize or not able to comprehend. In that scenario only, he may lose capacity in alcohol dependence or alcohol, and or the other extreme can be delirium or immediately post-ictal state. So if he has capacity, then you will have to follow his decision, the patient's decision. You can't admit him against the will. To admit him against the will, you will have to establish that he doesn't have capacity. There the NR will admit, and then if capacity is not impaired, obviously that advance directive comes into play. Follow AD. If no, then if AD is not there, you have to follow the admission process under section 89, as long as the new rules or the some other rules are not framed for the de-addiction centers or the rehabilitation centers per se, or the other halfway homes and whatever is told in this act. So till that, we'll have to follow the section 89 and follow all the procedures in that section. So that is my view, sir.
Yeah, I think you have made it point very clear. Do not go against the liberty of the patient, because Article 21 is right to life and liberty. If you want to go against the liberty of a patient, you have to establish the patient doesn't have capacity, because the law says everybody has capacity. Yeah. And if you are saying I'm admitting him against his wish and will or the consent, you should prove that he doesn't have capacity. Then only you can do it, even if it is for alcohol or substance use. They come under Mental Health Care Act. It has been clearly documented as per the definition of mental illness. Next case, Professor Manik.
That's it, sir. We have 5 cases only.
Thank you. I will be discussing in another next 5 minutes about the practical aspects, which we are finding it very difficult, and also the mistakes done by our psychiatrists or mental health professionals, and what are the challenges. I'll be sharing a couple of slides so that the issues can be discussed. I think everybody is able to see this.
Yes.
Okay, so just a minute. Yes. So before I move further, I would like to say we have already from NIMANS, we have made various YouTube videos on Mental Health Care Act. We have around 57 videos. Please subscribe to that. Suresh Badadmat is the channel we have. So there, all the issues regard to Mental Health Care Act, what we are discussing is there. Every section has been discussed. So you are free to subscribe and learn, and also all the MHRB members, if they are there, you can go through the videos. So first and the foremost is capacity assessment interview. It will take around 5 to 10 minutes. And if the patient is very severely ill, the capacity will be considered as obviously not there. And also the documentation also will take time. Collecting information will take time. So these are the issues which you should understand. And second, let's understand what are the problems in practically when you are doing admission. First and the foremost, as Professor Manik was mentioning, majority of the problems which have reached the court, which occurs usually in the night or on the holidays, especially on Sundays evening, where there will be only one doctor for management, maybe only one a medical doctor who is there or the psychiatrist who is there. Invariably, psychiatrist doing the emergency care invariably will not be there. So in such a scenario, you need to be very careful. Don't admit such care during that time. If you want to admit, call the psychiatrist, call the medical officer or the mental health professional to assist. So invariably what we are finding it, social demographic details are not filled in the pro forma. Diagnosis is not mentioned. At the same time, name of the NR or the ID card which is required is not mentioned in the Form C for especially independent admission. Reasons for various yes or no questions, especially in capacity assessment, it is not elaborated. That is again the fracture of the capacity assessment guidelines. Please don't do that. Please write the elaboration. I'll show that. And many a time signature of the mental health professional NR and the patient is missing. And many a time ID card Xerox copy is missing. That should not happen, because if it goes into the court of law or in the MHRB, the lawyer or the family member or the person who is sitting there as a judge will look into these aspects. Many a time date is missing because the patient, invariably we say 72 hours. From where it starts, you have to mention the date and time. If the patient has come on maybe around 11 o'clock night, around 11:30 p.m. And now if you don't document the 11:30 p.m., the mental health review board will not know when he was admitted. Because it's 72 hours, you have to calculate the hours. So the date and time is missing. It's the biggest problem. And again, if your patient is admitted as an independent, and if the patient becomes ill, you have to shift the patient from the 86 independent to a supported admission. In such a scenario, you have to assess the capacity, and changing from one section to another section, you have to do it. Not only that, if the patient is admitted under 89, that is supported admission, if the patient improves, when you are doing capacity assessment, you have to shift back to 86. Don't simply sit there and do. And weekly assessment has to be done for 89, and many files do not have this, not only in our institute, many other institutes. Don't do that. And fortnightly assessment of capacity has to be done under section 90, and many rehabs don't do that. Now you are mandatorily are supposed to do that. And if you are shifting from 89 to 90, this is another biggest problem. 2 psychiatrists has to sign it. Please make sure that it is signed. Now let's look into the forms which are seen and observed by our internal boards. What are the errors? Look at here. You can see the problems. The problems are here. There are no P number, provisional diagnosis is not there, NR's name is not there, ID is not there. Although the doctor who was admitting him has been able to mention the date and time. So on the right-hand corner, please look into that and make sure everything is filled. Here you look at, this is capacity assessment pro forma, nothing elaboration is done. That is the biggest error. Please write the elaboration, because it is clearly mentioned in capacity assessment guidelines. If you are making any interpretation, yes or no, you have to give your logical explanation. Do not write just yes or no or tick it, because you have to explain. If it comes after maybe 1 year down the line to the mental health review board, challenging your admission, challenging the treatment you are given, that explanation should be there. If you don't have explanation, that means you will be in soup. So those, if yes or no, provide explanation is written there. Nobody has written. So that's the biggest problem. We are finding it. And I request all our health professionals to do that properly. Coming to the other again, if you look at this again, explanations are not given everywhere. This is the biggest mistakes which are happening. Now coming to this again, if you look at the error, the doctor's signature is not there. Signature of the NR is not there. Time is missing again. This is again the documentation error. And if it is challenged in the court of law, friends, I'm telling you, it is very difficult to defend you. Please make sure these are all filled properly. These forms are available in the rules, and Form C, Form A, Form B, D, all are available. Please make sure when you're admitting the patient, all these forms are in place. Coming to section 30, that is section 89, capacity assessment has to be done before admission. Form E has to be filled. NR has to sign it, and independent opinion from the 2 doctors. One doctor, that is psychiatrist, another is a doctor or a mental health professional. It is an independent opinion. Don't take a signature on the same page, because independent opinion means it's separate. And many a time, both the doctors have signed it at the same time. I will show this problem which has occurred. Independent opinion that has, and 3 capacity assessments should be available, so that you don't miss when you admitted the patient, where there is at the end of 7th day, 1 capacity assessment form, 14th day 1, and again 21 day. And if the patient doesn't improve, you will be shifting to 90. So, and also you should have the request for discharge by independent patient if it is there, because he has improved. You have to have those forms to be filled. And again, these are again for the beyond, that is section 90. Again here, 2 independent opinion of the psychiatrist is required, and also keep the 6 capacity assessment forms there in the file, so that when the patient is admitted, name those capacity assessment form when to be done. Either the sister or the nurse who is there, who knows about it, and you have trained her, or you have to do it. So keep those available and do it. These are the things which you can see here. Again, patient is admitted at 8:27, but unfortunately the capacity assessment and the admission is signed at 11 a.m. Imagine, patient is admitted before, and the assessment and the forms are filled at 11 a.m. That means you have not done the assessment before admission. This is again, it's the biggest mistake which they have done. Although the patient has been seen before admission, but it is documentation wise 11 a.m. is written. And if you look at the right hand corner here, the time is 7. It is basically the time 8:27 a.m. and the admission is at 11 a.m. That's completely wrong. The form should be filled before admission. So this is again summarizing the whole thing. And these are the mistakes which are being occurring. Please don't do these mistakes. Try to fill all the proformas. Assessment, again, I'm repeating this. Explanation has to be written. Without explanation, the capacity assessment is null and void, because the guidelines are very clear. And also all these procedures to be done. And I think I have explained all the things what I wanted to tell. And now I request the organizers to take over.
Yeah, there are few questions in the chat box, so you can answer them.
Yeah, right. Just a minute. I have to stop sharing this. Okay. So we have time, no? Because we have taken 1 hour when we started at 11:55.
Yeah.
What if the patient has a mental illness, addiction, both, and what should one do? This is, I think, by Dr. Nitin Dalia. Of course, if the patient doesn't have the capacities, it takes it. And if the patient has both, you have to treat both. That's the basic answer. Addiction, as Dr. Bakshi has already responded to it, addiction is also a mental illness. Mental illness already, if it is there, it is a mental illness which has to be treated as per the Mental Health Care Act of 2007. And Dr. Balchandar has asked what special cases should be kept in mind to avoid trouble. Let me be very clear. There are prohibited procedures. Don't do that. If the patient, you are isolating them and locking them up, which is clearly prohibited, don't do that. Emergency city, prohibited, don't do that. So they have prohibited procedure, I think in section 97 or 96, I think 97 may be there. Don't do that. They have clearly mentioned that. And don't give direct ECT under no circumstances, because it is clearly prohibited. If you do prohibited procedures, dance to the music of the law, don't do it, because they are clearly told that. That is my sincere advice. No lawyer can protect you at that time. So prohibited procedures, regulated procedures. If the restraint, if you are using, there is a procedure to do it. Psychiatrist has to authorize it. You have to document, and also the forms are there, which has to be sent to the SMHA. Please do that. Follow the documentation, follow the rules, and follow the Mental Health Care Act by spirit. Any other questions we are missing, Dr. Balchandar and Dr. Manik?
There is one by Bakshi sir. It is rather explanation. So if you are called for treatment of delirium, basically, so will you suggest the treatment shifting after 72 hours? So obviously not, because primarily diagnosis is important as per this act. So that is, he himself has written that. One interesting question by Bhave sir is there. I'm just searching for it.
Decision in MHRB, if not,
patient stays beyond 72 hours because of medical problem. That is a question.
Sir, can you please repeat? I could not hear.
In medical setting, the patient should be transferred within 72 hours. That is the explanation. In case the medical problem is still there and needs to stay beyond 72 hours, so what to do?
Yeah. So here, that's an interesting scenario, sir. The physician has to document that patient is primarily admitted for the medical illness, and it is not that he is admitted for the psychiatric illness. So obviously there is going to be a comorbidity. Rather, our patients are the ones who are most vulnerable for cardiac illnesses, strokes, and all the metabolic issues as well. And that is not because of medicines. Again, there are genetic factors and biological factors that are proven for that. So it is primarily admitted for whether medical illness or for the psychiatric illness. If a physician is admitting your patient for treatment of depression, that is the diagnosis, then yes, he should shift to an MHA. If he is admitting for the treatment of diabetes or uncontrolled diabetes, and depression is a comorbid disease, then obviously you will just write the treatment, and he will be getting treatment for the diabetes. If the patient feels that he needs further treatment for depression, and he as an inpatient later, once his diabetes is settled, then he should be shifted to the MHA rather than again continuing treatment in the medical setup.
Okay. I think Professor Manika has explained, but I would like to give answer from the legal point of view. See, we think these legislations are sacrosanct. That is basically Mental Health Care Act is very rigid. Let's understand. Above Mental Health Care Act, something called as Constitution of India. All the courts are protecting guardians of the Constitution of India. There is a legislation, Mental Health Care Act. Imagine if the patient's life is at problem, or maybe the life has an emergency issue, whatever it is, document it and say, to protect or to prevent the death of the patient, I am taking the Article 21, right to life and liberty, and I'm treating, considering there is law problem, but I'm treating because of this. And if there is a colleague, take a signature, go ahead and treat. And this we have been consistently telling in National Law School, Bangalore, because there is a postgraduate diploma medical law ethics we are teaching there. There we clearly say that in emergency situation, if there is a medical issue which is an emergency situation, don't wait for Mental Health Care Act. There is a Constitution of India, Article 21, right to life. You have to protect the right to life. That is the prime importance of all doctors. And we have to do that. Don't say that Mental Health Care Act is not there, and by chance it goes to High Court. The High Court will say, boss, you are a doctor. Before that, you are a citizen of India. You are supposed to protect the right to life. So the Constitution of India overrides all legislation. Just don't say that this is a legislation. So please go ahead and protect the right to life. Don't think about, many a time our doctors are becoming defensive. The simple reason is legislation. Think about the Constitution of India, which has been beautifully written, articulated, right to life and liberty. All doctors should read about this. And even all healthcare professionals should read about this. And that is where you are going to get if you are doing action in good faith. And even if there is a patient who is wandering mentally ill and he is not able to take care of himself, I would rather say right to life and liberty is there, where you have to say right to life is at jeopardy because he is wandering at large. And this happened many times in our COVID situation. Patient, no family members are there. He is wandering around and he is brought there saying our hospital said, oh, there is no ID card, what to do? We had to explain our administrator and say, go ahead and treat right to life and document that, go ahead and admit and say these are the problems. Later we will send it to the maybe MHRB or the court, whoever is there nearby, or to the district legal service authority, inform them, telling that there is not yet formed and we are informing you. You are the legislator, you are the person who is going to protect the rights of the persons with mental illness. So I urge all our health professionals, mental health professionals, patients, family members who are attending this seminar, there is something called as legal aid. In district legal service authority, in every taluk, there is taluk legal service authority. They are situated in the court complexes of your place. It may be any taluk, maybe a taluk where there is a court. Go and ask who is the member secretary for taluk legal service authority. If it is a district legal service authority, if it is a metropolitan like Karnataka or maybe Bangalore or maybe Mumbai, ask where is the district court and district legal service authority. If you don't get response from there, approach the High Court legal service authority and ask them, I'm not getting help, because this is again a proactive legislation, something called as National Legal Service Authority Act of 1987, which gives you free legal aid for persons with mental illness. And it is the responsibility of the judiciary or the legal service authority to provide free legal aid for persons with mental illness. And if you are a senior citizen, again under Senior Citizens Act, or if you are a disabled person, again, you are entitled for free legal aid. Please avail these services. Many people do not know about this, and I request all our psychiatrists, psychologists, social worker to encourage and also inform about this free legal aid, free legal service authority that is available in all district courts and taluk court. Over to Dr. Balachandar.
Yeah, thank you very much, both the speakers. It was indeed a very great lecture. I hope many of our doubts have been cleared now. So before now we will move to the next session. Before that, there is an important announcement that we will not be taking lunch break so that we can manage the time. Okay. So now we will move for the session 3. It is the learning from experiences and where we are. Functioning of State Mental Health Authority and Mental Health Review Board. This is the panel discussion. Chairperson and moderator for this session is Dr. Vihang Vaiya. He is the senior psychiatrist and professor emeritus of the Psychiatry, Mumbai. So I now hand over session to Dr. Vihang Vaiya for further proceedings.
Thank you. Thank you, Dr. Balachandran. I
I'm indeed happy and thank you for this singular opportunity to moderate this session. We have an astute list of panelists for our group. Dr. Nimesh Desai, who's known to almost every psychiatrist in the, not almost, every single mental health professional in the country knows Dr. Nimesh Desai. He has been a psychiatrist who has been promoting psychiatry at every sector, including the parliament. He served at the IBHAS for 23 years and initially he was head of the Department of Psychiatry and Medical Superintendent. He has been a member secretary and interim CEO of Delhi State SMHA, and he has been actively involved in implementation of MHA 1987 and MHCA 2017 at IBHAS. He has nearly 100, I think he is now more than 100 research papers, multiple monographs, and has 5 national awards for his original research. Dr. Nimesh Desai, I welcome you to this panel discussion. The next one, Dr. Sanjay Kumawat is a consultant psychiatrist. He is my very dear friend who I kind of fall back on for all my medical legal advices. He is the director of the Insight Mind Care Center at Thane. He has been in the past Deputy Director of Health Services, Government of Maharashtra. He has been a medical superintendent of the Regional Mental Health Hospital, Thane. He is a member secretary of the State Mental Health Authority, Government of Maharashtra. The next panelist, please. Dr. Chandrasekhar. Formerly the professor and head of the Department of Psychiatry at the Bangalore Medical College and Research Institute of Bangalore. He is now retired. He's got multiple points to be mentioned about him. Besides, let me just summarize all these lines into saying that he is one man who has understood the relevance of MHCA at the government and now at out of the government institutions. He has also been a recipient of multiple awards. He has been interested and established Manasa Kendra and government-run institutes for rehabilitation of the mentally ill. He has been on the TV for 179 episodes in the Doordarshan Chandana 9 Mano Chintara live phone TV programs every Monday from 8:30 to 9 a.m. and he has 9 a.m. and he has successfully conducted 500 episodes on Mano Chintana radio program. So he's a man who is equally into professionalism and giving the right direction to the mental health, right information about mental health services to the general public. The next speaker, please. Dr. Rajesh Sagar, professor at Department of Psychiatry at the AIIMS, Delhi, and member of the Central Mental Health Authority of Government of India. He has been the chair of Global Burden Diseases in India, and he's the honorary professor at the University of Melbourne in Australia. He's honorary visiting professor at the University of Leicestershire in UK. A number of publications, more than 500. Major achievements, advisor. He's been recipient of several awards like Outstanding Researcher and other orations, award of ICMR, PP award, IPS and other awards. The next speaker, please.
Yeah. These are the 4 panelists.
Right. Is that we have Dr. Now, may I start with what I want to let people know of what we want to do? Sorry. Let me try and share a set of slides which I thought I would start with. Am I seen? Are the slides visible?
Yes, yes.
Right. So this is West Zone Maharashtra and Maharashtra branch on learning from experience and where we are. we are going to discuss functioning of state mental health authority and mental health review boards. Now, for my panelists, I want to emphasize that we are going to focus on standalone psychiatrists. We have just concluded a very nice session, which was chaired by Dr. Suresh Badamat, and a whole lot of issues that are of relevance to practicing psychiatrists were discussed. But besides the relevance of those issues which involve MHE, mental health establishment, we have to realize that largest number of psychiatrists in the country do not work at the mental health establishments. They are standalone psychiatrists who practice out of their clinic without a residential facility. So they don't have a nursing home where they admit the patients. So without prejudice to a lot of issues that are kind of brought up against Mental Health Care Act, including the lawsuit which has been now pending in the court in Maharashtra, we have today on our panel astute clinicians who have hands-on experience of applying mental health care in patient care, Mental Health Care Act in patient care at institutional as well as at clinic levels. There are frequent discussions on laws guiding mental health care which apply largely to the mental health establishment. Dr. Suresh Badamat also pointed out that some of the laws apply not only to mental health establishments, but mental health establishments in government sectors, not even in corporate sector. So it's highly selective and there is being debated. Majority of the mental health in standalone clinics practice or need to apply Mental Health Care Act in the consultation room practice or in psychiatry OPD of corporate hospitals where they do not have admission rights, but they are into liaison psychiatry more often at outpatient clinic. So these multi-specialty hospitals, this issue was brought up in the last discussion and we probably may not need to elaborate on that. So let me start with Dr. Nimesh Desai, sir. Sir, IBAS was perhaps the first institute in the country to apply MHCA at the institution, MHCA 2017 at the institutional level. So could you please share your experience of how you educated the staff and what was the new staff profiling that you required to implement in your institution and your experience on software of the MHRB, the review boards. Off my slides, Dr. Nimesh Desai, please.
Morning, Vice Sahib. Thank you. Thank you so much. Thanks to you, Vice Sahib, the moderator and the organizers. I won't go into thanking every organizer, but really, thanks for having me here. I have finished my tenure with IBAS a month ago, and so I'm now possibly in that standalone chamber practice. Besides those two aspects, for last 10 or 15 years, through SMHA Delhi, I've also coordinated and helped, I wouldn't even say supervised, but coordinated and helped standalone chamber practice, individual nursing homes, general hospital, private and government nursing homes, which is now under the MHA 2017. But to your first question, yes, 28th May, when the Government of India declared the MHA is implemented, 2018, 29th May, we were ready because for a few months before that, as you are aware and a few colleagues are aware, including my friend Suresh Badamat, we had been preparing the performing and the hardware and the software for implementation. So the IBAS implementation level has been easier. I will possibly get time to come to a few issues, final nuances. But the private nursing homes, also through SMHA Delhi, we made sure within the first week or 2 weeks that we were consulting with them. In fact, in the first 6 months after that implementation, we had a series of sensitization workshops and meetings with government hospital departments as well as the private nursing homes. And so that is how I think Delhi has been okay in terms of implementing what I see as the spirit of MHA 2017. And I am quite a lot with Suresh Badamat in what he said. The issues about individual practice, if I might take up that, sir, as you said, Suresh has clarified it, but I just like to add what my understanding is. there has been a debate and a lot of fora about whether all provisions of the MHA will apply to a standalone practice, chamber practice or not. And that's something that we have to be seen. As of now, obviously it doesn't, because it doesn't get qualified as an MHE, as you clarified. What I think we need to understand is that all the provisions of the MHA driven by UNCRPD, especially about rights, will be applicable. For example, there cannot be an argument that because I am not an MHE, I will go ahead and do one of those prohibited procedures. What is prohibited in section 95 is prohibited everywhere. The access to records will be as per the concerned sections. So both issues of rights and the rights of the patients and obligations of the provider will apply regardless of the setting, my understanding. And that's the first thing that we need to realize, not try and find ways out of provisions of MHE. There is also the provision of making a register digital on a web register of all the practitioners, chamber practice, as well as psychologists and social work colleagues. I am not aware of any state that has begun to do that. We have begun to do that in Delhi. What's also been possible, and I must take this stance, is that in Delhi we took the position with 2 SMHA meetings after the implementation of the Act. And may I remind everyone that section 126, especially subsection 3, provides for continuation of SMHA as per the previous composition till the new SMHA is formed. And so what we did was we had the old SMHA functioning with the chairman continuing to be the same, with added composition of all the members who the new SMHA required. And we have taken the position that we'll focus on the functional aspects. One, registration under section 65 of all the MHEs, and that has been done from time to time every year. Provision of MHRB, one temporary part-time MHRB that we have at least for the 11 districts of Delhi. And so all the grievances or complaints that need to go to MHRB go on. Obviously, the Delhi possibly is one of the few states that has, under the High Court and government supervision, had minimal standards prescribed, MHEs. And one of the issues that have come up in the previous session, we have minimal standards not only for acute care, short-term psychiatric care facilities. We have separate set of standards for long-term rehabilitation care. We have a set of standards for dual diagnosis. We also have a set of standards for drug dependence treatment centers. As many of us are aware, quite a few states have NGOs functioning as drug treatment and rehabilitation centers. And to my awareness, many, if not most states, do not have this clarity about drug abuse treatment centers being covered under MHA 2017 or being monitored by SMHA. We have fortunately made this clear. And so we have minimal standards for all categories of MHEs, including drug abuse treatment centers, and they are being implemented. I have some experiences about MHRB and the implementation at ground level that if you have a chance, we'll come back to, sir.
Thank you, sir. So essentially what Dr. Nimesh Desai so clearly and categorically mentioned to us is that psychiatric practice outside MHE fulfills the basic tenets of medical practice. We are answerable to our patients and we have to follow every single regulation that respects the patient's independence and the rights of transparency in medical care. We have these concepts of EMR and EHR that have been documented and published, I think, a decade ago. They are not being emphasized or they are not being practiced. We have to maintain records, preferably electronic medical records. And at some point in time, EMRs of every person will get compiled into EMH. That is what we hope will happen sooner than later. We have, where is it gone again now? I'm sorry, but my slides keep getting messed up. All right. So we have Dr. Chandrasekhar. Am I now visible again? Are my slides visible now?
Yeah.
All right. So we have Dr. Chandrasekhar, and for you, sir, I have some specific points. You have applied MHCA in public sector mental health establishments in Karnataka. Now, could you please share your experience on the website of your state mental health? Have you appointed an officer on special duty? And what are the norms for the number of state health review boards in the state of Karnataka? Do they differ from the central directives? Having established MHRBs, what are the problems in communication and coordination of several issues between mental health practitioners and mental health review boards? What is the time delay? What does one do in that time delay? Doctor, the previous session had touched upon this in some ways, that essentially it is the right to life, section 21, as Dr. Suresh Bhatt mentioned. The point is, 21 mentions about length of life. It doesn't mention about quality of life. In mental health practice, we are more involved not so much with life-threatening illness, but quality of life-threatening illness. So how do we differentiate between the two? And when it comes to MHCA and rehabilitation centers, so how many rehabilitation centers do we have, and what is the population for which there is some norm of how many centers for how many people? Should they be in corporate sector or public sector only? And what about residential care, which was touched upon, but maybe you would like to tell us a little more about it. Dr. Chandrasekhar.
Yes, sir. Sir, I would like to share the screen.
Please.
Okay. I will start with a brief introduction about what has happened in our Karnataka state. Sir, what is the current status? And at the outset, thank the organizer for giving me this opportunity, and Professor Bihang for a very nice introduction of me. So what I'm going to take is, I'm going to talk about chapter 8 and chapter 10 of Mental Health Care Act of 2008. I just briefly present what we have done in the Mental Health Authority. And as far as this website of SMHA is concerned, we have established website since 2014. So it has, it is, I think we have taken a private vendor. Now we are going to take it from the government. So it has all the members of the authority, all the acts, and list of registered mental health establishment, list of registered mental health professionals, and all other awareness material. Most importantly, we had almost 5 writ petitions in the Honorable High Court of Karnataka, and all writ petitions precedents regarding the awareness of the mental illness and availability of mental health services. So that's why we have DMHP in all the districts. We have even going towards PSCs also, where we have Manochintana clinics. So we have completely established the official and non-official members of the authority. And in that, I would say Additional Chief Secretary, Government of Karnataka, Health and Family will be the chairman, and Professor and HOD, Department of Psychiatry, BMCRI will be the medical advisor. We have Commissioner, Health and Family, who is a IAS officer, will be the Chief Executive Officer in that. And we have all other members. And as far as non-official members are concerned, we have I think number 2, Dr. Narayan Prakash, who is a Ayush MD, who is also a member. And we have professionals, NGOs, family caregivers, and patients are also in there. We have completely, all the decisions are taken in the meetings. Some of the decisions taken, I will update little later. And we also have an Office of the State Mental Authority in the Arogya Soda of Bangalore. So we have following step in that. In that, Commissioner will be the in charge of the Mental Health Authority. And of course, most of the action will be taken by the medical advisor or the additional member secretary. That is the name given to him. And we have a legal advisor who was a district retired judge who was appointed by us. We have a AU, assistant administrator, who is a government gazetted officer who works under the medical advisor. We have first division assistant, program coordinator, IT programmer, data entry. So importantly, is officer special duty. In fact, right now we are in the process of appointing the mental health review boards. So all the complaints, all the RTIs, all the court cases are taken up by the legal advisor, and yeah, he's got a lot of work to do right now. So many complaints or many role of the mental health review boards are being advised by him, and of course we always get the inquiry done by the district level district health officers, and then take appropriate action. Another important thing about Karnataka is we have been made our own state mental health care rules 2021, which was approved by Government of India, and it was gazetted on 18/10/2021. And in that, I want to specifically talk about this chapter 2, legislation by reference, where we are just following central mental health and MHRB rules. And as far as mental health management system is concerned, so Karnataka mental health management e-portal for registration was inaugurated as early as July 2020 by our Honorable Chief Minister, and we have started online. It's a very good website. I think it is formed in coordination with NIMANS and IIITB. We have given good funding from Government of Karnataka. It's a no contact process. Everything happens online only. So already we have registered 193 professionals, and including psychiatrists, and 78 mental health establishments. In addition to whatever previously registered, it will be almost 200 mental health establishments have been. Of course, these are all the functions of the mental health management system with comply with Mental Health Care Act. That is registration of mental health establishment, registration of MHPs, State Mental Health Authority portal to approve. We actually just go through the website and approve the thing. Mental health review boards, we have made a provision of accessing the basic medical records of inpatients and outpatients, advance directive, nominated representative, and as provision of grievances also in this. It is coming out well, and of course all these things has been discussed very in detail with the NIMANS people, especially Professor Suresh Badamat and Dr. Naveen and Dr. Rajini. They have all made such a wonderful website, and everything is OTP based. Nowhere a person can access another mentally ill person's records by without OTP. So that is how this MHMS comes. And so as far as MHRBs are concerned, we have made some regulations. I just want to tell what is the current. Currently, there will be 6 members of the, I will not go into the details. And these are all the functions of the mental health review boards, like, register, review, modify, cancel, advance directive, appoint nominated representative to review application person, MIR, NR, against decision of medical officer, Section 89, 90, to receive and receive application respect of non-disclosure of information. So we have made a website which will be able to fulfill all the criteria. So based on the actual workload of the board in the state and number of persons with mental illness, number of mental health establishments, so we proposed to totally 11 mental health review boards in Karnataka state, where we have 30 districts. So one mental health review board for every 3 districts. But however, like previous speakers have said, we had shortage of funding. And then at the first step, we thought, we'll have a revenue division wise mental health establishments. This is the list of mental health registration in the previous act. More than 54% of the mental health establishments were in Bangalore division. Then Belagavi division only 10%, Mysore division 18%. Based on that, we have made a division-wise mental health establishments, mental health review boards like Bangalore. Then it will be placed in NIMANS Bangalore. They are going to provide us accommodation and other facilities. Then Bangalore division, District Hospital, Tumkur. Mysore division, New District Hospital, Mysore, Belgaum division, NIMANS, Dharwad, and Kalburgi division. We have actually almost written letter to all these places to provide us the place. And this is the conservative estimation of what will be the expenses. I think this is done after discussion with our finance department and various mental health authority meetings. So approximately we are paying 1 lakh rupees for the district judge, psychiatrist 1 lakh rupees, 80,000 for medical practitioner, FD and all other things. And as non-official members, you are only giving the sitting allowance and daily allowance and transport allowance. Totally, we have estimated 50 lakhs per mental health review board. And then how we are going to appoint is another thing. This has been done various discussions and deliberations in the mental health authority. So district judge or a officer of a retired judge will be appointed on contract basis after advertisements. Representative of deputy commissioner district, which board is to be established, shall nominate representative as the member of the board. Then till the government sanction, there's no, right now we have not yet got the sanction of the post of medical practitioner psychiatrist. So posts of psychiatrist and medical practitioner, they'll be selected from government medical college or district hospital among the permanent faculty, preferably without administrative posts. They will be working in MHRD on deputation, and same thing as far as medical practitioners and members who shall be persons with mental illness or NGOs or caregivers. Based on documentation, we are going to advertise. And this is the advertisement we gave about almost a year back. And we had requested for 5 chairpersons and then 10 non-official members for the mental health review boards. We received quite a good number. In fact, for 5 posts, we received 19 applications, which we have done the processing. We included retired High Court judge for selecting the best people. And we have actually selected 2 plus 5 people, like, in the waiting list to start like that. And terms and condition, all this in the act. So what I want to tell is, these are the timelines. For example, section 82, it has to all the decisions challenging admission of minor, challenging supported admission at section 89. A period of 7 days is only given for MHRB, and application supported admission to section 90, 21 days is given. Other than that, 90 days. Based on this, we have to have that. So we have requested the infrastructure for mental health review board as follows. That is 4 rooms, 1 for chairperson, other for members to come and sit, hall of for proceedings, like, almost like a court hall with camera, because most of the proceedings will be held under camera. And there shall be a waiting room, and there shall be a room for, of course, supporting staff. We have to appoint especially Group D, clerical staff and a driver, and furnitures, equipment and stationaries for the above, transport for visiting MHEs and prisons. And of course, right now the challenge is getting the medical practitioner and psychiatrist. And so one more thing is, as far as private practice in the outpatient, I think as Dr. Nimesh Desai said, there is no question of getting a license, no registration for a mental health establishment, because it does not come under the purview of the mental health the establishment definition. But if he is going to admit, then he has to admit in a mental health establishment which is registered. Answer your question, sir.
Thank you. Will you take off the slides, please? Hello, will you, Dr. Chandrasekhar, you need to.
Yeah. I am trying, sir. Stop share. Okay.
So as you stop, thank you very much. That was extensive discussion on the back office work of mental health review boards. How much does this affect a clinician in the field who's not a part of the mental health establishment? Over your experience, how many standalone psychiatrists have had to refer the cases to the mental health review board? And one important question is that when the mental health review board takes a decision, who's the final authority? The psychiatrist or the judge? Does the judge decide what is good psychiatry, or does the psychiatrist decide what is good psychiatry?
So what we are thinking is, probably psychiatrist will be the person who will guide the judge. But as a chairman, he will have extra vote to make all prominent decisions. I feel, we are actually organizing 2-day training for the MHRBs. So probably we'll train them so well that, of course, Act also says that, so no psychiatrist should be just some penalties should be given, as the Act says. So probably psychiatrists should dominate all the things. So we are looking at, very senior psychiatrists who are going to be member of.
So 2 days of training cannot make a judge an expert at mental health issues. That's the whole message you are trying to give. And the other message you gave is that the government, at least Karnataka, has set up extensive establishment of the backup services of whatever the legal help that a psychiatrist might want, or whatever the legal help that a party stakeholder might hold against the psychiatrist. So does this put psychiatrists in a defensive practice like Dr. Suresh Badembat kept mentioning, or does the psychiatrist feel that his decisions will be actually backed up by the MHRB so long as they are academically sound decisions?
Sir, as far as my knowledge, last maybe 4 years of implementing Mental Health Care Act, we have rarely received a complaint against a psychiatrist.
Rarely.
Rarely. One death happened in a mental health establishment. It was not registered. That has been pending.
I see.
Yeah,
So-
really, people will.
So can I conclude or summarize your presentation into telling my colleague psychiatrists in the recent areas that MHRB is not a punitive organization. It's an administrative organization which will facilitate your practice and should not stop you from, practicing state-of-the-art psychiatry for the fear of a punitive action by an MHRB, by a judge who might be ignorant of psychiatry, take a decision based on concepts which are 50 years old. MHRB will stand by you, because then the psychiatrist in the MHRB will be able to correct the judge and teach him the newer developments. Would that be a correct decision? Could that be
Absolutely, sir. We are actually looking at judges who will allow a simple psychiatrist to practice in a taluk hospital without much tension.
Without much tension, yes.
That is the objective of our act.
Because when I heard your presentation, I really thought I should give up psychiatry and go back to a law school before resuming my practice. But that doesn't have to be so. Thank you. That's very nice and very interesting. And we move on to the next speaker, Dr. Rajesh Sagar. Sir, in your opinion, what is the jurisdiction of CMHA over SMHA? Can the Central Mental Health Authority dictate the State Mental Health Authority in their decisions on an issue, clinical issue? Then how many CMHAs are established in India? I believe they are only in central government territories and centrally ruled territories, not in the state level of any kind. Then what would be the support and the directives from the Central Mental Health Authority to the State Mental Health Authority? So at the state level, is the State Mental Health Authority the final authority, or somebody who's grieved, who's a grievance against the State Mental Health Authority, have a right to approach the Central Mental Health Authority for grievance resolution? Dr. Sagar, over to you.
Good afternoon to you and good afternoon to everyone. And it's wonderful to be here, and good afternoon to the organizers. And we are having such an important discussion. And since I will only speak since I'm a member of Central Mental Health Authority, though I have attended few meetings of Delhi State Mental Health Authority with Dr. Desai. And also many years ago, we conducted 2007, the meeting of all SMHAs. That was, in fact, I have been telling central government to conduct a meeting of all SMHAs. So what is important, I think, just to update you with regard from Central Mental Health Authority, like we had our first meeting in 2018, November, and our last 4th meeting was last year. That we are having every year a meeting, and last meeting was in April 2021. And many such discussions have taken place. If I can update my colleagues, in the country, right now, from all states and UTs, 8 states and UTs have the framing of rules have taken place. Just to update you, Andhra Pradesh, then Jammu and Kashmir, Karnataka, Kerala, of course, Karnataka, Dr. Chandrasekhar had presented. Maharashtra, of course, the rules have been framed. Then Odisha, then Uttar Pradesh and West Bengal. So these are 8 states where the rules have been framed. Now, as far as this MHRB is concerned, there are from 8 states. Now I can hear Karnataka also. So 8 states, the MHRB have been constituted. And just to update you, these are Himachal Pradesh, Meghalaya, Punjab, then Sikkim, Tamil Nadu, and Tripura, Uttarakhand, and West Bengal. So where the MHRB has been established. In fact, we could see some of the ads for MHRB positions and so on. Now, the state mental health authority, in fact, CMHA have been writing to all the states, all the principal secretary since from the first meeting itself. And at the moment, whereas 28 states already have been established. Most of the states and UTs, they do have SMHAs, but many also do not have at present also. So I think, this is the current position as far as SMHA and MHRB is concerned, and this is for the information what we have got from central authority. Now, the important question what you had asked, I can tell you, initially there was a lot of confusion was there about MHRB, that the central authority will fund, or central authority will in a way will give a financial support for MHRB, which actually is not true, because it's very clear from central authority, it's a state subject. In fact, it has been documented, and it answers your question also, that state has the independent authority as a state subject, and the MHRB is a totally a state, that they will have to have a finance for that. CMHA is not will support for MHRB. That's one. The other thing is that in 2017, some funds were allocated for SMHAs. I can tell you 2 lakhs, 7 lakh for recurring, non-recurring, and they were dispersed in 17. But some of those funds are being allocated here, and the discussion is there whether we can support in a way. And CMHA is aware of the difficulties, problem with the implementation, and whether in the next course some changes can be made to ease out some of the phenomena. So these are the some of the discussions which have been there in the previous meeting. Now, as far as CMHA is concerned, since you had raised this point, many such activities have been done. The one which were prescribed by our MHCA, that the capacity assessment document was prepared, advanced directive, the how it is to be done, that has been made, regulations have been made, and also the minimum standards have been made. So what all was the way was prescribed, that all has been done. What's the CMHA, and not only this, also the kind of the material for training of police and judiciary, those all, even the caregivers. So some of those materials also have been prepared, and they are available. In fact, the talk was there. In fact, because of COVID, it could not materialize to have a separate website for CMHA with FAQs and all, which also has been discussed. So as you have been asking, the question was that how many CMHA? Yes, there is only one right now, and all the central government institution will be part of it. Number one, not only central government institution, but also the railways, the army, and which are part of the central government. They will be the hospital which come under that will be part of CMHA. So already this has been noted. And so that answers your specific question. So I think these are some of the responses. And primary, it's a state subject. Health, we all know. and the state will have is the authority. And in fact, CMHA can overall coordinate. In fact, we had a meeting of all SMHA sometime many years ago. So, but after all, it's the responsibility of a state. So I hope I have answered your question. If there is anything more, I think we can discuss it further. Back to you. Thank you.
That was very nice, sir. Precise, and you were exactly on the dot. About the discussions that had come up in just before you started talking, Dr. Rajesh, is that we had asked the question whether in a MHRB, who decides, the judge or the psychiatrist? And there is a clear answer by Dr. N.N. Raju, our president of the Indian Psychiatric Society, that it is, of course, the judge who will take a decision. But then Dr. Nimesh Desai went a step further to say that all decisions in the MHRB are not necessarily by consensus, but it has to be by majority. So if the votes are equal for and against a particular issue, then only the judge would give a casting vote. The decision will not be an individual vote of the judge. So a field psychiatrist in the field would have that comfort of talking to other mental health professionals in the review board as the decisions get taken. And Dr. Nimesh Desai also said that in Word, provisions of the MHCA are rather restrictive and in more ways than punitive. Dr. Suresh Bademat has said that he has actually put his YouTube connection, link for us to be able to take a decision. Let me just go through the points that have come so far. So, Dr. Nimesh Desai also highlights that if a psychiatrist in practice has an MHRB decision which is not acceptable, then only a high court can reverse it. It cannot be reversed anywhere else. And Dr. Bhalchandra has asked a question for Dr. Chandrasekhar. He says, is there an audit of MHE in Karnataka? And when the Karnataka Mental Health Review Board audited mental health establishments, did they find any issues that Dr. Chandrasekhar might like to highlight?
Sir, minimum standards have not been framed in Karnataka. We have made a committee under the chairmanship of Director Nimans for framing the minimum standards. As far as audit has not found, because we are only issuing provisional registration to all the mental health establishment. So only minimum standards happen, then only that will come.
All right. So then we will get to know more about it as we see more of issues coming up when minimum standards are established.
Yes, sir.
All right. So I come back to the last speaker on the panel. Now let me again share my, okay. So Dr. Kumawat, before I put a question to him, I want to highlight that, you know, silent waters run deep, they say proverbially. Dr. Kumawat is one of them. He is a man to go to for my colleagues in Maharashtra and West Zone in general. He has the ability of grasping a situation, and somehow he always finds an answer which is an all-win situation, all-win answers. And he is one of those guys who has never been on page 3, but he has all the answers to the issues raised on page 3. And I'm so happy that Dr. Kumawat is here today to represent the status in Maharashtra.
On session 3.
And it's, yes, Dr. Kumawat. So may I ask you a very few, actually I got several questions for you. Say when the psychiatrist prescribes medicines, oral medicines or long-acting injections without being attached to an MHE, do the rules apply differently? Do the practicing psychiatrists require a written consent before prescribing a long-acting drug? The issue of in private practice has been touched under GA, so we need not repeat it. But what about the ketamine therapy? Does a psychiatrist who want to administer ketamine drip in his own clinic, does that psychiatrist require a special license? Because that also involves more often than not an anesthetist to stand by the patient. ECTs in the previous session was mentioned that requires an ECT, so no question of doing it in private practice or patient's house. What about ketamine therapy in the psychiatrist's clinic? Then, of course, there are several messages have been going on amongst psychiatrists who are in standalone practice. So please share your message for psychiatrists in consultation practice who are not attached to any inpatient services. And they would like to know the registration of mental health professionals and the directory that needed to be made with various clauses. For example, the obligations of a mental health professional in a city like Mumbai, Pune or Nagpur would probably be different from the obligations of a mental health professional in a remote area. Is there a city-wise recognition of mental health professionals? For example, in mental health establishment, mental health hospitals, MBBS doctors who don't have a psychiatric degree are also for the purpose of MHCA considered psychiatrists. Is there similar provision for nurses who are not psychiatric nurses, in fact, auxiliary nurses with decades of experience in mental health clinic? Then what are the challenges and solutions in communicating with the authority? How easy is it for a guy like me to speak to a guy like you? Then what about the rules and regulations? Should they be in which language? Marathi, Gujarati, Hindi, and what other languages? And who does the cross translation? What are the minimum standards for the MHE in different categories of cities? Then the question of confidentiality for this was answered in the previous meeting. What about the guidelines on issues and practice of cross-pathy? And the clinical psychologists being allowed to give prescription of psychotropic drugs. This issue of unregistered de-addiction centers has been already addressed, so we need not answer it just now. And the coordination between MHEs and other agencies like police. Apparently in Karnataka, it's easy. Dr. Suresh Bademat rattled out the clauses under which the police can be asked to intervene. Does it really happen in Maharashtra? How easy? In Mumbai, it's not that easy that I know. Resources allocation for recognized to, when there's a standalone psychiatrist who cannot afford a psychologist, what does he do? And what about the training? And most of all, Dr. Kumawat, you have done this to me several times, and please share it with others. Your recommendations to allay apprehension of practicing psychiatry in the current scenario. Over to you, Dr. Kumawat.
Can you just maintain that screen so that, one by one I can answer those questions? I cannot
maintain that screen, yes.
Your first question was about long-acting injectables to be, or depot preparations in and oral medicines in outpatient clinics, right?
Yes.
Right. In this case, if the patient comes in walking, then the consent is implicit, as we have when we get a call on teleconsulting also by the patient, the consent is implicit. However, we do make them understand the treatment details, and then accordingly we can give them oral medicines or even injectable medicines. When it comes to a patient being brought by a caregiver or a nominated representative, so-called, in this case, if he has been appointed as a nominated representative, but if we generally coming as a family member, we mention the name of the person who has brought the patient, and accordingly we will give the medicines to the person concerned. Of course, the medical records will be put on paper, and it will be also digitally recorded. So that part definitely applies to office practice also. Your second question was about ketamine therapy and ECTs. Let me tell you that whenever there is no lock and key, and that the patient is not staying for 24 hours in an office practice, then Mental Health Establishment Act other provisions do not apply to him. So that patient comes for ECT, we have the IPS guidelines for ECT. If we have that infrastructure, and if the patient is going back after say 2-3 hours post ECT, after getting an informed consent from either the patient or if he doesn't have capacity, the NR, the patient, we can give ECT over there. And same thing stands for ketamine therapy also. Ketamine therapy, generally we expect that the capacity of the patient is present. And even if it is not present, if the NR is there, then we can continue with the ketamine therapy on outpatient basis. Your next
May I
question.
interrupt Dr. Kumar for a second?
Yes, please.
About
Yes,
the
please.
long-acting injections, we must caution the relatives about what are the possible side effects.
Yeah, I told you that
very tricky thing.
Give them details about the therapy
Yes,
pros
but-
and cons, alternatives available.
But
And
doctor, issue is, what is the worst case scenario of giving a depot neuroleptic? There can be an anaphylactic shock and death. So if we tell
Yes.
the patient that in the worst case scenario, I'll give you an antipsychotic injection,
Oh,
and well, the patient can die. Nobody will take that injection. So what kind of adverse effects should the relatives be cautioned about? We cannot give an exhaustive list.
see, we cannot give exhaustive list, and we should talk about the commonalities of the side effect rather than giving the rare side effects. Because even if it happens as a rare side effect, as long as our motives are clear, even in case of CPA, that with what intention we had given injection to that patient, that particular intentions will be taken in applying that we were not criminally negligent in managing the patient.
Thank you. Thank you very much.
All right. Now, next is registration of mental health establishments, mental health professional directory needed for various clauses. And it is definitely needed from the point of even the next point, that is cross-pathy, which we have mentioned. It is also needed about the mental health professional that has been trained at the district mental health program levels. Here, the nurses part, where you are talking about the nurses and their participation in implementing the mental health care. So those nurses, their training also is important. Even the private mental health establishment where nurses are other the non-parapsychological psychiatric staff is also there. Their mental health training is also important. So the Central Mental Health Authority, I learned just from Dr. Rajesh Sagar that they are coming up with manuals for this. And those manuals, if we consider them as standard, there should be some means and ways where all the mental health establishments which are registered with the SMHA state level will have to undertake that particular training, and some kind of means and ways of certification for that training will have to be given in recognition with the state branch or the city branch or the local IMA branch, which will give some kind of recognition to this training. Your next question is challenges and solutions with communicating with authority. Well, if we have a redressal mechanism, whether it is a SMHA where we can communicate with the OSD, same thing with the MHRB. We will need one particular number contact. It's not only the emails on the websites, but some numbers will have to be there wherein we can contact these people. And most important is that since we are going to give a call also and we are going to digitally mention on the mail also, we have definitely a document about informing the authority. Next authority remains is the police when it comes to either patient creating nuisance, either in the community or in the health establishment, or even there is a neglect of the patient either in the establishment or in the community, we can inform the police authority. Now, your question about the police authority in Mumbai and otherwise saying, "Ye hamara kaam nahi hai." But then we need to sensitize. I'm afraid that in Maharashtra, so much work about training of the police officers is not done about mental health mental health legislation. And as it is simplified in Karnataka, that they have to just talk about the clauses and exhibit those clauses to them, and they will accordingly follow the rules and regulations. Here we need to do a proper training to them, And after training, definitely then they will fall in line and will cooperate with us. About the rules, regulation and forms, yes, the other languages, particularly Gujarati, which is also a prominent language in Maharashtra, needs to be done. Marathi and Hindi are ready and they are awaiting central government's approval. Yes, minimum standards for mental health establishment, category-wise and city-wise. When I was member of the state mental health authority, I suggested them that, well, we should have 3 zones, that is urban, metro, the rural zone and the tribal zone. Not that all kind of mental health professionals will be, or para-psychiatric professionals will be available to each and every facility. So from that point of view, more you go in a rural and tribal zone, you need to have some kind of training to these people and then recognize them as the nurses or the, I wouldn't call psychologist and psychiatric social worker, but at least for nurses, there has to be some training given to them. And this training has to be kind of, there should be some authentication done at the state level to consider this training as authentic, and even that training has taken place has to be authenticated by the local IMA or the local IPS or the local psychiatrist association. About the guidelines on issues of practice of Krashpati, I just mentioned about it. If we have a mental health professionals who are registered, so mental health professional, we have got all the things which are mentioned in our act. They are right from psychiatrists to those postgraduates in the respective other allied fields. But if they are registered with our SMHA and SMHA has done that job, then only will be considered as mental health professionals. Rules for unregistered de-addiction center. Well, this is an Herculean task that we need to quantify and qualify the de-addiction center of the state, centers in the state. And once we qualify and quantify them, then only we will come to know that which are actually worth for registration. And those who are following those minimum standards which have been laid down by the state mental health authority. So this needs to be done. They have been, they are already, they have prepared the rules for de-addiction centers, but this quantification work has to be done and qualification work has to be done. Coordination of establishment and other agencies I mentioned, resource allocation and recognizing the resource crunch in standalone practice. Well, I did not get this question. Resource allocation and recognizing the resource crunch in standalone practice. What exactly you mean to say, please? Your mic, please. Your mic, please.
Will the state government support financially appointment of a paramedical staff through the district level mental health center? Mental health
well, when it comes to the district mental health program and the district center for mental health at the district hospital, already the district hospital is also getting a teleconsultation and also getting digitalized. So for the same purpose, they are going to recruit the necessary staff from IT. In fact, at the SMHA level in the state of Maharashtra, also IT staff recruitment process is going on for the website being formed in MOU with Nimans Karnataka Bangalore, where e-Manas software will be used over there. So this same kind of financial support is being given to the district hospital because they have a separate grant for digitalization of the hospital.
And a private psychiatrist can refer his patient to a district mental health authority.
Well, it is as per the act that since we are referring for free treatment because the patient can't afford, even a police can bring it to the private psychiatric nursing home in emergency. After that is over, being transferred to a public health establishment, and it is said in the act that the reimbursement will be done at the district hospital level.
Thank you. Thank you.
Training of clinicians and other mental health professionals in generating awareness of special situations like POXO, LGBT, and NDPS. I honestly say that we had done this for various kind of people working on this particular area. For even judiciary people, we had done for almost 300 people. We have done this training, but still a lot of work to be done on POXO, LGBT, NDPS in general awareness. In fact, the latest fiasco about the SRK case itself suggested that NDPS needs a lot of awareness. There are a lot of falsities and there are lots of myths about the act in public. And this training has been, the ownership of the department has to be taken to be responsible for this training, because everything doesn't fall as we sit here and say that public health, but everything doesn't fall under the ambit of public health. So everybody has to coordinate and does do this training. Well, recommendation to allay the apprehension, as already to voice what Dr. Suresh has said, that it is definitely a proactive thing. He said about will be defensive, but I strongly feel that too much defense will unnecessarily trouble our colleagues in MHRB, because if you see in Maharashtra, our director just now said that there will be 8 MHRBs for almost 28 plus districts. And just imagine, I have 10 admission in one district, 15 admission in another district, and another 16 admission in third district. Imagine the plight of the mental health review board's members. So it will be definitely a Herculean task. HR wise, there will be a tough thing. One of the questions which was asked in the earlier session about the MHRB and its functioning, Dr. Chandrasekhar was talking about the judiciary and psychiatrists in different positions. Dr. Nimesh Desai said that yes, the person who will take the decision, actually by consensus, the decision will be taken and the last casting vote will be of that the honorable judge. But still, I say that to give a consensus opinion, do you expect all the members of the MHRB to be present to each and every case at the same time? Because everybody's understanding of mental health is different. So these will be some practical difficulties unless that MHRB is rigorously trained, except that psychiatrists, about understanding mental health issues. Such kind of webinars or such kind of workshop should be held for entire all the members of the MHRB. Then only there will be some kind of understanding of the practical issues they are going to face. Otherwise, it will be a tough scene. So I strongly feel that to be proactive, the psychiatrist's opinion and psychologist's opinion will be taken as a final decision. And I strongly feel that the judiciary will honor their decision. They will not, unless it's an extraordinary case, override the decision.
Thank you, Dr. Kumawat. We are running short of time. There are a whole lot of questions. Some of the important ones I'll put it to the entire panel. Whoever wants to answer can do that. So how many mental health establishments can one psychiatrist be attached? Or how many establishments can one psychiatrist, set up? Mental health. So it should be one psychiatrist for one mental health establishment, or can the psychiatrist be attached to multiple establishments? So actually establish multiple mental health care centers. Dr. Nimesh, Dr. Kumawat, Rajesh, anyone?
There is no prescribed. It will have to be decided by each state, and we have some experience in Delhi about this, but it will have to be decided by each state. There is no restriction about it being only one.
Okay. Any other opinion? Right.
Well, definitely yes, that there is the law is silent about it, and if at all, when it comes to how many established, sorry, the second part was more interesting. What was the second part?
How many can one psychiatrist establish multiple MHEs? Can one psychiatrist own multiple mental health centers?
The law talks about the psychiatric mental health establishment, general health psychiatric unit, and a company owned unit. So it may come to a company where we have one owner and he has multiple establishments.
That's interesting. Okay. Can the state mental health authority take any action against unauthorized de-addiction center? Can the
Yes,
SHMS be punitive
provisions.
only against listed ones or even unauthorized one? Or does it become a law and order situation?
I think there are provisions in the Act to take action. Yes, please, Nimish, you want to say something?
Yeah, sorry. Can I say, like I wrote in the chat, one, the state SMHA and government will have to firstly bring the drug abuse treatment centers under the provision of MHA and SMHA. It is implied in the law, but that will have to be done like we did in Delhi. My own view in Delhi that has been held by the government and the concerned court agencies is I see SMHA as a technical regulatory agency. There are provisions in the rules for inspection and audit. Once I have done that, I will refer that to the local law enforcement.
But if I don't, I establish a de-addiction center and don't register it with the SMHA.
Sir, about that, there can be complaints. Huh? We have received those. We
That's
have
the
received
police.
such complaints. Yeah, there is a provision for complaint to SMHA.
So,
Sorry, the point that I was making is, unlike I think what I heard Sanjay ji saying, the law enforcement cannot be, and I don't think should be a part of SMHA's function.
That's it.
I prepare a report, I give it to the police and the district magistrate.
That's right. That's great. How long will a session? Okay, somebody wanted to know when will we finish. So I think we'll honor that and we'll end it here. And thank you very much.
Can I just say this, sorry, can I just say that I'm sure all of us will agree. See, we are all talking about what we partly have learned and understood. This is still a very evolving scenario. We'll have to wait for case laws as they emerge.
Thank you. Thank you, Dr.
There is
Balchandra.
nothing that has happened yet.
Before Dr. Balchandra shuts up the projection, over to you, Dr. Balchandra. Thank you very much. And thank you, my panelists. You've done great justice to the topic. Thank you very much.
Yeah, thanks all the panelists and moderator for having such a wonderful discussion. So instead of wasting time, we will move to the next session. Next session is concern and solutions about private mental health establishment. What are the different categories of the mental health establishment and what are the different concerns about day-to-day functioning? So Dr. Devavrat Harshe will be moderating this session. He is the consultant psychiatrist, assistant professor psychiatry at D.Y. Patil Medical College, Kolhapur. Area of interest are brain stimulation, biostatistics, adult psychiatry, and clinical research. He has published more than 40 publications and he is the secretary of IPS Kolhapur branch at present. So he is the active members and thorough student of the MSc 2017. Over to you, Dr. Devavrat Harshe, for your proceedings.
Good afternoon, everyone. I hope all of us have had a sumptuous lunch and we are ready for this session. It gives me immense pleasure to introduce the panelists for this session. I would like to start with respected Dr. Deepak Kerkar, a very senior and renowned psychiatrist from Akola, having a very reputed name in terms of psychiatry and mental health. He has a huge hospital at Akola. He is a member of MHRB for that region. He has founded and he's also a motivational speaker and he is very much active in public awareness and education. Next, I would like to introduce Dr. Ashish Deshpande sir from Mumbai. He is a consultant psychiatrist and currently director of Samarpan, which is an institute which offers rehab services in and around Mumbai for psychological well-being. Currently, he is also engaged in other projects like capacity building for healthcare workers in community coalitions, and he is also an ideator and advisor for an addiction preventive initiative which they are working with Rotary in a combined capacity. We also have for this session Dr. Alka Subramaniam. She is an associate professor for psychiatry at TNMC and Nair Hospital, Mumbai. She has extensive experience in geriatric and child psychiatry. She has played a vital role in establishing the psychogeriatric clinic at Nair, has received multiple renowned and respectable and awards across her career for research and presentations. She has been an active IPS member as well as other governing bodies like IIGMH, and she is chairperson for Child and Adolescent Mental Health for IPS West Zone. We also have with us for this session Dr. Mahesh Gowda, consultant psychiatrist at Spandana. He's also a DNB program coordinator, very much active in academics. He also is currently running a rehab center since past almost 20 years. He has been a very active member for IPS in Karnataka. He is an editor for IAPP and more than 60 publications in index journals. So without taking much of your time, all of us are very much interested to learn from these stalwarts. So let's join them. This session is also going to be sort of a panel discussion and not a one-to-one presentation model. So my first question is going to be to Dr. Mahesh Gowda. We just discussed about MHRBs and various roles they play. So how is or how a private practitioner should think or approach the day-to-day communication with the MHRB? Dr. Mahesh?
Good evening, good afternoon, sir, and thank you for this opportunity. When it comes to communication with the board, I think a lot of onus of responsibility has been put on us. If you look at communication, I think basically it's going to start with giving all the data on the hospital management software, which has to be eventually synced with the e-Manas software. So they are going to definitely have a lot of data that we generate, whether it's outpatient, inpatient, from the time of admission, discharge, the current process of a capacity assessment, all those things, they will have the data. So they are definitely going to look at admissions of minor. They're going to look at admissions under section 89 and 90. So these are the highlights that they would want to review, or anybody who's a special population, could be a geriatric person or a pregnant person. And they're going to generally look at data for consenting. They're going to look at capacity issues. So they're going to definitely raise a lot of concerns about patients being kept longer than what would be needed. So their issues will be basically revolving around the duration of stay and the consenting process, what I think.
Thank you, Dr. Mahesh. I would like to extend the same question to Dr. Kelkar, sir. Sir, being a member of the Akola MHRB, what would be your inputs on this? I mean, suppose I'm a practitioner at Akola, then in what channels should I be communicating with the MHRB? Are there any prescribed modes or methods of communication which the MHRB deems?
Thank you very much. Thank you for giving me opportunity for this session. Thanks, Balchandra, and thank you, Dr. Harshi. Right now, the MHRB is not in existence like it is on paper. So right now, we don't have clear-cut guidance or directives from the state authorities, like what should be done, how it will be functioning, what is its role, where is its office, Like up till now, like I came to know that I am on MHRB from Dr. Kumar. My daughter is working with him. So I came to know from him. Otherwise, I don't have any official communication from government that I am on MHRB. So that is the state of affairs right now.
All right. Okay. To take this discussion slightly on a specialized note, I would like to ask you, sir, again, Dr. Kelkar. There are many of us who have multiple practice locations. Some have a couple of OPDs or some have 2 IPD setups. So what should be, what should they be working on? Because now they have to take care of 2 or 3 places instead of just 1. And with all this paperwork, what would be the advice that or inputs you will be offering them?
Like as far as I know, like one psychiatrist can handle or is responsible for 100 patients. So even if he is attached to establishment more than 1, I think total together, he can be a psychiatrist for 100 patients. Like that is what I know earlier. And like if you have more than 1 establishment, then we can have another psychiatrist there who is in charge of that. Like we have got one hospital at Nagpur. So we have got another psychiatrist there who is working and who is in charge there. So like that.
So just to make the point clearer, the number of establishments doesn't matter, but the number of patients does.
Patient, yeah, right.
All right. So 100 patients per for one psychiatrist.
For one psychiatrist. Yeah.
Okay, that's a very new insight into this. Thank you, sir. My question to Dr. Mahesh will be: we talked about communication with MHRB and day-to-day activities. Then, what should be the practical approach for certain issues like, say, informed consent or privacy or availability of communication channels to the patients when it comes to private practice, or availability of insurance and reimbursement for mental health treatment? So what approach or what let us say workaround solutions you can give to private practitioners about it?
I think there's a lot of onus put on the treating psychiatrist as far as the records and communication is concerned. So if you look at the basic document right from the time he comes in, a lot of documentation has to happen. If you look at a typical situation of Section 89, we need an assessment, the clinical assessment, and it has to be capacity. Then you decide to admit. So if it's Section 89, it has to be 2 certifications. Before you admit, you need to take a admission on a prescribed form that has already been gazetted. So there's too much of documentation even before the patient gets into the system. And after he gets into the system, every day, one mental health professional face-to-face contact has to be documented, and the assessments also are prescribed. And informed consent, if you look at, is going to be the heart of all the documents that we're going to have. It should have all the basic required information about why the patient is getting admitted, the illness that we are going to treat, the treatment options, the other alternative therapies that could be there, the risks involved, and his voluntary willingness to get in case of Section 86. If he's not willing under Section 89, the consent will be from the NR, and that becomes an important document. It's good to have an impartial witness who's not your hospital staff. It could be somebody who's accompanied, somebody who's not a part of your hospital, to actually sign as an impartial witness also. And all notes, it will be a good practice if you can actually get somebody to cross sign your notes. It could be NR or the patient to say that it's been done. When it comes to documentation, I think a lot of relearning has to happen right from the day of our training from PGs. The way we document, we used to document everything as a corroborative history from everybody and make one document. Now there has to be a system where I document what the patient says, what the informant says, and what I would get from one more treating professional who may give the information. When it comes to release of information, we have to release the patient's data only what he's told, not about the collaterals that we collect. And the same way, when the NR is asking for some release of information, it should be only the basic minimum records that we'll have to release, which will be helpful for him to avail treatment outside, not the whole data. Anything that is going to be confidential, which may invite trouble, it's good not to enter a lot of data here and become responsible. Once it's entered and captured, the patient or the NR or any authority can have access to your records. We have a habit of actually recording a lot of issues of sexual importance, affairs, and a lot of fantasies and things which may not really help us in clinical management. So try and avoid all this sort of documentation. When it comes to insurance asking data from us, I think the person who's availed insurance would have signed off with the third-party vendor or the insurer that he can avail our records. So they will give us a written request. And generally, they will also have the patient's policy with them. So based on that, we can release the records that is needed. And only the basic minimal records is what we must provide, not everything that's also confidential. So we can try and filter out so much of data which may not be necessary for them to scrutinize.
Thank you for that lucid explanation, Dr. Mahesh. Now, just what I noticed something interesting which you mentioned about recording at least one face-to-face interaction with the patient. Now, when we are talking about supported admission, we are going to require ratification by either 2 psychiatrists or 1 psychiatrist and 1 medical professional, right? So
you're
some of
right.
our colleagues are practicing in locations where they are the sole psychiatrist for that whole region. So some of them have asked, can they examine a patient and ratify a supported admission, and they get opinion from a second psychiatrist via teleconsultation? Will that work?
Yes, basically, if you look at supported admissions, it's technically has to happen in MHE with an established department, with all the support staff of MHPs that we generally want. Section 89 should not happen in places where we don't have this sort of infrastructure and manpower requirements. When we have issues with certification, there is a provision for an MBBS doctor or the other MHPs authorized by the Act to sign the second certification. Telepsychiatry has come to our rescue here simply because you're not actually treating, you're evaluating, examining a patient. All evaluation and examination can be done via telepsychiatry. And the other aspect here is your one consultation is what you're doing. So it will also serve as a model of revenue to invite a third opinion, or whenever you want second certification from outside the institute. All these things can be built, but it will be more robust. You should not skip any of the certification or the second assessment. Make sure it is reviewed by a second person who may be an outsider, but there has to be a documentation. He has to give you a certificate in writing that he's assessed on telepsychiatry mode, and this is the observation is done, and he can be section under 89, and the certification has to come in the electronic mode at least.
I was just going to ask that when you say so he has to be issued a statement in writing, will a digitally signed and digitally prepared certification or document do good, or it has to be a handwritten and hand signed document?
I think the same principles of whatever is applicable for telepsychiatric prescription holds good. If you're signing it off digitally there, I think it's also valid here digitally, but there has to be a documentation that it comes from his portal and it is landing in your hospital portal or your patient records portal. It has to be captured and recorded.
All right. So let us move
Can
from
I
general
interfere here? Hello, can I interfere here?
Yes, sir. Yes.
Yeah,
Yes, sir.
like section 89, it says mental health, like a medical practitioner also. Medical practitioner means any person who is having BAMS, BHMS qualification also is a medical practitioner. So a place where one psychiatrist is there, there are other people who are BHMS or BMS. They are medical practitioners. So they can independently, they can assess and certify that he is the patient.
Okay. Thank you both of you for clearing that up, because many of our colleagues are practicing in small places and they are having this difficulty over there. So let us move from general psychiatry to a bit of specialty psychiatry and talk about issues of rehabilitation and de-addiction. So I have a question for Dr. Ashish Deshpande. Sir, how are you seeing this change in perspective from MHA 87 to MHCA 17 and NDPSA? So how do you see all this in terms of rehab and de-addiction?
Okay, so NDPS Act is totally different. I would see NDPS Act as an act which regulates the movement of psychoactive substances, narcotic drugs and psychoactive substances in the society. Whereas Mental Health Care Act 2017 or 87, they talk about actual treatments that are offered to patients and how they should be offered. So I think NDPS and Mental Health Care Act are two different apples and tomatoes. So I would not want to compare that. With respect to the clauses that are mentioned in both the Act, Mental Health Care Act, the previous one and the new one. In previous one, in mental illnesses, substance use disorders were mentioned only in one of the chapters, I think chapter 3 of the Mental Health Care Act, whereas in 17 Act, it is very well mentioned right in the beginning when you define mental illnesses. You have specifically mentioned conditions which happen under the abuse of alcohol or drugs. And that is one, maybe, whether to use the word abuse because it's not mentioned in DSM-5 or ICD-10. So whether we should be mentioning in the Act itself because of the negative connotation, that's a separate semantic issue, but that is something that one needs to address. The other thing that comes along with that is that the decision making, because substance use disorders and all the other mental illnesses have this basic difference where the assessment of judgment and impact that it would have in the decision making is probably little less confounding than in substance use. So we all know that in intoxication and in withdrawal, the person's impairment of judgment and his choices are going to be difficult, and he requires some assistance in probably reaching him to the decision that he would want to take. But what happens to judgment and decision making once the withdrawals are over? There is sufficient evidence in substance use disorder literature that there are multiple cognitive deficits that are there in a person, and the choices that the person makes, even when he is sober, even in spite of 30 days of sobriety or even 90 days of sobriety, the choices that one person would make may not necessarily out of free will or with the probable understanding of the consequences. So there the problem arises where the implications of different kinds of admission procedures or even nominated representative or advance directive, giving advance directive, become a problem, because uh, what is the understanding of the act if a person has given an advance directive or given a nominated representative in a sober state, and when he comes in an intoxicated state, do we accept the nominated representative offered or advance directive offered, or when does the choice change, when does the free will change, and when do you allow the person to make the changes? With this understanding, what would happen is the provisions are that if there is a conflict, then the issues have to go to state mental health board, and I fear that there would be many references to the state mental health board from various rehabilitation centers, multiple rehabilitation centers that we have, and which give supported admission facility. So in terms of substance use disorder, I believe that it becomes complicated. So there has to be some relook. That's what I feel, and I read in the literature that substance use has been excluded from the Mental Health Care Acts of UK, Australia, and New Zealand. Well, with the new law coming up, we don't want such a drastic change to happen, but I think there has to be a relook on the implementation of Mental Health Care Act when it comes to substance use disorders and associated conditions.
Thank you, sir, for the very elaborate. I mean, not only the state of the current law, but how the global perspective is changing on the state of substance use in whole mental health scenario. What I would like to ask further is, what changes or what would you now have to do differently for running a rehab or a de-addiction center with the new act? I mean, things which were not being done previously but now have to be done, and things which were being done previously cannot be done.
One good thing with Mental Health Care Act is that it is now known that it is not a social issue, but it is a health issue. So I think family welfare and social empowerment department and the health department, they will have to make choices about where actually this particular problem lies. There would be a lot of paperwork which essentially would do good to the rights of the patients. Um, the independent admissions and supported admissions, though at the time of admission, um, could be very easy to differentiate. Once the patient is admitted, then whether the admission status, okay, sometimes can change. So independent admission can become supported admission sometimes, if in substance use specifically. So the procedures that need to be followed have to be documented. So it will demand a lot of time. And my humble understanding is that if you have a team of mental health professionals to work with a psychiatrist, then it takes about 1 hour minimum per patient of a psychiatrist, and about 5 hours of time every month of a non-psychiatrist, maybe a counselor or a peer counselor, in order to fulfill all the requirements of documentation that are required. And that is something that would have to be different. Apart from that, there are sometimes people with underage or less than 18 are admitted in the same facilities. I have seen that happening, which obviously is not right, and strict implementation is required because of the population that exists in a rehab center. Sometimes because of family issues, the person requires to stay in the rehabilitation center for a longer time. In the literature on therapeutic community, they do say that the requirement for certain changes to happen may be about 6 to 15 months. But certainly, whether to keep the person for those many days at request is something else, and forcefully is something totally different. So what are the according to the Mental Health Care Act, there are provisions for extending the stay in the rehabilitation center. But again, there is an ethical issue about that. Some family members do demand that the person should live in the rehabilitation center permanently and do some job in the rehabilitation center. So whether a recovering addict or an alcoholic can be given a job in the same rehabilitation center, and at what remuneration and how it reflects in the paper of accounts, that again is an issue which probably doesn't come under the gamut of Mental Health Care Act, but it's an ethical issue altogether.
Thank you, sir. Moving on to another specialty in psychiatry, let us talk something about minors or children and adolescents. So, my question is to Dr. Alka. Madam, how do you see or what challenges do you think will be imminent in handling minors in either government or private setups on OPD as well as IPD basis?
So, first of all, thank you to the organizers and Devrat for having us here. It's been a very interesting day so far, unfolding about the multiple issues that are coming up. See, minors are really going to be a challenge. The POCSO has been implemented since 2012, and we are already having so many issues with it, with a great divide between psychiatrists where they feel that, why is mandatory reporting when we are going to be impinging on the confidentiality and losing our patient. So that itself has opened a Pandora's box. Now with MHCA, every admission, if we talk about the IPD part of it, every admission is a supported admission for a minor. Plus you need documentation from 2 psychiatrists or an additional mental health professional or a practitioner, right? Now, like you said, in smaller places, this becomes a challenge. It also increases the paperwork. Here, what we are trying to do is to minimize the red tape or bureaucratic trauma for minors. That was the spirit of the POCSO Act. The spirit of MHCA is to be patient-centric. However, in case of minors, 2 things come up very evidently in the Act. One is that the documentation is tremendous. And second, because of the nominated representative, at times the person who's the nominated representative or the only caregiver is also the person who is the perpetrator or causing harm. And that's where we overlap and a conflict of interest comes about. Now, for children who do not have families, the CWC or the Child Welfare Committee is supposed to take the onus of them. For children who are in contact with the law, they fall under Juvenile Justice Act and they fall into state-run homes. We all know the unwritten problems that state-run homes have. There is lack of regulation, lack of surveillance. There's a lot of problems that the children face over there also. Okay. Now, if the MHCA was implemented as it is, this is not to deter away from the fact that it will be implemented for minors also, but we are just foreseeing that there will be problems. How are we going to cross paths with the CWC, and where will the role of the MHRB, the SMHA be, and the decision-making power with the CWC as far as each individual child is concerned? Unless these roles are defined and unless we have a track of, it has to be a green channel for documentation, we are just going to be going round and round in circles, I think, as far as IPD admissions are concerned. As far as OPD, outpatient treatment, is concerned, again, the child is not someone who walks in themselves usually, though we have had adolescents who have come in themselves with the realization that they have problems, of course, accompanied by somebody. So there's usually a referral system that comes in. As far as outpatient admission treatment is concerned, apart from the fact that there should be a nominated, documented representative, which is going to change our paperwork, and we document everything a little more meticulously, which has to be probably informed to the board. I don't think that that's going to be too much of a challenge, unless, again, these patients come in on an outpatient basis for assessment and have crossed paths either with POCSO or with the Juvenile Justice Act. So if I'm looking at the window of specialty minors, from the minor perspective, there's a lot of dependence on the nominated representative already. However, the bureaucracy and the interlinking is what we are going to have to really work on, but only once we start the process and we start working in the field will we understand how really things are going to move ahead. For a single standalone practitioner to deal with a minor IPD admission is going to be more of a challenge. I think there's too much of onus of reporting and documentation at this stage, subject to change, of course.
Thank you, madam. The next question is actually a two-part question, and it is actually open for all. We just heard in the last session that we are going to have category-wise minimum standards and guidelines about how these places should be run and made. So the first part of the question is a psychiatric OPD a mental health establishment? Because there are practitioners who are offering OPD-based ECD treatments or OPD-based ketamine treatments where patients are kept for some time for observation, 4 hours, 6 hours, or 3 hours after the procedure. So will those centers be mental health establishments, A? And what sort of differences are we expecting for these category-wise differences in guidelines or standard minimum standards for different sort of mental health establishments, as we spoke in the last session?
Yeah, can I go for that?
Yes, yes, Dr.
Yeah,
Kelkar, sir. Yeah.
Yeah, definitely. See, those psychiatrists who are practicing OPD-based ECT, they need not be registered for mental health establishment or in MSCA 2017. But when they are giving ECT, so now they have to follow all the things like which are necessary for giving ECTs in the OPD basis, like anesthetist and like whatever anesthetist requires for his GA, to be given. So he has to maintain everything. And if that is done, then I think there is no problem in giving ECT on the outpatient department or as an outpatient.
I thought I'll just add a few things on the risk that a practitioner is going to take here for outpatient ECT. If you look at some of the cases that has actually gone to court, if somebody is being put under short GI or anesthesia, he can have a complication where you need an ICU setup, or sometimes he may need a ventilator to manage his respiration. So these are the crises that very rarely it can happen. And if you're volunteering to actually give this sort of treatment options to a patient outpatient basis, we must have the backup. If it's not your own clinic, it has to be something nearby where you can shift the patient to safety. There's one case I distinctly remember. This was actually in Karnataka, where a doctor actually who's a gynecologist had operated a patient, and he did not have a ICU backup, and after the operation it got complicated, shifted, and then he is actually sentenced to 6 months of imprisonment. So outpatient practice, whatever we can cater is something that we must concentrate on. Doing an ECT, which is an anesthetic procedure, I think it's going to be a big risk that we are taking, simply because even to run an outpatient clinic, you need to take a license of Private Medical Establishment Act. And the norms of MHCA and Private Medical Establishment Act may not be very different in terms of infrastructure requirement. And OPD, you are being giving, everything is all right, but I think going forward, in the eyes of law, we are going to be really scrutinized, and it may be very difficult to defend unless IPS guidelines says that ECT can be an outpatient practice and can be given in an outpatient setting. We should have some sort of document from the professional body to just pass the Bolam test. Otherwise, I think we are going to invite trouble.
Yeah, I agree with Mahesh when he says that when there is a bad outcome, the law comes into force. So obviously the act always says that we have to be on the safer side. And as it is, this problem probably would arise in the rural settings more. I don't think in urban settings people are giving ECTs on a OPD basis. Maybe in a hospital setup, yes, with adjuvant hospital associated, it might be done. But just in consulting rooms, I don't think anybody gives.
Yeah,
Okay. Sorry, ma'am.
from what I understand too, only standalone OPD practice probably need not be registered under, although it's always better to, but however, when you're offering any sort of procedure, however minor it may be, in fact, so much there was a discussion on biofeedback also some time ago. Anything that you're offering a patient where there can be questions or you can be taken to court, it's always better to be registered.
Thank you, panelists, for clearing that up. Moving to another slightly issue of ethical balance, which was not there in the earlier act, is about restraints. Now, let us take a hypothetical case of, suppose there is a very aggressive patient in the ward who needs to be restrained. Now, Dr. Mahesh, can you elaborate a step-by-step process which a practitioner has to follow so that he doesn't land up in the legal soup? As suppose I have decided that this patient needs to be restrained. Now, what steps I need to follow, and what documentation I need to carry at each step so that I protect myself if the case turns out to be a medico-legal one?
I think the case scenario you're explaining looks like on face value on the capacity assessment. I would say that the first criteria is met and absolutely he has no capacity. So I need to take a consent for whatever procedure I'm going to do from the nearest relative or a nominated representative here. And the sedation, whatever you're planning, has to be the last option. We have to actually try all means of talking to the patient, calming him down, de-escalation. You name it, they say alternative to restraint, just to make sure you don't use any coercive method on the patient to be sedated. If nothing is working, and you should have a backup facility for so many personnel actually to manage. If you have to physically restrain a person and give him some chemical restraint, I think it needs at least 4 to 6 people to be there to make sure you're actually taking care of restraint in the least harmful manner. You should have the specialized bands to make sure you use the 5-point technique to actually restrain the hands and legs, and also at the pelvis level to make sure he's stabilized, and then sedate him after taking adequate medical precautions. And unless we document and take consent from the NR, I don't think we should actually venture into this sort of sedation also. We used to be heroic. We've done a lot of sedation. We've actually caught out of patient physically overpowered and actually given without documentation. I think nothing should be done without a valid consent here.
Would anyone like to add something to this?
Yeah, what we do in our rehabilitation, mostly with drug addicts and alcoholics, is that we have a restraint book, okay, or a register, okay. So there exactly when a person becomes aggressive, there is a aggression scale that is marked, and whether it is verbal, physical, is it threatening towards self or others. And there is a committee, there is a client committee where there are representatives of the patient, from the counselors, and they together try to resolve the matter, and they document everything about what is being communicated, what time communicated, the outcome. And then when the person is approached for training, clear the other patients should be around. It can't happen in isolation. So it has to be in public. It has to be, people have to be around that person. Then the person is restrained for minimum period of time. When the person is trained with all the precautions that I just said, there has to be continuous communication with the patient, trying to calm him down and assure him that as soon as you calm down, the restraints will be removed. All documentation is done and the family is informed, and the family's consent for restraining has to be taken at the time of admission for each and every patient. So if there is an untoward incidence, the consent for restraint has to be taken from the family member. So that we add to the whole procedure.
Just to add on the follow-up of restraint, I think Dr. Ashish actually mentioned a lot of things in the register. I think it's going to be one of the most important document for audits. You have to mention and actually document at what time, and actually every 15 minutes there has to be reassessment just to make sure he's not restrained for more than what is needed, and safety of the patient at all times has to be assessed, and family's involvement and wherever signatures are needed for every restraint, and all this restraint has to be authorized by a psychiatrist only and not by other staffs.
Just
Okay.
take that further,
Yes, madam.
to add to what both of them have just said, also there'll be the documentation process with the MHRV at every point in step.
Yes.
So whenever
Yes.
you restrain, you are going to have to document, inform, and then re-inform when the person is not restrained anymore, and that whole process has to be available with them till it is, till the patient is safe to be without restraint.
Yes.
So I don't know how that communication is going to happen.
Yeah. So again, practical, like how and how quick and how those green channels we are just going to have to wait for.
And every month, isn't there supposed to be a report sent to the MHRB demonstrating total number of instances of restraints, total duration of restraints, the longest period of restraints, and number of restraints without psychiatrist authorization?
That is the monthly report, but immediate report has to go to, and that's the part which we are going to have to see.
Yes, yes, yes. Actually, that's a nice insight about. Thank you, Dr. Ashish, about the restraint register. That was actually a very nice insight that came out of this discussion. Since we are talking about consent and capacity, let us have a brief moment to discuss capacity and competence. For in a private setup, what insights or what inputs would you give to a private practitioner on assessment of capacity and competence? And how should a practitioner distinguish between the two, and what documentation should be kept for that?
Let me answer this. The thing is that our setup, like most of the patients who are brought to us by relatives, like we take their blanket consent about restraint or chemical restraint or physical restraint or like patient being tied, whatever, and we have got blanket like consent which is taken. And hardly in my practice now of 37 years, like anybody has come on his own, like please admit me in your hospital, like maybe some 5 patients in last 37 years. So usually the patients are brought, mostly psychotics, they are brought here and they are admitted by the relatives, and then like it's a clinical assessment that we do and admit the patient.
Can I, Devara?
Yes, sir. Yes, sir. Please, sir.
So, in capacity assessment, the process starts during the history taking. We have something called pre-admission form. And in that pre-admission form, there has to be a documentation of whether the person requires a supported admission or not. So whether self-threat or threat to others or not able to take choices which might harm the person. So, or recurrent unlawful behavior. In either ways, we usually follow this procedure that if there is a recurrent unlawful behavior, there has to be a non-cognitive cognizable offense registered in the local police station where the person comes from. It is just for security because many a times because of multiple the differential dynamics between the patient and the family. Family might give you one history to begin with, but later on they might just change their history. So we keep that as a safeguard where the family member has reported to the police. Let it be a non-cognizable offense, does not require to be a FIR. In that process, when the person is first evaluated after the pre-admission form is filled, at that time, obviously, the reason why he is required supported admission is because he is under the influence. At that time, he is in use, and it is very easy to document the behavior at home at the same time at the time of examination. So it is easy to document that. The problem arises when the person comes out of withdrawal And because of the cognitive deficits that are there, their manipulative tendencies, aspirations, false aspirations from self, all kinds of stuff starts complicating matters. And then assessment of capacity and the choice that the person is wanting to make becomes very difficult, and it becomes a ethical conundrum.
The issue of capacity and competence can actually be on a continuum, and I think when it comes to treatment specific decisions that we're taking here, I think we should go with the rule book document of capacity and just see if he meets all these criteria that we need to look at when we have to certify that he has no capacity. Competence to stand trial, fitness, and other issues are outside our treatment rated parameter. So we'll have to look at only capacity to consent for treatment rated procedure as specified by law. Insight also is something that we talk about, but I think we should not mix issues here. Let's talk only about capacity.
Yeah, and sometimes I have observed that when patients are in a rehabilitation center or therapeutic community, there are feedbacks from the community that you are likely to get, which also tells us about whether the person is, when the person talks to you, whether the person is putting up a front, or is he talking from the heart. The manipulative tendencies or the masks, as my counselors keep talking about, the addicts are very good at wearing masks. So there are multiple inputs that you get from the educational sessions that you have, or individual counseling sessions that you have, or observations in the community or therapeutic community that are provided by others about a person. So that gives a lot of information, and sometimes it becomes very difficult to put it down on paper. So we have tried to have some kind of an assessment tool for observing clients who are in the therapeutic community. But I have a difficulty, how can that be communicated to the board when suppose an extension is required? How can that information that you get from the therapeutic community can be expressed and understood by people who are not in presence, not present in the rehab therapeutic community?
All the other data can be collateral, sir, whether it could be that you get it from printout. If a police has reported a case and comes in newspaper, this is a collateral that we get. A mental professional or a treating team that gives information could be again a collateral, and any other person who's not directly connected to the patient, who's been an observer, also can be a collateral source of information which can aid for our diagnosis. I like Dr. Ashish's idea of actually reporting to the police and making sure this NCR documented. Every time we get a request for making house visits under section 94, we also taking a letter from them. We also issuing a letter to the police why we want to intervene under 94. And unless the police acknowledges this and signs it up for us, we are actually not visiting clients at home also under section 94 to facilitate admission. So there should be some documentation, and whenever we are going into an unknown territory of a patient's residence, we don't know whether the patient is actually symptomatic, and there's no assessments done in the last 1 week by any mental professional. Good thing is to loop the police, because they also have responsibilities under section 100, and take some sort of documentation from them. It is definitely going to go a long way when there's a legal scrutiny of our admissions.
Since we're talking about capacity, we are coming to the end of the session with last two questions remaining. My question is to Dr. Alka, madam. Madam, in terms of talking about setups which deal with mental problems from the elderly and geriatric setups, what challenges or what do you think should practitioners be focusing on, or what changes do you think we have to do in those practices, considering the new set of rules and laws?
That's your question on capacity. Basically, assessment of cognitive ability and the capacity to make an independent decision is going to become almost a mandated thing as far as the elderly individuals are concerned. So for those who evaluate elderly individuals prima facie without doing a baseline cognitive evaluation, that has to change. So we are going to have to apply either the HMSC or some other tool whereby we document at least clinically that this person has this kind of this thing. clinically this is what I have done, and therefore I feel that this individual has aberrant cognition or has limited cognition, and therefore I am involving the NR over here.
Thank you. Now, this is the last question for this session. This is open to everyone. We just discussed about the load of paperwork that is going to fall on everyone's head. So, I mean, what would you suggest to all practitioners? I mean, how do we adjust our time and work-life balance and work schedule to make room for all this added work assignments? Because as sir said, it takes about 1 hour for one patient for a psychiatrist and up to 5 hours a month for a counselor or a non-psychiatrist. What would you advise everyone? I mean, how we should handle all this added work? Any inputs?
First of all, restrict yourself to one mental health establishment. Don't try to go for 10 mental health establishments. So that is the first thing. Second thing is that the peer counselors, if they are rehabilitation, their capacity needs to be built, because they are the ones, they spend maximum time with the patient. So it's always said that higher the qualification, lesser is the time that you spend with the patient. So it applies in de-addiction services critically. So there has to be a capacity building. It becomes very difficult because they are resistant and they not necessarily understand why we are doing it. But with Mental Health Care Act, I think it is needed, and it is mandatory that you influence all people who come in your contact to implement whatever that needs to be implemented. There are no easy solutions, just capacity building and delegation of responsibilities.
I thought I'd just add a few things here. What happened in our setup? I also was one of the prominent faces complaining about the act for long enough period. When it became inevitable, I've actually adapted and changed the way I practice, just to make sure I'm law compliant. The detailed workups that any student would be doing is something of the past. We have to just document what is needed in terms of basic minimal records. For outpatient, it could be under 7 or 8 headings. For inpatient, it could be 15 or 16 headings. Just document enough that is needed. Don't document too much. Just document enough to just pass the scrutiny of law. And all the documentation that we are doing, earlier it was just an obligation and nothing was specified. But now informed consent is a procedure. You please hire a team, have a designated person. Dr. Ashish said about capacity building. Yes, you must delegate this sort of task and make sure a good documented informed consent is there. Certification is a procedure. Capacity assessment is a procedure. Discharge planning is a procedure. Everyday notes that you actually have to put is also mandated by law, because unless you documented, it didn't happen. So these are inevitable. We all see patients every day. When we bill them for consultation fee, yes, this becomes an obligation. There's no shortcuts to escape documentation, and it has to stand the scrutiny of law. So hire enough staff, make sure they're trained, and if you have an SOP in place for involuntary admission, section 89, 90, or a voluntary admission, I think there should be a checklist. Though checklist may not be a good approach, we don't want to miss something. At discharge planning also have some 8 or 10 parameters under which he should be educated, and have a discharge planning for them. Make sure he signs it up, have a follow-up date. All those things should become a part of the SOP, and that is the only thing that's going to save us, is what I think.
So we come from a very different perspective, which is a teaching tertiary medical hospital. And we already have had a lot of teething trouble in adopting a digital system for record keeping, which our hospital initiated about 4 to 5 years ago. And just as of now, we have managed to make things a little more streamlined. But just like Mahesh said, that, there's a lot of reduction in the quality of data. You're taking in intake, which is essential. You don't take in extra input because there is only so much time and you have to constantly feed it in. So what I think is going to be for us coming up is grafting all the requirements which are MHCA compliant in that system, and training staff across the board, which is going to include our social worker, our psychologists, and our nursing staff for inpatient admissions. So the checklist will probably be at the ward level when the admissions are taking place. And at an outpatient level, we will have down forms which will come, which will say that, okay, this is what you have to do and this is how you have to fill the forms in order to be MHCA compliant. So it's going to take a lot of work. And I think that the training is not something which is going to be a one-time training. It's going to be periodic training, because we'll have batches which come in, and in those batches also, including us, we are likely to, have some attrition of skills or forget certain things, and we need to keep revisiting those and help ourselves till we become very proficient with the system.
Dr. Kelkar, sir, last words.
Yeah, the thing is, we have prepared a booklet, for admission, and that booklet and a checklist. And we have trained 2 staff members and 1 supervisor. So like he rechecks it, and then we are training them ongoingly, continuously, as it is said. Continuously training ongoingly, like how to fill up the forms, what to tell them. So like when the patient, like when the booklet comes to me, everything is ready, and then I have to just sign and just recheck final whether the things are in place or not. I think training staff and keeping staff, enough staff, that is essential.
All right. Thank you, eminent speaker, panelists, for making this post-lunch session very lively and interesting. A lot of new and very practical insights came out of it, like number of patients allowed for one psychiatrist to cater to, or maintaining a restraint register, or just like sir said, a checklist and a booklet. Or as Dr. Ashish Deshpande sir said about therapeutic community and their inputs. I really thank all of you for making this session very...
Dr. Devrat, there's one chat that actually asked about where is the reference for this 100? How did you actually derive this number 100?
Yes. Please, I'll clarify that. The thing is, in 1987 Act, it was mentioned that 100 patients for one psychiatrist. And whenever we applied for Maharashtra government here about the license, so they were referring to that Act, 1987. They said, we don't know about this Mental Health Care Act 2017, and we are not giving license according to this act because it has not yet been established. So we are giving license according to like 1987. It is mentioned there 100 patients for one psychiatrist.
Yes, sir. Even in Karnataka, the old act norms, the minimum standards, what they specified, said that one psychiatrist for every 100 patients.
Okay. Thank you, speakers, for making this session lively and interesting. I request Dr. Balchandra to take over and continue with the rest of the CME. I hope all of you stay with us and enjoy the scientific feast that still awaits us for the last remaining sessions. Over to you, Dr. Balchandra.
Thank you, Devrat.
Thank you. Thank you, everybody.
Thank you very much.
Thank you.
Thank you, Balchandra. And thank you,
Thank you,
West
everyone.
Maharashtra Indian Psychiatric Society.
Yeah, thank you, Devra. Am I audible?
Yeah, yes.
Yeah, thank you, Devra. That was very wonderful interactive session. I thank all the panelists and Devra Harshi for conducting this interactive session. Yeah. Recording in progress. Move to the next session. That is how to get ready for MSCA. It is about software rules and regulation. What is the attitude of relatives about nominated representative and advance directive? And for these sessions, we have moderator Dr. Dhananjay Asturkar. He is the consultant psychiatrist from Pune. At present, he is the Honorary General Secretary of IPS Western Zonal Branch. So over to you, Dr. Dhananjay Asturkar, for further proceeding.
Thank you, BK. We call Bhalchandra as a BK most of the time. It's very easy to call him. Thank you. It's a wonderful program going on. And I think this fifth last but one session is already we had accepted that MSCA is on table and it's and all the bodies and authorities has been formulated. And this is going to be another challenges, and we accept that by now. And we see that how to get ready for this. And I think this session organizers has given asked me to moderate not only the just proper law thing, but also the allied thing in the practice for our practice. So in this session, we are going to talk about the documentations, the rules and regulation, also nominated representative and advance directives, and overall attitude of psychiatrists from the patients and relatives about this act. Here we are having 4 speakers, Mr. Amrit Bakshi, Dr. Sanjay Fadke, Dr. Mahesh Gowda, and Dr. Shashwat Sere. First, I would like to introduce Dr. Amrit Bakshi, sir. He is a chairperson of the committee of IPS Law College, Pune. He is member to represent mental illness on the advisory committee constituted by Maharashtra government under the Rights of Persons with Disability Act. As chairperson of the Hospital Management Committee of NIMAS for over 3 years. And also most important thing why he is here, because he is very good associated with this law. He's a very good associate with us also since last 2 to 3 years, and with Balchandra maybe for years together. And because he played important role in the drafting of this act. Especially he is proudly said himself as a caregiver, and also actively presented and made presentation in the record of this law before the standing committee of the parliament. Here I welcome Mr. Amrit Kumar Bakshi for his presentation.
Thank you. You have the PPT?
Yes, sir.
It is to be displayed by you.
Yes. I will ask to the host, make me host.
Yes, so I was asked to run through the journey of this act. So I have prepared a few slides. Slide 3 we go to. Yes, so this UN CRPD, Dr. Sumitra talked about it, and because India has ratified and 20 signatories were required for its implementation. So in 2008, 20 signatories ratified it, so it became effective, and within 2 years we were to modify our laws to bring these laws in consonance with UN CRPD. Next slide, please. So it took us more time, which always happens. In 2010, when we should have completed this exercise, we started it. And in January 2010, there was a meeting of important stakeholders in the Ministry of Health and Family Affairs. And it was decided to amend the 1987 Act, and that work was given to ILS Law College, Pune. And why it was given to them was because it was a law which needed amendment, so they wanted to give it to an organization which was involved with the law. This Right to Persons with Disability Act also was given to NALSAR, and this was given to ILS Pune, ILS Law College, and they had a psychiatrist also who was heading their Center for Mental Health Law and Practice. So first amendments were put on public domain in February 2010. Then second draft was put in public domain in 15th June, though it was ready on 23rd May. And then there were regional consultations, and it was found that such amendments are making the act very clumsy. So we should have a new act in place of the old act instead of amending the old act. So next slide, please. So it was decided to start drafting a new act. So the first draft was in December 2010, and the fourth draft was in 2011, then fifth was in October 2012, and then we had national consultations, and there was then it was placed before the Parliament in August 2013, and then it was referred to the Health Standing Committee of Parliament, and the committee submitted its report on 20th November. They did a good job, and they approved the act with some amendments suggested, most of which were accepted. Next slide, please. And then you see, as it was mentioned by Dr. Suresh, that Dr. Desi Raju, who was the health secretary, played a key role in pushing this mental health bill. He was unfortunately transferred to another ministry. So that was a setback, and then things didn't move the way things would have moved had he been there at the helm of affairs. And then also there were fresh elections due. Actually, this Ghulam Nabi Awad, who was the health minister, I happened to meet him in Nimhans. He had come there for a meeting, and he said that this was his last visit to Nimhans because elections will be held soon, and he will no more be the health minister. So then I requested him, sir, that before you leave, at least push this act and see that it becomes an act. And for that, generations will bless you. So he just smiled, but things did not happen. You see, had it become at that time an act, then this Ayush inclusion, which happened later, wouldn't have happened, and things would have been much simpler had it become an act at that time. So that didn't happen, and then the new government came, and it remained in cold storage for some time. And finally, when this Telangana issue was going on in the parliament, and these laws were being enacted, so then they tried to find some non-controversial bills which were pending, and they found this Rights of Persons with Disability Act and Mental Health Care Act bills. So they decided to push it because there would be no opposition to it, and both of these were already seen by the standing committees. So these bills were passed, and they became acts without any difficulty. Next slide, please. Now, this IPS and Mental Health Care Act, you see, 1987 Act was entirely done by IPS. So from 1947, after independence, they started working on it. And then in 1949, they formed a committee to go into it. And they had done all the drafting and submitted it to the government. Of course, government slept over it. And only in 1987, so many years after they discussed it in the parliament and passed it into an act. And thereafter, they slept for 5-6 years, and only in 1993 they notified it. So IPS had a major role in it. Now, this 2017 Act, of course, IPS was involved in all consultations and discussions, and they also appeared before Parliament Committee and national consultations and all. But they were like any other stakeholder. They did not have an important role. Why it happened that way? Yes, there are reasons, but I think today is not the day to go into that. Now, IPS had also issued position statements. One was after the second draft in 2010, and the other was in 2012. Whether there was any other position statement, I am not aware, but at least these two I am aware, and I have copies of those position statements. And after it became an act, now they have filed a writ petition in Bombay High Court, which is still pending. It is now 4 years, and as far as I know, it has not even been admitted. So many IPS members, secretaries, they feel that it's better to withdraw it because already the act is there, it is being implemented, and there is hardly any likelihood of court setting it aside. So that is the position. Next slide, please. Now, definitely, I would say that psychiatrist's role has been diluted to some extent in this act. One thing is that psychiatrists have been bracketed with other mental health professionals, and I think as far as mental illness is concerned, they have a unique role, and that has not come out clearly in this act. And then now this mental health establishments, you see, for admission, independent admission, etc., the in charge of the mental health establishment can be any mental health professional, and a psychiatrist may be employed in that mental health establishment. So admissions and discharge can be given by the head of the mental health establishment, maybe without taking the consent of the psychiatrist. So this appears to be an anomaly. In practice, this will not happen, I think, but technically it is possible. And similarly, in Central Mental Health Authority, they have not specifically provided that a psychiatrist will be taken on the Central Mental Health Authority. And of course, all directors of Central Institute are on CMHA, and most of them are psychiatrists also. But technically, it is possible that none of them will be a psychiatrist. So that is an anomalous position. Now, this committee of experts which framed rules, they have tried to take care of it, and they have stated that if amongst directors, none of them is a psychiatrist, then the two other members which can be nominated by the government, those will be the psychiatrists. So some care has been taken on this. Next, please. Now, families, you see, the families were opposed tooth and nail to this advance directive and nominated representative, because these two provisions are capable of destroying the institution of family caregivers. But for reasons known to them, they were keen on adding these. Most probably, they thought that will fully make it compliant with UNCRPD, and WHO was insisting on including that. So they got included, and caregivers stopped opposing it because IPS was opposing it, this act, this bill, and human rights activists were also opposing. So if family caregivers also start opposing it, then perhaps it will never become an act. And there were not many benefits and advantages. So overall, it was beneficial to the families and family caregivers. And it was thought that these two clauses, advance directive and nominated representative, will remain only ornamental clauses. They will never get implemented. So it's okay, let them remain. So they finally supported the act. Next, please. Now, miscellaneous issues. You see, this mental illness has not been defined properly. This 2S, if you read it properly, then you will find that only severe mental health disorders, the psychosis gets covered by it, and common mental health disorders get excluded by a simple reading of the act. And then they have left it to government to determine the mental illnesses, keeping in view those international standards, which also government has not done it so far. So in the Rights of Persons with Disability Act, you see, they have listed 21 disabilities. So like that, mental illnesses could also have been listed. That would have avoided all this confusion which we now have, whether this is a mental illness or not. So government has also not acted, or they could have said that as per ICD-10 or ICD-11 will be the mental illnesses. That they have not done. Now government has notified, I think it is now 4 or 5 years to that, and it has not been implemented properly. Most of it has not been implemented. Central government is very slow, state governments are also very slow. Next, please. Is there any other slide? So all I can say is that no law can satisfy all the stakeholders. If we find most of the things are good, then we should accept that law. There is always a scope for amending the law or replacing it by a new law. And howsoever good a law is, you see, its implementation is important. Otherwise, it remains on paper. Unfortunately, we are very, very slow in its implementation. Thank you very much. I think that's all.
Thank you, sir. Thank you very much. It was a really very nice journey we had witnessed, and you had seen each and every step since a long, maybe more than two decades while the drafting of the act. Now I request to organizers to show the CV of Dr. Sanjay Phadke. As we all know him, he is a senior psychiatrist and practicing in Pune from Jahangir Hospital and Dinanath Mangeshkar Hospital. He has been he chaired the Center of Behavioral Medicine and visiting faculty in Germany. He is very research-oriented fellow and has been principal investigator for the more than 50 international clinical research projects, including the medicines and technology. He has initiated Indo-German collaboration on neuroscience of the yoga. Also, we know him as a very enthusiastic and very active member of IPS as chairman of Indian Psychiatric Task Force, Mind Body Medicine. He has given very shape to this task force, and also at present he is on the same task force from the IPS WZB. Welcome, sir. I request you to talk more about the advance directive and nominated representative. Positive aspect of this provision, and also possible difficulties for a psychiatrist might face in the near future because of this, and what is in general your perception and attitude towards this MSCA as a psychiatrist? Welcome.
Yeah. So can I make my projection, please?
Yes, sir.
Possible to
support
Yes,
him,
sir.
please make sir as a host.
From your side you can share.
Yes. Okay.
Yeah.
Thank you. So thank you, Dr. Dhananjay, for a very generous introduction. And can you see my screen?
Yes, sir. Just do the slideshow.
Yeah.
Yeah. Okay. So let me take the liberty, because since the morning actually we have had the best of the collections. I actually thank the organizing team for inviting me, and they really had managed to get all the wise and very knowledgeable people on this subject, including the people, those who have been with it since the very beginning. And a lot of discussion has already gone on, into the various aspects, you can say the pros and cons related to the various provisions of the Act. And it's a great pleasure personally for me to also share the stage with Mr. Bakshi, Amritji Bakshi, who has been a very important figure in this entire development. And I thought that instead of getting very repetitive, about what people very authoritatively have said and have been speaking, let me try and bring a little bit different and a fresh perspective, for us to brainstorm about that. So Dhananjay, with your kind permission, let me start first with the perceptions part, so maybe we could kind of have some discussion about the NR and AD part in a while, because I also have my eyes set on the clock, which says that it's 3:30. So I will try to be quick. So in a nutshell, if I have to put, about the perceptions, whether particularly since we only have actually the psychiatrists people here and not the patients and the families, but the general perception has been that there was certain kind of a balance which existed in this whole triad. The patients, their families, and the psychiatrist, the treating psychiatrist. And whether this act tries to be disruptive in some way, to kind of change that relationship to the relationship to which we have been accustomed for like quite some time. So that has been the sort of a feeling which perhaps makes people a bit restless, perhaps a sense of a certain uncertainty. The process, as we know, is still very much in flux. And therefore, it's a common human nature, to be very certain about everything. It's a common human nature. Psychiatrists are also human beings. So we perhaps want to be very certain, and therefore our some anxiety and anxiousness, restlessness, whatever you may want to call it, is very understandable. And this is perhaps happens whenever some new change happens in any domain. So this is about this particular balance, which is sort of, to my mind, summarizes this whole crux of the issue. And people, in fact, have very eloquently written also about it. As we know, there was a special supplement in Indian Journal of Psychiatry a couple of years back. All these people have written about this point. And this issue, I have listened to actually various, you can say, debates about this. I remember the first very comprehensive debate was in 2014 Central Zone Conference, annual conference, and our senior fellow Indian Psychiatric Society colleague, Dr. Rajiv Jain from Sagar, he was very enthusiastic. He, at that time, he actually made, CDs of his arguments about these various provisions and how we should look at them. So if I look at it from this perspective of balance, and before I finish, I just have actually a couple of slides, but before that, I thought that let me also declare my own biases, because the people who would listen to what I like to put on the table, they need to know that I have a great deal been into the empirical aspect. Empirical aspect essentially involves more than theoretic discussions, actually the data-based, data-driven. So like I did my MD dissertation on insight in schizophrenia. Then there was a survey on violence, which we got a award, zonal president's award. All that which showed that some of the myths that we hold are not true. For example, psychiatric patients are not really more violent, than actually the general population at all. Or the insight in schizophrenia is a sort of is a continuum, not a all or none phenomena. And then my association with clinical trials, which taught me that a very elaborate consent, contrary to our popular belief, people suffering from schizophrenia, people suffering from bipolar disorder, they have a capacity actually, to understand even the complexities involved. The consent for clinical trials is actually very elaborate, and they are able to do that, which is a sort of a surprise in some sense. And when we justify these clinical trials to the ethics committees, we say the main common argument for all these running clinical trials is an unmet need. We say that we don't really have ideal treatments as of today in psychiatry. So psychiatry itself, the psychiatric intervention themselves are also in a flux. So it is not that we have some already the set parameters or the gold standard or the ideal treatments already with us, and which we are really very ready, to kind of completely put forth, and nothing should be disturbed in this one. Another source.
So may I request you to go for the next slide, because first slide is visible here, sir.
My next slide is already in place. Can't see the.
So we are not seeing you. We are seeing your first slide.
This one?
No, sir. Previous one.
Now?
Bias wala. No, sir.
And if it could be in slideshow.
You have to go for the slideshow, sir, from the beginning.
Is it visible now?
Yes.
Yes, sir.
Yes.
Thank you. Thank you. Sorry, I'm sorry. So basically, I was talking about whether it be the aspect of insight in schizophrenia or whether it could be related to some popular myths about people's abilities to actually, even with severe mental illness, to consent, or our sort of a non-perfection, non-availability of the treatments which can be called as ideals. So in other words, if we do a stock taking at our end, we understand, that our faculty itself has been in a kind of a great deal of flux. And then I had a long association also with disaster management, nearly a decades of community work experience, and which taught me that the bottom up of community opinion and response, as Bakshiji also mentioned, what the families actually do for the patients versus against the top-down provisions of law. So somewhere there is an intersection, between the society's aspirations, society's coping and responses, and what we try to achieve through a particular legislation. And as a consequence of all that, I tried to look at now this whole idea of mind-body medicine, because as we know that psychiatry has a legacy issue. Psychiatry came in when our twin brother neurology was not so powerful. Most of the whole ideas, and if you look at actually the Lunacy Act, it goes back actually to a century ago. So we also have a certain legacy. Neurology never had a neurology act. Or in the morning, like our colleagues Saumitra Pathare and other people, they highlighted that actually that diabetic people could also be as irrational, when it comes to actually treatment adherence as the psychiatric patients could be. But we don't have a law for diabetes. We don't have a law for neurology. But we do have actually a law for psychiatry, which is also part of the legacy that we have. So the whole psychiatric, you can say, discipline itself in various ways has been sort of being in flux. This is a situation that we have before us. So what do we really do, under such situation? So we have a particular kind of a legal provision before us, and we need to sort of apply it. And of course, there has been a lot of intellectual discussion. Can you see this third slide?
Yes, sir.
Thank you so much. So as we saw, that since morning this discussion is there, Bakshiji also mentioned that there is one camp which wants actually this law to be scrapped, and with this intention, they went actually to the legal system. And there are also people, who think that this should be adopted. We should kind of go forward. So we clearly have these two camps. And as a consequence, as I said, last many years, I remember now 8 years, we have been more into this intellectual discussion part. I don't think, to be very honest, that we have a equal degree of empirical data to match, most of our intellectual discussions and opinions. Personally, I would like to see more data, on the explanatory model, means that how actually people themselves understand the mental illnesses, about the treatment choices which they and their families make, about the treatment decisions by psychiatrists are done, and whether there is a sharedness, whether it's a shared decision or whether a psychiatrist kind of makes what the person thinks is the best choice for the patient. What with the pathway to care? Does the patient directly come to psychiatrist, or because of the so-called kind of heavy stigma associated with it, is it a very twisted sort of a pathway? In the modern times, have patients started preferring more our twin partner, the neurologist, for the pharmacological needs, and the psychologist, for the psychological interventions? We don't know really much about it. And even the care in the general hospitals, ICUs, the comorbidities. So whatever I think opinion I hear from a lot of people, with very due respect to their wisdom that they have, but it's not unfortunately backed, by, there are not even very preliminary sort of studies. There are a lot of studies, on prevalence. All the time we see important data coming out about the prevalence, but on the intervention side, some of these important data. So I would like to see going forward, my proposition is that we should treat, the whole act as a protocol, like a clinical trial protocol. And we should examine the provisions in the light of the empirical data, and then pass a sort of a judgment. Even if we need to bring in some amendments, it needs to be backed up by strong data. As you understand, currently important matters are in the highest court, the Supreme Court of our nation. And Supreme Court has very clearly favored, that you bring in empirical data, that if you want actually to kind of amend things, if you want to make changes, we can't, only go by your opinions. We like actually the empirical data to be there. So the perspective that I like to kind of put before all of you, that all these provisions, we should treat them as a protocol. We should say that fine, we have it here. Let us with a kind of open mind try and examine them in the light of the data. If we have difficulties with the provision, let us document that. That's how perhaps the things will get better. No protocol, no law perhaps in the first run can ever get to a situation wherein we can have argument, to either scrap something which is completely not utilized by people or is found unhelpful, or provisions which can be made better, because if you look at it, coming back to the discussion about the advance directive and the provision, for the nominated representatives, if you look at the developments in other field, I practice in a general hospital setting, and I also make certifications, for example, for organ donation. You see that, that it has really helped a place wherein now people are willing actually to donate, cadaveric organ transplantation is something which has really picked up well. Organ transplantation already has a similar sort of a committees, which do the screening for the donors. So these procedures, they already, you can see they start getting accepted. I think eye donation, body donation, for the medical purposes is all picked up, in the society. And I don't think that any new ethical boundaries really get breached, when you talk about the advance directive or about actually a nominated representative. So I think we need to look at the overall trend in other specialties also, like what is happening around us. We don't, at the end of the day, live in a vacuum. And therefore, my very humble kind of a proposition is that we need to, and my contention is that association is typically meant to carry out activities which cannot be done by an individual alone. One single psychiatrist cannot gather, evidence to kind of examine these sort of provisions. So these are the typical situations for collaborative work. Something what is called as a practice-based evidence. Evidence-based practice is like one way to understand things, but there is also something called as a practice-based evidence. So if we are able to together collectively generate, practice-based evidence, which will help us have more, I would say, informed choices, more nuanced, statements about these rather than just belonging to one of these two camps, would perhaps be a better approach that I would like to see as an aspiration. I aspire to that. That is what my, I would say, perception as a psychiatrist towards this whole issue. Thank you so much.
Thank you, sir. I request you to stop your sharing.
Yes.
Thank you, sir. It was definitely, we can identify your prejudice, mind, biases, and also perception, anticipatory anxiety as a psychiatrist before coming this law. Now I request organizers to give biodata of Dr. Shashwat Shere. Our next eminent speaker is Dr. Shere. As we know, he is from Ratnagiri, and he was lecturer at Goa Medical College and IPHB Panji, Goa. Also, he has been a class 1 psychiatrist at regional mental hospital Ratnagiri, and also experienced as a medical superintendent at the same regional hospital. He has done advanced training in community psychiatry and child and adolescent psychiatry from NIMHAS, and also received training in the drug de-addiction at Hazelden, USA. He has been former secretary of many organizations, president of the many social organizations, and also received a number of awards for his novel work. And if you see his CV, then you will definitely get to know that why he is a member of State Mental Health Authority, Maharashtra State. Sir, we welcome you and wish to know something about the present position of MSCA in Maharashtra State, and also what the difficulties you are facing as a member of MSCA in implementation of the law, practical difficulties, sir, and also your experience being a part of SMHA. Thank you. Welcome, sir.
Thank you very much for inviting me for this talk. I thank the organizers, and we'll straight away start with my presentation. Hello. I can't get my thing. Can you see? Hello.
No, sir.
No, sir.
I think my screen is not on. Hello.
Sir,
Support
share
you.
your slides.
Please make sir host. I think he is not co-host.
Yeah, I am not co-host, so I am not getting.
But you can share your slide. It is allowed.
Share content, huh?
Please click on the share button and then start sharing.
Now can you
Yeah,
see?
now, yeah.
Yes, sir.
Yes.
Sir, please do slideshow. Yes.
Yeah.
Yeah, perfect.
Yeah. So what I will be talking about is the present status of MHCA in Maharashtra state. See, the law became act by Government of India in April 2017. And in Maharashtra, the State Mental Health Authority was formed in 2018. And now today we are in 2022. So you can understand how the speed of implementation is going on. The draft rules for Maharashtra State Mental Health Authority were submitted to Government of India in February 2020. So that is after the SMHA was formed in 18. It took 2 years to just form draft rules. And there were suggestions made for relaxation of qualifications of clinical psychologists, PSW, and psychiatrists. We'll come to that later, why they asked for these relaxations. Government of India replied that the relaxation was not acceptable. This was done by letter on 24/7/2020. Now, SMHA again requested for reconsideration of it during the meeting held on 19/10/2020. It was decided to get from NIMANS and MHRBs were decided to be formed. This happened in October 2020. Government of India again declined the relaxation proposal on January 2021. Now, actually, I joined SMHA in April 21, when one of the person resigned from that body. And so I attended only one meeting of it. That was the last meeting held on 2nd September 21. And in that meeting, it was decided to send the draft rules without relaxation because twice the Government of India had refused to accept that. And during that meeting, all SOPs, MHRB appointments were sent to Government of Maharashtra for approval. As today we learned, it has gone to the Government of India for final approval. The GR has been published about the appointment of MHRB, the review boards, on 28/10/21. But still it is not functioning because they have not actually started working. They don't have established offices and the infrastructure and everything is still remaining. And that is why this particular problem is there. Now, all the members of these review boards are supposed to be trained that at the Indian Law Institute in Pune, and they will sensitize them and the working about review boards. Now, what are the difficulties we are facing? See, you have seen that how slow the process is working. And though the act became the bill became act in 2017 April, even after 5 years, we are still coming to the rules and regulation being formed. All the stakeholders concerned need to be told about the highlights of the new law, because as you have seen in Soumitra Bhattacharya's talk, that this particular law is based on the rights of the mentally ill patient. And it takes a very different paradigm. There is a paradigm shift between the previous law and this law. And you have to view everything from the patient's perspective. And this particular thing is very difficult to digest for many of us who are used to see the things in a very different way, a very authoritative way. And that is why, as the previous speakers said, that there is always a feeling of insecurity when a new thing comes up. And that is why a lot of training needs to be done, a lot of public education has to be done through wide publicity, public education, training of mental health professionals, offices from judiciary, because they are still not aware of the different things in this law, police department, Department of Social Justice and Empowerment, they all need to be trained and told about this. The use of advance directive and nominated representative will take time to start off, because the general public is very, very new to this idea. As you remember, when the insurance people came in the field, and when anybody, any insurance agent approach a person for life insurance, they would say कि मैं तो अभी किधर मरने वाला हूँ, मुझे क्यों चाहिए insurance? So it's something like that attitude is going to happen with the advance directive. If I'm not going to get mad, why should I worry about the advance directive? That is what the question will come into the people's mind. And it happens like that. Nominated representative is not thought of by people. And if you start looking for nominated representative, there may be a lot of areas of conflict, especially in females. If you see, you consider a lady who is recently married, who will become the nominated representative, whether the parent of that lady or whether the in-laws of that lady. Whether the husband will be nominated representative or whether the father will be the nominated representative. Sometimes it happens that both of them try to give the burden to the other person and don't want to take the responsibility of treating mental illness. And that is why this particular thing about the representative, they will find it difficult to actually choose somebody as a nominated representative when there are things like that happening. Many times it happens that old people are there and whose children are staying somewhere else, migrated to different places, and nobody wants to take a responsibility of that particular mentally ill patient. And then that is going to be a problem for all of us. There is another thing which I find that is going to be a difficult thing. The law states that a person will be discharged from the mental health establishment only after assuring his follow-up care by mental health professionals. So they say that when you want to discharge a patient from the mental hospital or any private mental health establishment, you need to draw out a aftercare chart, and you need to plan for the discharge, hand it over to the relatives, the caregivers, and then you should give all the information to the new psychiatrist or some mental health professional who will be looking after the patient hereafter, or you do it for yourself. The law also states that no person will be kept in mental health establishment after recovery just because there is no relative to accept him or her. Now, this is a catch-22 situation. For many chronic patients in mental hospitals who do not require active treatment but need some caregiver for their aftercare, we can't discharge them because the law says that you can't discharge without assuring aftercare situation. And if, as I said before, if there are no people in the family who want to accept him and take the responsibility of his or her treatment, how are we going to discharge this patient and what will happen to this patient? There are no trained caregivers in the society in a situation where there are only old, sick, or absent relatives who can look after the patient after the discharge. Under such circumstances, there is an acute need to develop halfway homes, assisted homes, rehabilitation centers, or at least daycare centers. Now, none of these institutions are presently working anywhere. There may be a few like Sign daycare center in Pune, or there may be some long stay patients care homes, things like that, but they are not common. And for patients from mental hospitals, government aided or government managed things, centers are not available anywhere. Now, development of such services is being expected from the Department of Social Justice and Empowerment, because they are supposed to deal with the people who are and who not have anybody to look after, and people with disability who require care. But that particular department is very ill-equipped for handling mentally ill patients, because they do not have any experience about handling these people, creating institutions like halfway homes or assisted homes. In the SOPs which are prepared for mental health services by Government of Maharashtra, this SMHA, in mental health mental health establishments, old age homes, schools, de-addiction centers, a lot of emphasis is given on the psychosocial and psychological therapies, which are expected to be delivered by mental health professionals. But the Act recognizes only following mental health professionals. One is psychiatrists, who are registered qualified psychiatrists, registered with the MMC or Medical Council. Clinical psychologists, which they say should be MPhil or PhD, registered with RCI. And PSWs also with MPhil, and psychiatric nurses. Now, if you look at the scenario, do we really have these people? How many of them are present in the current situation? How many clinical psychologists with MPhil or PhD are there? The suggested ratio of these persons in these particular rules and regulations or the SOPs which are formed is psychiatrist for one psychiatrist for 100 people, 100 patients. One clinical psychologist, one for 200 patients. One psychiatric social worker for 100 and psychiatric nurse for 75. Now, this is grossly inadequate, as I presume. If you want psychosocial interventions to be in place, one clinical psychologist catering to 200 inpatients in a mental health establishment means that he will spend or he can see, if he wants to have a session with a patient for say 15-20 minutes or half an hour, he will see one patient in the whole of a month if he has to cater to 200 patients. Now, this needs to be changed. A large number of professionals with MA in psychology, this is what I was talking about, why the SMHA had written to the central authorities that they need some relaxation in that, because there are no MPhil and PhD people in psychology who can be appointed in mental health establishment as mental health professionals. There are a large number of MA in psychology who have done masters in clinical or counseling subjects, but they do not find any place in the present rules as MHP because they are not registered by RCI as psychologists or clinical psychologists. And now they have no legal status in the present Mental Health Care Act. Now, this is particular thing which needs to be followed up. Now, what they say, when I had approached many people with that, even I had written to the current state mental health authority in detail about it. that this is a large amount of man-force which can be of very good use for us, is left out just because some laws which were passed in the past have called that clinical psychologist must be MPhil or PhD. Now, actually, the RCF, which they say that it is the authority which has decided that the clinical psychology should have this particular qualification. The RCI itself has started another course in which they call assistant clinical psychologist. And in the preamble of that, or the introduction of that particular course, they say that MPhil and PhD are academic kind of streams, and people taking up psychology for MPhil and PhD, they are supposed to be going into the academics or research or things like that. While we require a lot of field workers who can work in the hospitals with the patients, and for that we need some other people who have different kind of training in psychology, training with the patients, clinical training, and that is why they have formed another course. RCS form another course for postgraduate course in assistant clinical psychology. Now that course is available in 12 centers in the whole of India, and none of them is in Maharashtra state. Now this is the pathetic situation. Actually, if we go and see, there are good universities in Maharashtra like SNDT, Mumbai University, Pune University, who have good curriculum, who put their students into internship at different clinical places where they get experience on and hands-on experiences. So they should be allowed to practice as a psychologist, and they should be accepted as mental health professional. Now, this is a particular thing which needs to be followed. This was twice rejected by the central authorities. Though there is in the act, it says that there are rules which state can make themselves about the qualification. But actually, when we ask them, the central authorities say you can't change anything and you have to follow this rule. So some change in the rules is essential to include them as mental health professional. A possible way is to include all those who will be registered as behavioral health professional. Now there is another act which has recently passed, National Commission for Allied and Healthcare Professionals Commission. So there people have to, all paramedical fields are included in this particular law, and where they, instead of calling mental health professional, they have called them as behavioral health professional, and they have categorized them as psychologists. Though they also, again, in that new law, they have said that the clinical psychologists are excluded from this because they are to be covered by RCI. So these are the practical difficulties we will face while applying this new law. Now, this new law states about the discharged patients, and discharged patients also need to be taken care of. And this particular law is not only about the mental health establishments, but it categorically states that this is a Mental Health Care Act, and the care needs to be followed up even after the discharged patients. Now, the major cause of relapse is because of the discontinuation of the treatment. And the major cause of discontinuation is the cost of visiting the nearest psychiatrist. And this is where the telepsychiatry comes in position. And if we can have different set of rules or the guidelines issued for handling patients over telepsychiatry, that can help and achieve a lot more the aftercare of the patient. This is what I had to share with you. I think you can ask any questions later on.
Thank you very much, sir. Thank you for this wonderful session. And definitely these practical difficulties are going to be a major roadblocks in upcoming future. But with the support of government and all our colleagues and our eminent office bearers at SMHA and regional boards, definitely will take care of that. We are sure about. Sir, can you stop your present sharing, sir, so I can?
Yeah.
Now our next eminent psychiatrist for this is young and dynamic Dr. Mahesh Gowda. He is, as we had already, Devdatta has given his CV, read out his CV. I just enumerate the major things that he has been consultant psychiatrist at Spandan, director of Spandan Healthcare, DNB program coordinator at Spandan. His major achievements are that he has set up a rehabilitation center in 2001. He has awarded with DLN Murthy Rao Award for Best Outgoing Student. He is past president of IPS Karnataka branch, editor of IAPP. Almost he has more than 65 publication in index journals and partnering tele Arogya video consultation platform. Welcome, sir. We want to know about, especially we want to know definitely about the importance of record keeping, not only the general and coming the future challenges after the MSCA. Also, the must be record kind of things. Those we should not forget to record, and if to make it easy, use of software. Thank you, sir.
Thank you, Dr. Dhananjay. Actually, I'm continuing from my previous session, so certain things were addressed in that session. But
yes,
for the sake of understanding, I think I have to stress the importance of documentation. If you look at most of the consumer forum issues or the medical legal issues that doctors in general get into, it's because of improper documentation in more than 90% of the cases. And most of them will be related to consenting procedures and documentation. So I think the informed consent becomes the heart and foundation of all the procedures that we're going to do. In outpatient practice, we are actually used to having implied consent and we're not documenting anything. But actually giving long acting, doing ketamine therapy, doing ECT, doing any other procedures in the outpatient practice also will need a documentation of consent. And my previous colleague talked about informed consent and how elaborate it is in research. I think all the parameters that is assessed in research settings for informed consent will be definitely applicable here also. It is a very elaborate procedure and there's no shortcuts to this procedure. It has to be a well documented consent. Preferably at the end of documentation, I think there should be one or two doubts which is particular to whatever the patient or the family member has asked, and their clarifications to their satisfaction, and his voluntarily willingness to do it is very important in section 86. 89 and 90, the NR's consent and his willingness to propose for the consent here is important. We have certification for any involuntary admission that becomes very important, and admission in prescribed formats is very important, and everyday notes has to be carrying the basic minimal records. Whatever is recorded is a patient's right to access your records, so document exactly what you want to document. If you look at issues of child sexual abuse or extramarital relationship and things like that, a lot of confidential issues we keep recording. Once it's recorded or once it's discussed, a lot of legal implication comes on the doctor treating. So documentation cannot be overlooked here. And right from the time of admission till the discharge planning, that becomes very important. And all this data has to be preferably in a e-format and also a hard copy format, because e-Manas may be implemented pan-India. Right now, it was just started as a project for Karnataka, and NIMHANS and IIITB actually coordinate the whole thing. But most states seems to be interested to coordinate this because it's a very simple process for the MHRB to function once they have all the data on the dashboard. For example, I'm a psychiatrist working in two places. So under MHE, there are registrations that apply and there could be admissions. So at the click of a button, the MHRB can actually look at what patients have admitted in what all places, whether it's section 86, 89, 90, everything can be visible. And the status of the patient's ongoing treatment also will be visible. We are all capturing data in our own softwares, which is cloud based or actually local server based, but all this data has to be finally synced in the format that they need. So what I understood from IIITB is we can use any softwares that we want, but they're going to ask us to share certain codes. And once the codes are shared, they're going to map the data that we are capturing into the required fields of the MHMS software or e-manas there. So I think it's going to be a transition. It's going to take a lot of time, but the MHMS wants all the data of people whom we are seeing and treating. So a lot of data of patients is definitely going to be there on the cloud. And the issues that can arise can be numerous. But going forward, all the documentation that happens and is a requirement by law will be there available with the government to look at data, analyze data in a lot more ways, supervise the patient's treatment program and progress, and also to look at treatment fallouts. And actually, if they really want to go into the level of actually getting the patients under follow-up, they can actually generate a system if the patient has actually not followed up with me. So that's a level of data that they can hold on to and actually put it into good use. And if a patient has actually been admitted and actually as a treatment refusal, there can be a system like the way they do in the UK and US, where they have treatment teams which go to the places. It could be a mental health nurse, it could be a psychologist or a social worker who actually will be the case in charge. He can visit and ensure compliance is happening. And a few things from my earlier presenter is what I thought I should take in here. Somehow, IPS or psychiatrist has been looked at a very different angle as far as this new act is being concerned. I've been a part of this MHCA committee there, and I've been the convener there for more than 3 terms. And right from the beginning, IPS is against certain provisions of the act, not that this act in total is not good for the patient's care and well-being. If you look at the role of IPS or the psychiatrist here, it's definitely not undermined simply because right from running a mental health establishment to being the doctor in charge or the in charge of the mental health establishment, it will be a medical practitioner or a psychiatrist till the time he's discharged. If you look at the onus of responsibility it's being given to psychiatrists in discharge planning, it is humongous. I don't think I've signed up for it at all. The day I became a psychiatrist and got trained and got certified to practice psychiatry, I never knew this is the sort of enormous responsibility that's going to come in to a psychiatrist treating. And admission and discharge, I thought that was the end of story. But the continuity of care in the community is what they talk about, and it's very difficult to achieve. And somehow the right-based act and movement has been talked about. A lot of nations have implemented it more than 2 decades ago. But if you look at the data that they have, and if you look at the way forward that they're doing, actually they've gone forward and had community treatment orders or outpatient treatment orders to make sure patients' continuity of treatment is continued. This act cannot overlook this sort of orders because all this data is already available. And having a right-based legislation has led to a lot of treatment refusals, and a lot of criminalization of mental illness has happened. And there's enough data right from Laura's law, Kendra's law, and a lot of states that have implemented the outpatient treatment program have actually looked at all this sort of data and made provisions for treatment. And if you look at roles being undermined, definitely not undermined at all. The legal issues that IPS has got into is not an individual psychiatrist decision. It is an annual general body meeting that actually requested IPS to represent itself, and hence a petition was filed. And none of the psychiatrists have actually talked about withdrawal of this petition at all. It is not disposed, it is not dismissed, it is still there in currency. COVID has actually reduced this sort of hearings there, and the government was slow to respond to all the objections raised by IPS. And I think the best information is available from the Maharashtra state chapter because it's filed in Mumbai High Court, and the legal issue is still on. If you look at the pathway of treatment that the patient gets into, we've actually evolved from being a paternalistic psychiatrist to actually having shared decision making. Now we are ready for having a informed consent and right-based treatment approach. But does it really translate to better treatment outcome is what we have to answer here. And we're definitely not undermined. And the issue here is funding. We've actually had an assessment, and we thought that 94,000 crores is something as a huge requirement for the implementation of this act. And whenever the funding is provided, the budgetary allocation is done, patients are going to benefit, and any MHE or any person involved, insurance being a part of it, definitely is going to change the revenue of a MHE or a psychiatrist. So we are not definitely opposed to having the act in the true spirit is what I thought I should say. And minimal standards they have been talking about in so many ways. Record keeping has been the most important thing here. We cannot falter on that. and having strict minimum regulations will discourage MHEs at a very tribal level or a rural setting, is what I thought I should say. Thank you.
Thank you, sir. Very informative talk. As we are running a little late, so we will just finish up. We get up some couple of questions. So my questions for Dr. Sanjay sir. Is there any format for advance directive? Like one has to mention on the bond paper or notarize it before the informing to the registering with the board. This question was asked by Dr. Atul Dage.
Okay, so actually, I had to look up to that. A few years ago, I had a situation, when this whole idea was pretty new to a patient, a very important one, and who wanted actually to make a advance directive, so to speak. So the general understanding, as we understand, with regards to also documentation, is the basic principle which is enshrined in the any kind of a testamentary procedure, that it could actually be a very plain, simple kind of a documentation. More important part is about the registration part, so it is unimportant, whether it is on a notarized paper or whether it's written in a plain kind of a this one. The will, classical will, as you know, a person kind of writes it down, whether it is kind of registered or not, is considered as a important document, provided there are people, there is a but, provided that there are people who would sort of honor it thereafter. In this case, actually, the registration is required, as I understand, with the MHRBs. Am I right, Mahesh? So to say that basically a registration actually is an important kind of a step in that. And because only if it is registered, then can it be given effect, at the time of the when it is required to be done, because it could be very prospective. It could range from maybe a few months to few years, when the actual use of this advance directive may be required to be made. So it actually implies that we have a registration system and a record system, which is a very sound record system and which makes it available. So effectively, it's something like that, when a patient comes to you for treatment next time, first you have a sort of a warning available whether actually this patient has registered an advance directive. So before you are able to make any treatment decisions, you have to first go through whether there is an advance directive available. That is how actually the mechanism prospectively would operate, isn't it, Mahesh?
Yes, sir. Yes, sir. And actually, since there's no mechanism of registration, it's good to make sure we educate them and actually encourage them to write advance directives. Actually, I've tried this in the last 2 years. They're able to write at the time of discharge planning and things like we talk about advance directives and help them to nominate a certain representative, and they're able to write it down. This copy can remain with the family member or the NR that he nominates to get it registered at appropriate time, sir. But this framework can be implemented. And if you look at a common man who is otherwise sound and having all capacity, number of people making wills itself is less than 5% of the general population. So we are talking about a special population here.
Exactly.
Sir,
exactly. But so basically, I see that some of these provisions in any law, it is not compulsory, that the entire population must do that. It is it's like a facility for the people available, those who want to avail.
It's
That's
optional.
why even during kind of my presentation time, I made example of people going for eye donation, people donating their bodies, and now people actually going in for even cadaveric kind of transplant situation donations. So these kind of procedures at one point of time, it's only over a period of time that people have got to know of it. And today we know that a lot of people actually going for eye donation, organ donation, all these activities, voluntarily they do it. So it is also possibly a maturation of a society, more people becoming aware. So it's a process, something which rolls over slowly. So we shouldn't read it that if the act mentions it that it is compulsory for everyone to do it. It is just a facility provided, that should someone want to do it, they have the legal backing to do so.
Dr. Sanjay, I think it also can be nice if patients say that, I want to be treated as inpatient only under Dr. Sanjay's inpatient facility on that can possibly happen.
Exactly, because that is what I
patient.
see. That is what I looked at actually the formats of the when I was required to do it few years ago. That was the time when I looked at actually the formats available on the internet about the advanced directives. From some of the developed nations where this is a common practice. And that is what I saw, that what are the elements that you can mention, actually the doctor, the hospital, the type of treatments, so you could write a fairly detailed one also if one would want to, that
Yes,
this person.
and if it's mentioned Dr. Sanjay's name, I have no business.
Exclusive name.
Or you could exclude yourself also from the process, that next time you want a treatment, you please situate, that it's not me, you have a better person than me available. So next time it could be Mahesh, instead of Sanjay.
Thank you, sir. Thank you, sir. The next question goes to Mr. Amrish, sir. Sir, in the chat box, you mentioned that the NR definition is not clear and also AD definition is inadequate. Why do you feel like this, sir? And secondly, second question is, what if NR refuses to take responsibility or was unable to take decision because maybe he or she has been to the overseas or died or bedridden? So at that time, what is the procedure?
See, NR can withdraw at any stage. Whenever he wants to not to be an NR, they can do that. And under advanced directive, there can be more than one NR also. You can, 1, 2, 3, in that order you can give their names. And advanced directive, of course, is optional. It is not compulsory. And when format is there for advanced directive, and when we say that they can say that what kind of treatment they want, where do they want this treatment. So other important question is who is going to finance it. See, if they say they want treatment in Jupiter Hospital only, and I as a family cannot afford that kind of treatment, I can refuse to agree to that kind of treatment. So the form, I think there is a provision that how the bills will be settled. So that is an important component of advanced directive. You can write what you want, what kind of treatment you want, but important thing is how you are going to settle the bills. Do you have, same thing is about nominated representative. Nominated representative, if says that the patient wants treatment of this type or that type, then whether the families can afford, families can refuse to finance any kind of treatment if they are not a part of the decision making. So that has to be taken care of. And the important thing is a psychiatrist cannot be forced to give the treatment as provided in the advanced directive. If that is my view, that if a patient says that I don't want DCT, I don't want clozapine, I get side effects, and the psychiatrist, the attending psychiatrist feels that this is a chronic case, only clozapine can help or ECT is required, you can jolly well tell that I will not give you the treatment which you want. I will give you the treatment which professionally I think is the right treatment for you. So you can go to any other psychiatrist.
No, sir. I would like to differ here simply because once the AD is valid and ratified by the board or the authority, only the MHRB can overrule his advance directive. I will have to approach them, sir. I cannot overrule his objections here.
No, yes, Mahesh, but MHRB cannot force a psychiatrist to give the treatment which the patient wants. I mean, a psychiatrist has every right to refuse giving treatment. You can go to some other psychiatrist who will agree to it. So MHRB can amend if you represent to MHRB, but as a psychiatrist, do you have the time to make representations to MHRB and get the advance directive modified? So who has that kind of time? So as a professional, I will give the treatment which my own judgment tells me to give it. If you don't want my treatment, you go somewhere else. That right, I think the professional has. Nowhere in the act it is said that this psychiatrist has to give the treatment which the patient wants. So psychiatrist has a right to refuse. What do you say, Dr. Mahesh?
Yes, we have rights to refuse, but if the patient is admitted and we have a valid advance directive, I cannot follow my clinical decision here. I have to follow what the patient's
Yes,
decisions
but
are
you
till it
have
is
a right
overruled.
to refuse attending to this patient, isn't it?
Yes, sir. And there are enough
If you
obstacles
give
to.
treatment, you will give as per MHRV, as per AD. But if you do not agree with that and you think this treatment will not help that patient at all, you can say that no, I cannot give you the treatment as you want.
These are the gray areas, sir. So, for example, I admit
Right.
somebody under section 86 or 89. He may have the capacity intact, but he may refuse to take what decisions I'm making. So again, I'll have to just admit him, wait for MHRB to intervene to rule his decisions against.
If you have that much time that you can make a representation to MHRB, argue with them, present your case, and get the ID modified, yes, welcome. Why not? But I doubt whether a mental health professional will have that much of time or will have that inclination to make representations to MHRB. He has to see other patients. He doesn't have only one patient that he will be doing all these things.
Right, sir.
Yes. Thank you, sir. My next question is to Dr. Shere, sir. The question is from Dr. Jaideep Patil. Sir, if we had already, if we had registered with the regional board, means our main, RHB. So, do we need registered to the local authorities like corporation under Bombay Nursing Home or Clinical Establishment Act?
That was clarified that if you are registered under mental health establishment, you need not register again with them, because if you are registered with other registrations, you just apply to the mental health authorities that you have this registration, and then you need not register again with the mental health authority.
So usually what happens at our corporation level, we have to register because we have to, for the biological waste, we need the POSCO wants that specific registration from the local corporation. So,
yeah, see that registration for biological waste is for the biological waste, and they will need that the hospital is registered under some kind of registration, either the Bombay Nursing Home Act or the Clinical Establishment Act, or so similarly it could be Mental Health Establishment Act.
So, one thing which I wanted to clarify, that the Act does not say for psychiatric nurses. Act provides for mental health nurses, and they have defined that. So we cannot say that because psychiatric nurses are very few, so that problem is there. So that problem is not there as far as nurses are concerned. And as far as clinical psychologists are concerned, you see, we blame RCI that they are so stringent that the number is very few, and people, those who pass out from other institutions do not get registered with RCI. But I say, what is wrong in having stringent standards? RCI says that you follow the status which we are given to you, and institutions like Tata Institute of Social Sciences and all, what is the problem? They can follow that syllabus, and those standards have to be maintained. The clinical psychologists who are passing out from Maharashtra universities and other places, they don't have a basic knowledge. ABCD of mental illness is not known to them. So I think RCI is right in having stringent standards.
No, you should give the curriculum additional inputs.
Oh.
See, when I pleaded about that, what I meant was that we should have this clinical experience given to the students of doing masters, or you have a postgraduate after master's degree, some course.
That is MPhil. MPhil is the course.
Kind of a training.
There is a lot of practical training. And another thing which I think the people attending this CME should know, that now they are also giving a professional course to clinical psychologists. They have introduced a syllabus, and that Bhopal Institute is conducting that program. So in India, we didn't have this concept of paid caregivers. So that concept is now introduced. and qualification is only 10th pass. And I hope we will have a cadre of paid caregivers also.
Thank
Sir,
you, sir.
about registration, I thought I could just clarify one thing here.
Yes.
Since a person with a psychiatric illness may not have only primary psychological issues, he can have multiple medical comorbidities also, sir. We end up admitting patients treating with diabetes, hypertension, sometimes residual stroke and things like that. So we do a lot of liaising. So if you're actually thinking of dealing with patients with these sort of populations, it's good to get them registered under Private Medical Establishment Act, because it's a larger umbrella. The standards are not different. Get it registered under Private Medical Establishment Act and then supply the copy to our Mental Health Care Act implementation, sir. That would be the best way forward. Otherwise, again, gray areas will be there. If I'm authorized only to treat people with Axis 1 psychiatric issues and I end up treating with other comorbidities, I may be in a legal tank.
Thank you, Mahesh, sir. This is that's why we kept the last session on the consultant liaison in the view of MSCA. Sir, this is question for you, sir. Mahesh, sir.
Yeah.
So from Dr. Devrat Harshe. Sir, what the platform like? What is your opinion about the platform like Pacto or other private organizations? Because it's usually that our appointment get channelized through that their app, and most of the information of ours and personal information of patient is available with that. Is it wise to use those apps?
Actually, for a beginner who does not have a lot of patient load, enrolling these sort of platforms have given them the push for them to get some quick patients and get some consultation from them. But on a long run, actually, not leaving a lot of data on this sort of platforms becomes important. If you're actually entering even drugs that you're prescribing onto the prescription portal, again, it's an issue. It should be just a PDF or a scanned copy. And try and maintain your own electronic records at your own servers. Don't put a lot of data on clouds, and this can be put to a lot of privacy and breach issues. Using this sort of platform is double-edged. It can help patients, but sometimes soliciting patients this way can be a legal tangle with medical counsel and advertising issues, because even simple putting the photo may not be okay. It amounts to advertising. And patients that are enrolled from them also can give and write feedbacks, which can be so many times counterproductive, make a psychiatrist of good repute and standing meaningless in the social media. And these sort of platforms can definitely capture a lot of data. So any platform which captures this sort of unnecessary data is not required, is what I think. We should just use an appointment system helping to get patients and not leave a lot of data.
Yes, Deva.
Just to carry this question forward, there are also some software which are not on any platform per se. These are actually software companies. They have developed their software which is cloud based. They have Amazon servers, and they are not like Bajaj or Practo or nothing. They are just a software company which is developing an EMR software which has a cloud based storage. So what about that? Because there I'm not, or there a psychiatrist is not using any other third party provider like Practo or say Sehat or something, but data is on the Amazon servers. So because storage space and all these things are going to be really hassle for everyone. So what is the advice on that?
So if you
Not
look
the
at
third party, but only cloud based. Yeah.
If you look at the liability that I will get into as a psychiatrist, is very minimal, simply because any person who's giving this sort of solution has his own liability, because he has to follow certain protocols and be up to a standards to give this sort of confidentiality and prevent breach on the data. So I will definitely be indemnified, because patient agreed to sign up and allow us to capture the data. Probably that should be there in your consenting process, that your data would be maintained by a third party provider. You will be easily able to absolve yourself from any breach that happen here. So we need not be worried about it, but it's good to not leave a lot of data, because most of the worries of patients or doctors is that data and actually been sold to so many people for their own benefit. So these sort of issues can be minimized.
Thank you very much, sir. We are at
Thank
the
you,
end
Dr. Mahesh.
End of the session.
I forgot to talk about those definitions. You see, nominated representatives has not been covered in the definitions at all. And I feel that should have been covered. And advance directive, all that they say advance directive means an advance directive made by a person under section 5. Now, this is no definition. See, that proper definition should have been given. It makes people guessing what exactly advance directive means. That is what I meant about the two definitions.
Okay. So I lastly conclude the session with a remark by Dr. Umesh Nagapurkar saying that how to make this act more psychiatrist friendly will be a challenge. And I request our 3 psychiatrists from this panel to rate this rate this act at present on the basis of psychiatric friendly. Out of 10, sir. Nice, sir.
I think it's 7 on 10.
Okay. Sanjay, sir?
As I said that I would like to have more empirical data, before I rate. So I don't want to be opinion-oriented person. I would rather be driven by data. So.
Okay, Shashwat, sir.
I think I would give it 8.
8. That's great. Any that more than 60% is considered as a first class. Thank you very much. Thank you very much, all the 4 panelists. And thanks to the organizers for giving opportunity to me to moderate this session. Thank you very much.
Thank you, everybody.
Yeah, thank you, Dhananjay sir, and all the panelists. It was very nice interactive session. So we will move to the next session. This is a post-T session. It is about consultation, license psychiatry, and MSCA.
Without tea.
And chairperson and moderator for this session is none other than our teacher, Dr. Henalsha ma'am. She is the professor of psychiatry at Nair Hospital, Mumbai. So over to you, madam, for the further proceeding of the session.
Yeah, thank you. It's been a pleasure to be here. It's been a great day of thinking and introspection and reflection. And I think many doubts has been cleared and many questions have come on the chat. Let's go forward so that I can introduce the next speaker, please. One of our speakers for today's panel is Dr. Nandu Mulmule. He is the president-elect cum vice president of IPS Maharashtra State Branch, studied from Nagpur and from Sion Hospital, Mumbai, received the J.C. Marfatia Gold Medalist from Mumbai University, consultant psychiatrist in Nanded, works a lot on culture. He is presently a columnist for the daily newspaper Lok Satta and conducted 500 plus popular shows on stress management, and I know we all love those. He's published books in Marathi on psychiatry, and his Manacha Gunti is a very, very popular program which people love and enjoy, and his experience in psychiatry is depicted in current TV serials also. So really a man with a lot of input in psychiatry in smaller towns and the rural areas. Our next speaker also is, if you can go ahead, please, is Dr. Sudhir Bhave, a professor, head of psychiatry at NKP Salve Institute of Medical Sciences, Nagpur, topper throughout his academic career with rich experience, worked in many of IPS committees, and currently I was working in one committee, always supporting with bright ideas, winner of awards, and he has been not only a chair of one committee that I was on, but in 5 other committees, published numerous papers. And I also know that he's a prolific singer, and we've had the pleasure because he shares it with us for us to join on. Thank you, Dr. Sudhir Bhave, for being with us. And the next slide, please. We have with us 2 non-psychiatrists who are going to add a lot of value to this session. The last but not the least session, Dr. Avinash Bonwe, who is a practicing family physician in Pune for nearly 40 years. He's a panel consultant as a physician on various hospital boards and activist, and his motto is to increase health literacy on educated people and masses. He's done more than 2,000 speeches and workshops on preventive medicine. He's a writer with humongous work, more than 5,000 articles in almost all Marathi newspapers. So you can imagine the kind of awareness he does and the weekly columns he does. 13 books, 12 in Marathi, 1 in English. Corona Warrior, been awarded for that. Has many awards for his service in medicine. For the books as a writer, has had many positions such as the president of IMA Maharashtra State, been the dean of the IMA College of General Practitioners, president of IMA Pune, of GP Association Pune, and the UNESCO chair of bioethics. Thank you, sir, for taking this afternoon off and being with us, Psychiatry Association, who will definitely benefit from your inputs. Can I have the next slide, please? Dr. Jan'22 is honorary pediatrician at many hospitals in Pune, including the Sassoon Hospital, Bharatiya Samaj Seva Kendra, Dinanath Hospital. He's a visiting faculty at ILS Law College because he's an LLB. He is a past president of IMA Pune, IAP Pediatrics branch of Pune and the Pediatrics branch of Maharashtra, vice chairman medical legal cell, IMA headquarters, and he has helped a humongous number of doctors, more than 2,000 doctors so far. So we know where to turn when we have problems or we are running into issues. But besides all of that, he's a very fit man. He's run 26 half marathons and full marathons, does cycling, has donated blood 65 times. He's the recipient of the Bertha Holt International Award for Rehab, recipient of the Best India Doctor Award by Indian Medical Association, and the chairman of the IMA MS Social Security Scheme, and has got a lifetime award from IMA Pune. Thank you, sir, for being with us and giving your inputs. So if I can now stop sharing the slides and get us four on the spotlight, it will be wonderful. So let me begin with my questions. We've had a lot of discussion. Maybe some of these questions will be repetitions, but since we have two non-psychiatrists also here, it would be nice to get perspectives from people who are outside our own field and have something more to say in that field. I should start with, of course, Dr. Bhave, because the whole thing about general hospital psychiatry being included in this act gave us a big jolt for most of us who work in CUN, because we have been immune to all of this. So now with this coming in, what is your sense? How is it going to affect what are our fears in the general hospital? How is it going to function in the general hospital? So what would you like to say about that, Dr. Bhav?
Yeah, thanks, Anil. I quite agree with you that since the GSPUs came under MHCA 17, I think there has been a lot of apprehension. Now we know that MHCA 17 defines mental health in a particular manner, and now there is no differentiation between a government hospital, a corporate hospital, or a general hospital psychiatry unit as far as inpatient admissions are concerned. Now, some of the difficulties that are being foreseen are the procedural difficulties. I particularly see two difficulties in two areas largely. One is a large amount of documentation that would be required. Like, for example, take admission under any section, say admission say under section 89, the supported admission. Now, it begins right from proving that the patient does not have the capacity to decide about his own treatment, taking written applications from the NR, then if within 7 days, if it's a male, within 3 days, if it's a female or a minor, informing the mental health review board about this. And I mean, so much of documentation has to be done. If it's section 89, every 7 days, you have to assess the capacity. If it's the restraint of the patient, every month you have to send all the data to the review board. So I think this kind of documentation work is something which is going to be procedural burden on psychiatrists or their juniors who are taking care of the patients. And secondly, one big area of difficulty that I foresee is the frequent communication that will be required to do with the mental health review board. Like at n number of steps, communication has to be sent to them, their reply awaited. Now we don't know how efficiently and how early would we keep on getting replies from them. So I think all these things will come in the way of what is best for the patient. Like pre-MHCA days, if we had a particular idea about managing a particular patient in a particular way, now this is something where we cannot take intuitively correct decisions, but we have to look at the legality of it all and then decide further. And then, of course, there are areas where MHCA 17 is silent when it comes to general hospital. Like, for example, I get a call from surgery ward that a post-op patient is getting delirious and I start the treatment. Now, after 72 hours, am I entitled to continue treating him or advise his transfer to a mental health establishment? The Act is silent on that. So I think there are certain areas where the Act is silent when it comes to especially liaison secretary, since the theme is liaison secretary. And at these times, I think we have to take repose to maybe what the Constitution says, or maybe what is in the best interest of the patient, whatever the law can permit, and so on. So I think these are the largely the major apprehensions or the issues that I foresee.
Thank you, sir. And I'll come back to you, but I'll just go ahead to Dr. Mulmale, sir. So you work in a very different area, in a more of a rural and a town area of practice. And I think the kind of practice that goes on over there has a lot of implicit consent and trust that is there. Now, we've heard whole morning about documentation and things like that. Also that in the rural areas, there are a lot of smaller nursing homes that are there. And now with documentation, registration, consent, advance directives, and audits, all these things coming up, how do you foresee this happening, especially when we know that most laws, when they trickle down to the rural areas, are not enforced as well? You know, people kind of take it easy. So how do you foresee, sir, what your practice is and how it will affect people, and what do you see the way out of all of this?
Thank you, Dr. Shah. I'll make two general statements about the discussion I've been hearing the whole day, and one special observation on what Dr. Bhave said. One overall opinion, thinking in our setup was that what I thought of MHCA is that MHCA is like pandemic. Whether you like it or not, you have to accept it that it has come to stay here and it's going to be endemic. So one thing, it is there. Now you have to accept it. Second observation is that what I have been taking a stand about psychiatry as practiced in India is that we have basically a Western psychiatrist trying to treat an Eastern patient. The topic which have been after for last few years, Western psychiatry and Eastern patient. And this is represented in MHCA. How? It's a very simple thing. We have an internal rift also, as you said, that I practice in a semi-urban, semi-rural area. We have an India and Bharat rift. There is a India in metro cities and there is a Bharat. There I practice, where laws being implemented are nothing more than a sort of a, I won't call it a joke, but then it comes down to same thing. I stay in Nanded. There are signals at every corner which government has put up, the traffic police has put up. Most of the signals are not followed. People travel through the road, look at the red lights, green lights. Amusingly, if somebody has OCPD, he might stop after seeing a red light, but it's not compulsory. Even the police standing in a corner is busy eating his tobacco, chewing his tobacco, so he's not bothered much whether somebody follows the rule or not. So, but that's not new to India, because we have got an Anti-Dowry Act, we have got a age of a specific age at which marriage is legal. We have these laws. You don't bother to follow it. That's no problem in India. So similarly with MHCA, I feel it has come to stay. Second thing is that it may not be implemented even at governmental level, leave alone people, leave alone psychiatrists practicing specifically in areas like me. MHRB, it could be a utopian dream. Setting up of insurance coverage to patients, it could be a dream. But we should always look at the positive aspects. As you said, what about documentation? Then AD and NR and these things are still far-fetched. But I feel one good thing, and we should always look at the good points about MHCA. One good thing is that it will at least set up a start towards documentation. Now, documentation is not possible in our areas where sometimes psychiatrist has to cater 100 patients a day. But then now, at least there is a realization. There is a signal which shows a red light. Some person might start stopping at the after seeing the red light. Then the start will be made. It may not be implemented totally, but a start will be made. So it is very difficult for documentation. You can't send back the patient because you have to cater to all the patients which attend your OPD. Sometimes I have seen 140, 50 patients a day in some time in the past. It could be difficult, but at least you could document some of them. That is a very important thing about this thing. One more observation I wanted to make when Dr. Bhave was speaking was that, see the contrast, a patient reaching general hospital psychiatry unit, whether it's a teaching hospital or not, that's a different thing. Patient reaching there with, say, some sort of physical ailment, physician admits him, starts treatment. There is no PHCA, there is MHCA, but there is no Physical Health Care Act. The physician doesn't have to bother about that. But there is a MHCA where mental health care itself is so at such a preliminary level. So that's a big contrast which I see here, big contradiction. And implementing it is going to take a lot of time. We have to get used to it, but in a specific setup like where I practice, I think being aware itself is one step. Implementing it is going to take a lot of time, but at least there will be one step taken towards some preliminary form of documentation. That's what I feel.
Thank you, Mulmule, and we can see wisdom speaks. I think change is always very difficult, and especially when it is imposed onto us, then we are making it. And change takes time, so I guess the time will tell. But sir, some people have told us you're being like ostriches, putting your head in the sand, and it will take time and we will wait for it. So I guess time will tell us how to move it. But the best part is that everyone will make one step ahead and go ahead and try and do things to get into the groove of things. I'll come back to you, sir, but now may I go ahead to Dr. Avinash. Sir, you've been working with general physicians and, are really into the groove of things there. I'm just wondering, what is the role of general physicians in the diagnosis, treatment, and management under Mental Health Care Act? Sir, you're muted. Sir, you're muted.
Yeah. Thank you, Dr. Hena Shah. First of all, I thank the Indian Psychiatric Society, West Zone, and Indian Psychiatric Society, Maharashtra State, for inviting us on this very august gathering of all the eminent psychiatrists. As you all know, I will be talking about the role of family physician as far as the psychiatric care is concerned. The family physician is very much important in the management of these psychiatric illnesses. He's the first point of contact. He is rather a listening person during the treatment. And of course, is very important as far as the follow-up is concerned, so as to continue the treatment of the patient in a proper way. And of course, is very much important in a relapse case. But the situation is that all the family physicians are not well trained or not well aware of the many facts academically as well as practically about the diagnosis, treatment modalities, and they're not updated as far as the psychiatric treatment is concerned. Most of the time, we have found that many patients who come with the psychiatric illnesses, but they are either underdiagnosed, or sometimes the patients with psychosomatic conditions are given more importance. As far as the treatment of a family physician is concerned, in his clinic, he gives very less time to the patients for the communication, because as you all know, he gives at the most 2 or 3 minutes per patient, and it is very, very difficult, because the main thing in psychiatric diagnosis is to listen to the patient carefully and make notes and do the other thing, because psychiatry is the most important clinical branch. We do not have many surgeries or procedures or investigations. So the clinical history taking and making all the derivations after that is very, very important. Many of the doctors are not giving much time for the communication. And the most important thing that I'm sure that most of our family physicians and primary healthcare workers are not aware about the law of MHCA 2017 and its implications. I've been listening to all the discussions, and I really felt that it is rather many things we have just heard about, but most of the things we are not aware. As well as the medical practitioners are concerned in this law, which I know that the medical practitioners are the part of this treatment, but in this there are specific categories that not only the MBBS doctors or the modern medicine doctors, but also the Ayush doctors are also given the chance. They are also included in the treatment as medical practitioners. As far as we know, that most of the family practice is rather taken up by the Ayush doctors. There are very few modern medicine doctors, and these Ayush doctors are absolutely not rather trained or not oriented for this MHCRA or any of the diagnosis and the treatment modalities of the psychiatric management. And what I feel that we need a lot of grooming for all the family physicians for all these activities as far as the diagnosing and treating the patients, and about the many details about the MHCA as far as the treatment part is concerned, and we may get involved, and we definitely will be helpful. But as far as the knowledge of a family physician is concerned, we definitely treat the primary cases like anxiety or the depression or some other illnesses, but many of the morbid conditions are quite away from our circle, from our knowledge, and for that we take help of the psychiatrists. Most of the time these cases are definitely referred to a nearby or for the eminent psychiatrist. But for that you have to diagnose that, you have to at least make some provisional diagnosis for all these things. So what I will like to request this August gathering and this Indian Psychiatric Society, that recently I've been elected as a Dean of Family, Dean of IMA College of General Practitioners, which takes care of all the academic activities and the courses of the general practitioners all over India. So with the help of Indian Psychiatric Society, we can have these type of courses. We can make aware all the modern medicine doctors about how to treat, how to manage, and how to take, how to be rather, how what are the implications of the MHCA as far as this psychiatric treatment is concerned. So there are a lot of things about the communication, about sending the patient, about referring the patient or the admitting the patient. We still have many patients when the relatives take that person that we want to admit such and such patient, but we are totally unaware in a new scenario how this can be done. So all these protocols and everything should be clear to all the doctors. So that is my request, and Definitely, thank you very much for giving me to present this side of the situation. Thank you.
Thank you, Dr. Avinash. It's really useful, and I'll come back to you. But I think two important things that for us as psychiatrists, we can mute the others, please. As psychiatrists, what we really have to realize is that we have to work with our colleagues who really, I know we are struggling with understanding MHCA, but whatever understanding we have to spread the awareness. And sir has offered, that you can work with him and the general practitioners. That's one beautiful thing. And also, I think what he said is that people are not aware about psychiatry much. And therefore, our aim to increase the psychiatry understanding in undergraduates should be supported, I hope, by IMA, GPs and things like that. And we'll come back to you to think about that, whether you feel the training of psychiatrists in a training of MBBS for psychiatry should increase. So I'll come back separately and talk about that also at a later date. Thank you for that. Now I'm going ahead to Dr. Jan'. Sir, as a lawyer, so we have seen so many times when there is violence against mental health professionals. And with the law, people are worried, we are going to be more defensive. We are going to ask for paperwork and documentation. There were times when we gave, surreptitious medicine and all those kind of things were there. These are, what do you think? I think.
Hello, sir.
Dr. Bharat,
Hello.
you to put yourself on mute, sir. Yeah. Thank you, sir. So I'm just wondering, what is the advice you would give us as psychiatrists to protect ourselves and also to yet maintain a good doctor-patient relationship?
Thank you, madam. Thank you, madam, for a nice introduction to begin with. And number two, I thank the organizers for giving us this opportunity to interact with you. We are not experts in psychiatry. We are not experts in this incoming law. And so far, it has not been applied to Maharashtra state in toto. That's my understanding. So we should be better prepared. So before I go to your specific question about violence, I would like to have one comment on what has been interpreted so far and what the panelists have been saying, that these are the difficulties in law and how it will be implemented, and these are only the guidelines, something like that. Here I would like to say that there are two acts which come in front of my eyes. One is PCPNDT. This sonography, everything has to be registered, everything has to be online. So you see the compliances are exactly the same way as what is being mentioned in this MH Act, because it has to be done in 3 days, 7 days, everything has to be online, it has to be sent to the appropriate authorities. And every nook and corner of this town and village in this state are doing that now. It took about 6 to 8 months, but then if the law is really implemented strictly and with the spirit, it can be done even at the remote places. And more than that, I'm very familiar with this adoption process. I'm working in this field from my postgraduate days in 1976. So from that time, I've seen the change, and in 2015, everything became online. And there were so many exactly similar way wording, everything is there. This authority, state authority, CARA, central authority, and you have to do compliances in 3 days, 96 hours, 7 days, extension of 1 month. So these orphanages are spread all across the country, from places like Shillong, Meghalaya, and all those things. So there is a complete compliance now. So whatever started on the 17th of July 2015 has been fully functional from 2018 December. So it can be done. So only thing I know, the difficulties for the psychiatrist, 100 plus patients, you will have to appoint extra people. The person or the people who are handling hundreds of patients will afford one extra person to take care of this. So that is one thing. So compliances can be done if these are meant to be done. This is my comment, unexpected and unnecessary comment from my side, but this can be done. As far as your point regarding, I'm sorry, can you just read?
Yeah, violence and Dr.
Yeah, violence. This is a major social problem. It's a definitely major problem. Luckily for us, against the psychiatrists, so far, at least in our area, we have seen violences against all specialties, but not so much about psychiatrists, but there are n number of consumer cases. And there are problems of threatening. So violence can be, of course, psychological violence, emotional violence, and it can be physical violence and against the property. So violence can be prevented only by better communication. That is number one. And number two, we have to have unity amongst the members of your profession practicing in that era, in that area, not necessarily psychiatrists. So what we have done in Pune, there are 12 police districts in the city of Pune. So accordingly, we have created WhatsApp groups, what we call as rush teams, and that has worked fantastic. So violence can occur anywhere. Once we keep a group of over 25 doctors, at least 10 will reach the scene. If the doctor gives a warning signal that this is the thing which is anticipated, call the police, that is one, and call the rush team. The rush team usually reaches much before the police come, but once they see the crowd of 10, it works. As far as this violence is concerned, this epidemic act, what central government has made a change, that there are strictest punishments against violence. And what we have put the case in Bombay High Court, where we expect the final hearing to be there on this Friday, coming Friday, that we have pleaded that the changes made in the epidemic act against the violence should be there, whether there is a violence during epidemic, pandemic, or whether it is at a particular clinic. In a non-pandemic situation, there is no difference. Violence is violence, and same rule should apply. So that is what we ask for: better communication, better interpersonal relationship, and rush teams. These are the urgent things to be done in each and every town, city, and village. That is my opinion.
Thank you, sir. And that was, though that was not the question I asked, but those are pearls of wisdom. You are telling us, and very rightly so, that there are other equally strict laws which got applied within a few months to within a year. So we cannot take a backseat and say it will take a few years and never be applied. I guess we have to start preparing, and therefore this CME like today is the first thing which gets us sensitized, and we should go with the mindset that it is going to be applied, and let's get ready and get as much as we can done and ready before we are, pulled up or faulted for doing it. Thank you very much. So I'm coming back to you, Dr. Bhave. So we work with so many other specialities and so many pathies, and under MHCA, how will this work really when we are working like this? I mean, how is it going to go ahead? So you're muted, sir.
I think when we practitioners of modern medicine, we read MSCA, I think there are several questions that come to mind about other pathies, like all those Ayush pathies. First of all, a puzzle for me was, is there a specialty of psychiatry in Siddha medicine or Unani medicine? I'm sure means many of our colleagues were not even aware that such specialty exists. A second rather arrogant, I might call it arrogant doubt was that are they really proficient in treating mental illnesses? They may be, may not be. I'm not very sure. But then subsequently, as MSc gets implemented, I am seeing two kinds of difficulties. There could be more. One is the communication gap that might arise between us and the practitioners of other pathies. Like, for example, a patient getting transferred from one mental health establishment run by, say, a Unani practitioner or Ayurvedic practitioner to, say, my establishment, Section 93. It allows for that kind of transfer. Now, with this, there would be a sudden shift in the treatment that is being followed at the two places. And we know that changing treatment abruptly, because what he's prescribing, I just would not have any idea. I would not know whether how efficient those medicines are likely to be. I cannot prescribe them. So the sudden change in medication that would happen is one major difficulty that I'm seeing. And second, of course, communication difficulty. Like if I send the patient to another psychiatrist, it's too easy to say that he's a patient of paranoid schizophrenia and I'm not able to keep him, so kindly take care of him or whatever. But when a similar patient comes from some other pathy to me and he describes the diagnosis in his or her own nomenclature, now that is something where I would find it quite difficult to really communicate with that. The second point you talked of was other specialties in modern medicine. Now that again is an issue. Like for example, say take emergency treatment clause. Now under emergency treatment, the patient can be kept only for 72 hours and subsequently you can't really treat him. But then we know legal experts say that Article 21 of Constitution allows you to, go over MSCA and take care of the life and liberty of the patient. if need arises. Now, I think we need to educate other specialists about proper documentation. Like if there is a patient of schizophrenia with, say, a significant physical morbidity being treated by a physician as an indoor patient, then maybe I need to educate him that at the end of 72 hours, since I'm also seeing him, kindly note down in your papers that the patient requires continued admission in medicine because he has got this so and so life-threatening condition or serious medical condition and so on. So I think a better communication with the other specialists, maybe educating them on aspects of MSCA that are likely to affect us. I think that would be the order of the day subsequently.
Thank you, sir. I think there are two parts about this. Crosspathy is because, again, like MHA is new and it's telling us to open our doors, and we are not sure whether we can open our minds also. So it is a tough one for all of us, and I guess we have to work through it. And the second part really is, I think it's like a double-edged sword. We can use MHC as a way to communicate to many more people about mental illnesses, whether it is general practitioners or specialists, but it also can be that it can increase stigma. So how we use it and how effective we are in our communication is up to us and our associations. So I think we should pick up that challenge and open the doors to other specialists and general practitioners, at least of modern medicine, so that everybody is able to work towards MHCA, at least in modern medicine. So coming back to Dr. Mulmule, so you've heard that we have done this very often, even in all hospitals, that, patient doesn't always come, the relative comes, and we give medicines for a year, for a month, or we, if the patient's relative comes and said it's very acute, we have given surreptitious medicine. Now with the law, I mean, I don't know if it was right before also, but with this law, which is looking larger than life right now and looming down on us, these things are not really acceptable. So how do we really work through, because our patients really trust us, and patients' relative come with great amount of trust on us to find a solution for a very difficult position. So how do we negotiate it? I mean, it's simple to say, go to the police or magistrate and all those kind of things, but how do you foresee that unfolding in places like Nanded, where the trust is even very, very high as compared to Mumbai, where there are so many doctors and you're one of the many, and there is only one Dr. Mulmule who will be there in Nanded who's trusted so much. Sir, you're muted, sir. Sir, you're muted, sir.
Now, is it okay?
Yes, sir. Yes.
I can hear. So I am not alone. There are now new coming psychiatrists in this area. Nanded is not such a far remote dreaded place as you are picturing. No, it's not. It's a biggish town with 5 lakh population. What I'm trying to say is that what I was thinking, a couplet came to my mind. समझ सके तो समझ जिंदगी की उलझन को, सवाल उतने नहीं है जवाब जितने हैं, which means that there are few very pertinent questions which MHCA is asking us, and we have to give multiple answers. You can consider that when there are many answers to a question, you can safely consider that there is no answer to such a question. सवाल उतने नहीं है जवाब जितने हैं. We have to give multiple answers. I was thinking in my mind that last 40 years I have written PNB on my prescription paper almost 50% of the times. In other words, 50% of the patients who come to me don't come to me, relatives come. The answer is very simple. They are poor. And I tell them that if your patient is okay, then bringing him all the way from 60, 70, 100 kilometers, paying the bus fare, he can purchase 1 month's medicine out of that bus fare. When if the patient is coming to me and I am asking him just a few cursory questions, सब ठीक है, नींद भी आ रही है, अब आता बड़बड़ वगैरह तो काही नाही ना, अब ठीक आहे, गोया चालू ठेवा. For these two sentences, asking to spend a chunk of money which can purchase him 1 month's medicine is out of question for me. whether they'll be MSc or not. I'm not going to do that. It is not practical. Second thing, as you said, faith is a most important card played, not only in place like Nanded, everywhere, in fact. In fact, why medicine and why medical healthcare? Faith plays a place in banking. There's a person who says that my collection sometimes of the shop is in, say, lakhs. I can't go and stay there till the cashier counts all the money. So for last 40 years, I am attached to that bank. Cashier knows me personally. I keep the cash there. I come back. I tell him that if there is any shortage in cash, you let me know. I believe him. Faith works in all walks of life. It works more so in healthcare, in all pathies, more so in mental health. We are trying to do the best, give the best of the service in the interest of the patient. This is the underlying thing. Now, law says, the MHCA specifically says, surreptitious medicine. It says advanced directives. So what about surreptitious medicines? I have to give treatment to patients without their consent. I have to give treatment to patients who don't reach me, can't reach me. So I think some deliberation needs to go into these clauses, and we need to sort out this problem at the at the IPS level, or at whatever negotiating table. I don't know. I'm not part of it. I think this is a very big gap between the drafting of the law and the ground reality. They are divorced by miles apart. The people who have drafted it, they have done it with the best interest of the rights of the person with mental illness. That's okay. But then even the best of the interest of the person with mental illness is also giving him medicine, sometimes against his will, or against his consent, or against his knowledge. This is also part of the right of the mental person. See, I don't understand. Before drafting the MHCA, there no psychiatrist who was in practice who must have put forth this point that having mental illness means 50% of the people are not going to have insight into their illness. In yesteryears, 30, 40 years, not long back, 30, 40 years ago, we classified psychiatric illness into neurotics and psychotics. And the base was very simple. People who don't have reality testing intact, people who didn't have insight were psychotics. Psychotics were brought, those who were brought to the psychiatrist are psychotics, and those who come on themselves are neurotics. And I believe that in principle, in the soul of the psychiatry, the rift remains the same. Psychotics are people who have lost insight, who have who don't have reality testing intact. That is why they are mentally ill people. So how can you think of consent and not giving surreptitious medicines? There is a patient with me who comes for last 40 years. Stealthily she comes to me. She takes the medicine. I give her medicine for 6 months. Patient is her father. She was a small child when that person's wife used to come to me. Now the daughter comes to me. He is a very well balanced professor in some college, doing very well, doesn't know that he is being given one small tablet every day at night, but the family is able to survive, and family is able to do well in their life just because the person is given medicine against his knowledge, but for his best of his interest, and he is doing well on his occupational level, getting salary, and the family has pulled on for last 40 years. There is a thing about addiction, alcohol de-addiction. We have to give disulfiram against the patient. Who, you tell me who is, we don't get patients coming to us saying that we want to stop alcohol. Every time alcoholic family member comes to us, this is a common experience, whether it is a metro city or a mega city or a small city. Addictives don't want to stop addictions. We have to give them, even I give disulfiram without their consent. I have survived for last 40 years without any litigation. Now, this is a discussion which hits the soul of MHCA. I can't pull on this discussion more, but I will emphasize on this. Even this is in the right of the interest of the patient against his consent to give medicine. I don't foresee any practical solution out of what MHCA sees and says and what the ground reality is, the requirement of the ground reality.
Thank you, Dr. Mulmul. And I'm sure many people who are listening are saying, yeah, we agree with you, sir. But the law says it differently, and we'll have to find a meeting ground on how we implement it and how we move ahead. So while we struggle with all these things, I'm coming back to you, sir, Dr. Avinash, that, again, there is a lot of stigma for psychiatry, and I know that even general practitioners hesitate to send to psychiatrists at times for various reasons that are there. And with MHCA, do you foresee the stigma increasing? How do you suggest that we kind of work towards decreasing the stigma and being able to work towards MHCA?
Yeah, definitely. Whenever a patient, rather, we feel that he has some psychiatric problem and has to be referred to a psychiatrist, or may need admission if he's violent or giving trouble. So that time we have to convince the patient's relative. And as you all know, it's definitely the chances are always 50%. The patient's relative may get convinced or not. But the main fact, what I perceived from this act, that the patient should be ready to continue treatment, or patient should be should accept to take the treatment. So is it like that? The patient's acceptance is important. So that is why the main important thing is there. And most of the time, what I have found, and most of us will definitely agree, that in our society, the things are now decreasing, but in our society, the patients who are having this psychiatric problems, they are taken to the babas and all those this thing first, and after that, when they become the things go beyond their capacity, then only they are brought to the family doctor, and they are asked about where to admit or where to send it. So there is definitely a stigma that even for the simple conditions, say maybe anxiety or the simple depression, or maybe some psychosomatic condition, if we ask them to go to a psychiatrist, the patient definitely asks, I've gone mad or something like that. So that stigma, we have to convince the patient that it is not the case. That is the first thing. And secondly, about this Mental Health Care Act, the people absolutely are not aware. The common persons or people are not aware, and it is maybe a fortunate thing, because this law considers more in from part of the patients and the relative, and less as far as the doctors convenience is concerned. So this is definitely what I find, that the patient definitely have some stigma for taking a psychiatric treatment, for getting admitted to the patient, and they may take advantage of this Mental Health Care Act.
Thank you, sir, for that. So again, another opening for us to work with our colleagues and to help in destigmatizing, and also in registration of hospitals. And, IMA can take a lead in helping people to get registered, so that that itself will decrease stigma, because, when you are registered, you're accepting and you're opening your arms to all mental health patients also. So we would expect and hope, sir, that you would push for that.
Sure.
Yeah, thank you, sir. So now coming to Dr. Jayant, sir, legally, insurance has said that, insurance is now supposed to cover mental health also. But the ground reality doesn't translate into all of that. So as your legal opinion and outside the field, of course, we all have had our discussions about it, but you being a legal person and not a psychiatrist, how would you advise us as to go ahead to see that the rights are met? Because this is an important right. Even it is for, one thing is as suicide, and if you have suicide, committed suicide, then, you don't get your life insurance. And the second part is that if it is physical illness, it's covered easily, but mental illness is supposed to be covered, but there are many issues. So how, as a lawyer and a non-psychiatrist, would you advise us to go ahead with all of this?
No, madam, the one-line answer would be a very strong lobby. A very strong lobby in the central government and with the IRDA, the Insurance Regulatory Authority. But they are the toughest people. And you just mentioned that you get easy coverage for physical. Answer is no, it is not so easy. Even over there, they're obstructing even minor claims. When this happened to me with a fractured hip. 25 years I've been paying my personal medical insurance, and they created several objects. I had to literally give them a legal threat, and then I got my money back. So anyway, mental health is not covered at this moment. So we need a very strong lobby. If this law is coming up, it must be with the assistance from the Health Ministry, Family and Welfare Ministry. So we should be lobbying over there. The same way, I think Dr. Mulbule was absolutely right. I would compliment him about finding out these difficulties in implementing these laws, because 50% of the times it's not possible to convince that person and take a consent and all those things. And then later on it becomes all right, it is possible. But till then, initial thing would be, so what my suggestion to IPS, particularly Maharashtra state, would be that Maharashtra specific mental health act is yet to come. So here is the time window where you can make certain changes which are more practical and more appropriate when you treat these patients, because these difficulties are better understood by psychiatrists rather. And of course, we will help you. IMA will help you. So we can go together, and Maharashtra specific mental health act can come, which may be followed by other states. So these things, for example, clinical establishment act. Several changes have been suggested and accepted by the ministry. So same way, IPS Maharashtra state West zone, they can definitely take help of people like Dr. Mulmule, who are quite experienced, and they can find out the real difficulties in 50% of cases. And that's why these changes can be brought in as Maharashtra specific mental health act.
Thank you, sir. That is a ray of hope. But as Dr. Shere was just telling us, that the whole process is really slow, and they have been trying to make changes. And even to get from a RCI approved clinical psychologist to MA clinical psychologist is a battle that is ongoing. I guess we will have to stand united and, work towards what is actually applicable and usable eventually in the future, in the best interest of the whole community and especially our patients. If I yet have time, Bhalchandra, can I go on, or do we have some more time to discuss?
Yeah, 5 minutes more.
All right. So then I'll also look at the chat and look at some questions, but maybe I can just ask a question that I saw somewhere, is that, do general hospitals also have to, are they, government hospitals and things like that, they're not really covered under Hospital Act, so they don't have to register there. So how does it work with their registration? What happens to them, and how will they be registered? Do they have to register as an MHCA? How does it generally work?
Do I answer?
Yes, sir, for you.
So, as I understand from the MSCA gives a blanket definition of mental health establishment. It does not distinguish between government setup or non-governmental setup. So, as per the definitions of the MSCA, I presume that every single hospital, whether it's the mental hospital or a psychiatry department of a medical college or a private psychiatric nursing home, all of them would come under the ambit of mental health establishment, and they need to get registered with the state mental health authority. Yeah.
Yes, sir. So coming, one more question that was there is that if the family cannot afford what the advance directive is, As a lawyer, Dr. Jayant, and who's a pediatrician, not a psychiatrist, very often we've been told that you should give an advance directive. And in this advance directive, if the nominated representative cannot afford, so legally, where do we stand with such kind of things, sir?
I think in the law itself, there are adequate provisions that the facility should be given in the same district as far as possible by the government establishments. If that particular district doesn't have it, to the neighboring districts, and then ultimately the state can decide, the state board can decide to go as per the advance directive in the free facility provided by the government.
All right, sir. Dr.
It may be a bit hypothetical, but that is what is mentioned in MH Act.
So a lot of it looks hypothetical. I think till we start using it and implementing it, it yet is a little bit in the air, sir. But I think once we start implementing, it will become clearer, and we will figure out how to tweak it and how to work towards it. Dr. Avinash, also I was just wondering about, there is a lot of places where general practitioners can actually be part of a HCA. You are saying that we should, educate the general physicians and things like that. But do you think there is an interest in this? This is a question that I'm asking. What is your sense as a president? How interested would general practitioners be in being part of the mental illness, certifying admissions and things like that?
Definitely. As far as our modern medicine doctors are concerned, not only the family physicians, but even the specialists and super specialists are definitely interested in knowing about the basics and details of the various mental diseases or the psychiatric diseases. And secondly, about the Mental Health Care Act, people know about it, and definitely as all these acts which are coming, everybody should know about it. So we'll definitely be interested, and I'm sure that all of the doctors, not only the family physicians, but all of the doctors from modern medicine will be interested in knowing the details of the psychiatric management as well as the Mental Health Care Act.
Thank you, sir.
Madam, and secondly, a lot of interest has been aroused in all doctors, all allopathic doctors in particular, particularly the young generation committing suicide. So much stress, so much screen time, and particularly with this pandemic, so many mental problems have come up. So these seminars and these things are very well attended these days. And previously, when we were students, it was a neglected subject. Today, it is a subject in offing. So I think people will definitely come and attend these update courses.
Thank you.
And the society has become more open towards these problems.
Yeah.
Thank you, sir.
As
Yes,
Dr. Naurange sir conducts so many seminars, and from the state of Maharashtra, we have been conducting the medico-legal information webinars every week, which continued for 2 years. So we are sure that the doctors are definitely interested in knowing all the details.
Thank you, sir. So, Dr. Sudeep Rao, the last question really. There is, in USA, they have compulsory treatment orders, because the state says that when you discharge a patient, you have to make some provision for treatment. And because we know that in psychiatry, one of the biggest problems is that they don't continue treatment and they relapse. So they're like New York State or others have, you have compulsory treatment, and therefore, treatment has to continue. And there are options on how to do that. That is something that is not mentioned at all in our act. And I guess if that was there, then all our worry about patients not following up, not coming, what are the ways out would be solved. So do you envisage that maybe we should make representations for things like that, not only for us in general hospitals, but even Dr. Mulmule and all other private practitioners? So there is a win-win situation, both for us to, when we are discharging the patient and worried what will happen, and for the patient's relatives, that there is a way of them, because there is a law which says that treatment is compulsory. They will have to find a way how to get it and where to get it.
Helen, if I recall correctly, it's section 98 that while discharging the patient, the psychiatrist is supposed to look into the post-discharge care of the patient,
Yes.
the possibilities in the community, educate the family about what possibilities do exist. I mean, our role ends there. I mean, we do not have to go out and ensure whether it's really being followed, but we discharge a patient only after looking at the possibilities of further treatment and once the family has been educated. So that has been mentioned in section 89. But it does not go beyond that, as you rightly said, as in USA. Like in USA, if the patient is suicidal and lost to follow up, then it's your responsibility to trace the patient and go all out and see where the patient is it in the treatment or not. So MSCA doesn't go to those lengths in ensuring follow-up.
So what I was trying to say is actually that if the law insisted that there should be treatment after discharge, instead of just leaving it education, then there is a chance that the follow-up and the relapse rate can be less. And then there is a way, as Dr. Mulmule said, how to yet treat. And maybe we can, think of ways on how to get treatment done on follow-up. And we can think of options there. So I think those kind of suggestions that can come, and maybe in our Maharashtra laws where we follow up, where we can have, compulsory treatment options with ways of how to implement some of the things that are already ground practice. So that is for Dr. Shere to think about and to implement and get to the table.
I think
works on it.
The law clearly states that you have to hand over the responsibility to some mental health professional of that patient, and that mental health professional is supposed to carry out it. Of course, there is nothing there to say that it is being enforced or not, and to check it out. There are ways and means which we should develop, and I have done is the telepsychiatry follow up, and then I find that I did a study for 1 year where I had 1,000 calls, and I could find that 80% of the calls could be managed, or the patient's complaints could be managed on phone itself. So that saved about, I calculated the amount from where they came and things like that. We saved about 25 to 40 lakhs of rupees in 1 year. So that is a huge sum for a rural population. So that is how we should develop such kind of things in the future.
Thank you, sir. So with this, first of all, I thank Dr. Balchandra, Dr. Mulmule, Dr. Dalaya, Dr. Bhushan Mhatre, and all the organizers for getting all of us here and giving a day full of so many interesting topics and really thoughts to ponder upon. And I really thank my panelists for giving so many ideas. And I think what we have really learned from this, especially this session, is that though that one, of course, there is a divide between what is practice and what is expected, and that's how life is. And slowly we will bridge those things, and maybe we can use the Maharashtra laws to help us to do that if possible. But we also have other friends who will help us, like the IMA and the general practitioners, and we really need to increase awareness, destigmatize psychiatry, get them on board so that we can move ahead with the law and better treatment of our patients. So with this, I hand it back to them. Thank you from, again, all of us, to the organizers, for having us over here. Thank you.
Yeah, thank you very much, madam. It was really wonderful interactive sessions. I thank all the panelists and Dr. Hinaisha madam for being with us. So we will move to the next session, that is a take-home message and the summary. So I request Dr. Kumawat sir to be on the screen and say a few words about the whole session. This is really a marathon session from 10 a.m. to now it's almost 6 p.m. in the evening. So I request Dr. Kumar sir to take the charge.
So you're muted.
Kumar sir, yeah.
So really, as you rightly said, Dr. Balchandra, that it was a marathon session. We had people who have scripted the act. We had people who had done a lot of advocacy in the act. We had policy makers from the government of India. We had administrators and executive officers from government of Maharashtra. We had people who have been initiated in implementing this act in their states. We had a lot of members of the mental health authorities from Karnataka and Maharashtra here, and we had stakeholders in form of all the mental health professionals. And there were multiple questions which were asked, multiple topics were covered, right from the genesis of the act to the various bodies and how we cope up with them, how we communicate with them, the issues about the patients and their rights, the confidentiality of data, communicating various things to the various executive bodies, and then, of course, the sensitive issue of lies and psychiatry. So everything was discussed from top to bottom of implementation of this act, and it was actually active participation of all delegates and interactive session that encouraged our panelists, I must say, and that created a lot of questions. And I have a couple of questions and people who have asked this question to just name few and give awards for the same. He is Dr. Nagapurkar from Nasik, Dr. Amar Shinde from Pune, Dr. Nitin Pandey from Nagpur, Dr. Prasanna Khatawkar from Western Maharashtra, Dr. Omkar Mate from Navi Mumbai, and Dr. Omkar Joshi from Shirdi. So congratulations to all. I thank all the moderators and panelists who were so important in today's discussion, because the moderators set the ball rolling and that they went it so well that it encouraged our panelists to come up with a lot of doubts cleared in mind of all the viewers. And with this, I hand over to Dr. Bhushan for giving us what is the take-home message for the day. Dr. Bhushan Mehta.
Yeah, so
It's echoing.
So we are running behind the schedule. So we started at 10 a.m. and we had excellent deliberations and interactions from all the esteemed speakers. So in inauguration, Dr. Taide informed about the status of implementation of our act, and she also asked for partnership of IPS in the training of healthcare professionals. In the session one was about philosophy behind MHCA, and where Dr. Soumitra Pathare, he highlighted about how India became signatory and India did ratification to the United Nations rights of person with disability, and how the paradigm shift happened from the medical model of disability to social model of disability. After that, we heard from Dr. Kaustubh Jog. He had done overview of MHCA 2017. He talked about capacity assessment. He talked about nominated representative advanced directive. He also talked about mental health review board and its functions. Then we had a very interesting session of case-based discussion on MHCA by Dr. Manik Bise and Dr. Suresh Badamat, where we had cases like IT employee coming alone with suicidal attempt, where the ECT on emergency basis, right to confidentiality, and what to inform to insurance agencies were discussed. We had second case where plight of family members was discussed when there is violence at home, when patient is not taking medications. We have a third number case where minor with catatonia was discussed, and how it was difficult to treat that patient when we have nominated representative who is not helping the patient. We had case 4 where consultation liaison psychiatry was highlighted, where physician managing the alcohol withdrawal was discussed. Then we had case 5 where de-addiction center and the management of addiction cases in the de-addiction center and need to register them as mental health establishment was discussed. Then Dr. Suresh Badamat gave certain lecture on the certain errors which are commonly done while filling the form, and he has highlighted certain prohibited procedures like ECT in minor psychosurgery and restraints without informing mental health review board. Then we had session 3 on which was chaired by Dr. Vihang Vahia, where we had Dr. Nimesh Desai, who was the first to implement MSCA in Delhi, and he gave the idea of implementation and how it is successfully implemented in Delhi. Then we had Dr. Rajesh Sagar, who is member of CMHA, and he explained about role of Central Mental Health Authority. Then we had different scenarios for Dr. Sanjay Kumar, like ketamine and ECT, depot and oral preparations are given in OPD, and cross-pathy de-addiction centers. So this was happened in the session 3. Then we had session 4 on advanced directive documentation softwares, where we had speakers like Dr. Mahesh Gowda, Dr. Kelkar, Dr. Ashish Deshpande, and Dr. Alka Subramaniam. Dr. Ashish Deshpande spoke on rehabilitation, de-addiction centers, and how MSCA is globally looked like the global perspective on substance use disorder, whether to include it in MSCA or whether to exclude from MSCA. And there are certain countries which are excluding substance use disorder from MSCA. Dr. Alka Subramaniam, she spoke about child cases, and she spoke about the need to link and coordination and defining specific roles between State Mental Health Authority, Juvenile Justice Board, and child welfare committees. Then Dr. Kerkar explained about the minimum patients or maximum patients per psychiatrist. One psychiatrist can see how many patients. Then Dr. Mahesh Gowda, he was talking about documentation, why it is important, and he was talking about how his hospital software was synced with e-Manas software of Karnataka state, and what information to share to insurance authority. We need not share everything to insurance authority, but what is important, we need to share. Then we had session 5, where which was moderated by Dr. Dhananjay Asturkar, where we had speakers Dr. Amrut Bakshi, who spoke about a journey of MSCA 2017 from UNCRPD, and he covered up to the attitude of psychiatrists and other professionals and even caregivers. He also highlighted that there were no definitions of nominated representative or advanced directive. Then Dr. Sanjay Phadke, he spoke about his perception and biases, and he explained the need to see more data on the explanatory model rather than personal opinions. Dr. Shere, he presented present status of implementation of MSCA, shortfall of qualified mental health professionals like psychologists and psychiatric social workers. Dr. Gowda also highlighted the importance of record keeping. Then we had last session, which was chaired by and moderated by Dr. Henal Shah, where Dr. Nandu Mulmale, he spoke about importance of faith and the good intention when we do certain things. Then Dr. Sudhir Bhave, he talked about the documentation difficulties at general hospital psychiatry units. He also highlighted difficulties in communication between the other pathies and other specialties when the terminologies explaining psychiatric illnesses are different. We had heard Dr. Avinash Bhondwe, who highlighted role of family physician as a first contact, and he also highlighted the need to create awareness about MSCA 2017 among GPs and other Ayush doctors. Then we had heard about adoption law from Dr. Jayan Naurange. So he told, he gave example that how it became fully functional within short period of time, And he also talked about violence against medical fraternity. He also talked about the need for strong lobbying with Insurance Regulatory and Development Authority of India for the patients patients with mental illnesses, so that they will get the insurance. So, and with this we concluded. So this was the summary of whole day CME. Now I will hand over to Dr. Bhalchandra.
Yeah, thank you, Bhushan. It was nice summary and take-home message. Now I request Dr. Bharat Sarode sir, Senior Psychiatrist from Pune, President of SMART, to give the vote of thanks.
Thank you. First of all, I really congratulate the organizer. This CME jointly held by IMA, PPA, Pune Psychiatric Association, SMART, IPS West Zone, IPS Pune branch, with the help of INTAS. I first off thank to our Honorable Minister Dr. Rajesh Tope, who consented for attendance, but due to his busy schedule, he couldn't, but he had blessings for our conference. I really very thankful to our Director, Health Services, Maharashtra State, Dr. Sadhna Tade, Madam. I am very thankful to Dr. Gautam Shah, President SARC, Dr. Yanan Raju, current IPS President, Dr. Arun Marawali, Sir, IPS West Zone Branch Secretary, Dr. Kumawat, Sir, our Deputy Director, very good friend and very motivational figure about all these MSCA. Then Dr. Nitin Dalaya, President IPS Maharashtra Branch, Dr. Dhananjay Asturkar, Secretary IPS West Zone, Dr. Bhalchandra Kalmek, host of this conference, as well as our dear friend, Secretary Maharashtra State IPS Branch, Dr. Bharat Watwani, Sir, Dr. Saumitra Pathare and Dr. Kaustubh Jog, who delivered the good lecture and put their views how this act came. Dr. Suresh Badamat and Dr. Manik Bhise again conducted very good sessions about various clinical cases. Dr. Vihang Vaiya, who moderated the session, along with Dr. Nimesh Desai, Sir, Sanjay Kumar, Sir, Dr. H. Chandrasekharan and Dr. Rajesh Sagar. Very good sessions, and I am very thankful for them. Then Dr. Asturkar, who moderated the session, who participated, Mr. Amrit Bakshi, Sir, Dr. Mahesh Gowda, Dr. Sanjay Phadke, Dr. Shashwat Chere, Sir. I am very thankful to all these panelists to discuss various issues with their experience. Again, another session which was moderated by Devrat Harshe and participated by Dr. Deepak Kelkar, Dr. Ashish Deshpande, Sir, Dr. Alka Subramanian, Madam, Dr. Mahesh Gowda, and given their experience and input on various subjects. And lastly, the last session, which is moderated by Dr. Henry Shah, Madam, and participated by Dr. Nandu Mulmule, Sir, Dr. Sudhir Bhave, Sir, Dr. Avinash Dhonde, Sir, Dr. Jayant Naurange, Sir. And I really congratulate and thankful to our host, Dr. Bhalchandra Kalmek and Bhushan Maitre, who taken a lion's part to organize this giant marathon CME. And last but not the least, our the pharma partners, INTAS, and Mr. Bipin Rai and Mr. Jain, who have helped a lot to organize this CME and to become this CME successful. I thank all the participants, all the panelists, all the lecturers, and those who have directly or indirectly helped to organize this CME on behalf of SMART and IPS West Zone Branch, IPS Pune Branch, as well as IPS Maharashtra Branch. I thank you very much. Over to Bhalchandra.
Yeah, thank you, sir. So we are coming to the end of this CME. Before that, there are two important announcements. That is, feedback form is compulsory for the MMC point. So we have already sent the link for feedback form. Kindly fill it and send it back. And this all CME, whole day CME will be available on YouTube soon. So we will also share the YouTube link with you. So this was a wonderful manthan of various views, suggestions, concerns, and recommendations. Now, friends, it is time to implement all these things for the MSCA. So all these will be thought of and taken into consideration for the second edition that is we are publishing in near future. That is the book of MSCA 2017 Together We Can. So all this will be documented in printed form also. So thank you once again all. I thank all panelists, speakers, all the moderators, especially for the guidance of Dr. Kumar sir and his free hand to give us all the facilities he have provided. Thank you once again and good evening to all. Have a nice day. So admin, you can stop the sharing, stop the recording.
So thank you very much.
Yeah, thank you. Bye.
Bye. Thank you. Good day.
Good day.
Bye bye. All good day.
Bye. Bye.
Admin, you can stop the recording.
यस सर, मैं बोलता हूँ उनको करने के लिए.
Yes, yes. Yeah, thank you, Kumar sir. Once again.
Thank you, sir. Thank you very much.
Thank you, Bipin.
Yeah, thank you, Vipin.
Prabhat.
Thank you,
Bipin,
Jan
Prabhat.
sir.
Thank you, sir. Thanks for giving us this opportunity. We'll always
Yeah,
be there
पूरा
for.
अच्छा हुआ CME uninterrupted हुआ.
Yes,
कुछ
sir.
technical problem नहीं आया. It was well organized, arranged.
Really, very good. Very good.
Bhushan sir, thank you.
Yes, yes.
Bhushan, well done.
Yes, thank you. Thank you, everyone.
Okay. So, okay, bye.
Bye.
Bye. Bye, everyone.
Have a nice Sunday evening. Okay, bye.
Bye. Bye. Bye.
Sir, I request everyone to please exit to leave so that we can stop recording.